Seocon is formed by an association that's known as SEO, which is a group of passionate otolaryngologists who are inclined towards endoscopic ENT surgeries. This academic program covers a wide range of novel and exciting topics of clinical relevance in endoscopic ear surgeries, nose surgeries, and throat surgeries, as well as innovations which will be delivered by our distinguished faculties. So we are privileged to have with us three international faculties, that's Professor Daniele Marchioni, sir, Professor Prepageran, sir, and Professor Prof Gadre, sir. So none of them requires any special introduction. Professor Daniele Marchioni is the pioneer of endoscopic single-handed ear surgery from Italy. Professor Prof Gadre, sir, he's a renowned otologist from Danville, who's a staunch believer of microscopic ear surgery, but he's absolutely open to all the new techniques and innovations. We have with us Professor Prepageran, sir, who's a renowned anterior and retroskull-based surgeon from Malaysia. And the next one is our own Professor Dr. Mubarak Khan, who's the pioneer of two-handed endoscopic ENT surgeries with many patents and innovations to his credit. This conference will be having a feast of academic activities which will not only involve the cadaveric dissections, that is the microscopic by Professor Gadre, but also the endoscopic dissection by Professor Daniele. Along with that, we promise to give you the best of live surgeries in endoscopic ENT surgeries by our eminent faculties, also the lectures by the eminent faculties in India as well as abroad. Also, the competitive sessions are an attractive feature of this conference. It's the first ever conference across the globe to unveil and teach the two-handed techniques in endoscopic ENT surgeries plus the goat head dissection. And this is the first time we are having 12 delegates who will be doing the temporal bone dissection over the goat head. And they'll be lucky ones because they'll be getting to operate and use the endoscope holder, that's our endo hold, along with the very crispy endoscopes from Olympus as well as DKC and high-end cameras from Aquino and Olympus. So focus of this conference is not only between single-handed ENT, that is ear surgeries, but also two-handed endoscopic ear surgery, that is SHEES as well as THEES. Along with that, there are some insights about the endoscopic two-handed nose surgery and the throat surgery, also known as ETHANS. So now, other than taking more of your time, I call upon the moderators, Dr. Prakash Kulkarni, sir, and Dr. Sachin Patel, sir, to take over the dais.
Good morning, everybody. Warm welcome to Tayega. So without wasting time, we'll start with the first session, that is lectures. Now, as the moderators for this session, I call upon Dr. Charwas Jagtap from Dhule, Dr. Bharti Mohan, and Dr. Satish Bagewadi from Belgaum. Dr. Charwas Jagtap is an eminent ENT surgeon practicing at Dhule. He has graduated from Bizet Medical College, Pune. He is a certified vestibular specialist, special interest in vertigo. He has a state-of-art vertigo clinic at his own place, Dhule. He has been actively participating in neurotology updates with Dr. Anirban Vishwas. Similarly, he has been instrumental in organizing various conferences and workshops. Dr. Bharti Mohan is a professor at Madras Medical College at Chennai. He is a state nodal officer for prevention of deafness program, and he has done many cochlear implants. Dr. Satish Bagewadi is a professor at the Government Medical College, Belgavi, since 15 years, and he is a dynamic person, dynamic surgeon at Belgavi. So we'll start with the first session. The first lecture is a video topic, 200 temporal bone. Okay, we'll start with endoscopic anatomy of the ear. Dr. Edoardo Serafini. Yeah, over.
It cannot be done. It's done. You can do it from here. This is the next one. So we'll go next.
Good morning. We don't have much time. I try to give you the most important concepts about the endoscopic anatomy of middle ear. At first, during our experience, we discovered which are the most important options and most important advantages of endoscopic ear exploration of middle ear. And there are mainly three: a better exploration of traditional difficult areas such as protympanum, epitympanum, especially anterior epitympanum, retrotympanum, round and oval windows, the evaluation of middle ear ventilation routes, and the optic magnification of the structures of middle ear. So after elevation of tympanometal flap, the first thing that we see is the mesotympanum. Most importantly, the mesotympanum is directly connected to the retrotympanum, the hypotympanum, the protympanum, and these structures are directly ventilated from the Eustachian tube. So there is a direct route of ventilation. Starting from the retrotympanum, which is one of the most interesting areas that we explored with the endoscopy, we see that it's divided in two main parts: the superior retrotympanum and the posterior retrotympanum. The subiculum is these structures here. The subiculum divides the superior retrotympanum from the inferior retrotympanum. So these are some images of the retrotympanum. As you can see, the retrotympanum here is divided from the subiculum in the superior part and posterior part. In the superior part, we see this part here, which is the ponticulus. The ponticulus is a bony ridge which has different shapes because it can be complete or it can have a ridge shape. And the ponticulus divides the sinus tympani here, which is a very important part, as we'll see later, the posterior tympanum, and then there is the lateral part of the retrotympanum, superior retrotympanum, which is made by the facial recess that you all know what it is, and then the lateral sinus here. So we have here this part here that is the pyramidal eminence, which is the center of the retrotympanum, with the ponticulus. The ponticulus goes from the promontory to the pyramidal eminence and has to divide the medial part of the superior retrotympanum in these two parts, the sinus tympani and posterior sinus in the upper part. So in the lateral part, we have the facial recess laterally and then the lateral sinus inferiorly. Then we have this part here, which is this bony ridge structure, which is the subiculum. And the subiculum divides the superior retrotympanum from the inferior retrotympanum, and the inferior retrotympanum is mainly composed by the sinus subtympanicus here. These are some images on the surgical specimen. Actually, as you can see here, we have the pyramidal eminence. So this is the retrotympanum here, the pyramidal eminence. This is the ponticulus. And then inferior to the ponticulus, medially to the facial nerve, there is the sinus tympani. Most importantly, the endoscope, you can always use not only a 0-degree endoscope, but you can also use some angled endoscope as the 45 angle endoscope or a 70 angle endoscope, which allows you to study in a deeper way this structure. In this image here, as you can see, we used a 45-degree endoscope, which allowed us to study and to explore the retrotympanum, the superior retrotympanum, in a much deeper and interesting way. Here you can see we have the pyramidal eminence, and most importantly here, as you can see, this is the ponticulus, this is the pyramidal eminence, and you can see that the pyramidal eminence is not always complete. Sometimes there is a space just behind the pyramidal eminence here, which is a very important space that you have to, when you have a cholesteatoma, you have to explore this area here in order to see if there are some cholesteatoma residuals. This image is on a cadaver specimen, and it's very interesting. As you can see, the ponticulus here, this is the ponticulus, this is the pyramidal eminence, second tract of facial nerve, the third tract of facial nerve, and then here you can see the sinus tympani. Most important, as I told you before, we have different classification of the sinus tympani, as we see during our on cadaver dissections. We have three main conformation of the sinus tympani. The first one is a type A, which is a kind of conformation where the sinus tympani is not so deep, so it's very easy to explore with an endoscope and with an angled endoscope through a transcanal endoscopic approach. Type B actually is a much deeper, more deeper sinus tympani, with the limit is the posterior part of the third tract of facial nerve, which is has a deeper conformation, which actually is still achievable exploration with an angled endoscope. And then we have a type C sinus tympani, which has a very deep conformation, which is much behind the third tract of the facial nerve, and actually is very, very difficult to explore, to completely explore with an endoscope, and sometimes require a microscopic approach. Then the inferior retrotympano, we have to cite two main structures in the inferior retrotympano. Inferior retrotympano is mainly divided from the superior retrotympano by the subiculum, which is this bony ridge here, going from the posterior pillar of the round window to here, this structure here, which is the styloid eminence. Then we have the second structure, which divides the inferior retrotympano from the other parts of the middle ear, the tympanic cavity, is the funiculus. Why we call it funiculus? Because it's like the end of the retrotympanum. In between the structure here, subiculum and funiculus, funiculus goes from the anterior pillar of the round window to the tympanic bone. We have two main structures. The first one is the fustis here. The fustis is like a finger-shaped structure, which has two main different conformations, as we will see. And then there is this, we have actually the round window niche, obviously. And then we have this structure here, which is the subcochlear canaliculus. Why it's most important to identify these two structures? In these images, we can see the fustis, the round window, and then we have the subcochlear canaliculus here, the ponticulus, and the subiculum. It's very important because, as you can see, fustis, round window, and subcochlear canaliculus can have a different conformation, different anatomical conformation, and this is very important actually when you have to study radiologically and you have to program your surgical operation. Why? Subcochlear canaliculus has three main different anatomical variations. The first one is the most common, is type A. Type A means that the subcochlear canaliculus is very, very well pneumatized, meaning that the subcochlear canaliculus goes from the tympanic cavity to the apex, to the petrous apex. This is most important, for example, when you have some benign pathologies as the cholesterol granuloma, as you can see, sometimes only require the drainage of the capsule, of the material inside the capsule. So when you have a small cholesterol granuloma in the petrous apex and you have a well pneumatized subcochlear canaliculus, you can also try to perform a transcanal endoscopic subcochlear approach in order to achieve, to reach the cholesterol granuloma and to create a ventilation route of the capsule of the cholesterol granuloma. Type B actually is less well pneumatized subcochlear canaliculus. Type C is a very low pneumatized subcochlear canaliculus. So it's always important, depending on the pathology you are trying to remove, study also this kind of anatomy. Then the fustis. We have two main different variations of the fustis. As you can see, this one is type A, which is the most common. Type A is a big fustis, which has a finger shape, indicates you the region of the round window niche. The type B fustis actually is less frequent, and type B fustis actually does not indicate you the round window niche, but it's like the floor of the scala tympani of the basal zone of the cochlea. These are very important, for example, when you have to perform endoscopic assisted cochlear implantation. So it's important because if you see the fustis, sometimes, most of the time, the fustis indicates you how to drill the basal zone of the cochlea, how to insert the electrode. So it's like a very good and very good guide for this kind of surgery. Then you have the epitympanum. Epitympanum is very interesting for different reasons. Actually, because at first, speaking about the ventilation, epitympanum is not directly ventilated for the Eustachian tube, but when epitympanum have an indirect ventilation from the mesotympanum through a part through two different areas. The epitympanum can be divided in two parts. The lower unit, which is the Prusak space, and the upper unit, The lower unit is indirectly ventilated from the von Trosch pouch, as you can see here, because we have the posterior malleolar fold, then we have the tympanic membrane laterally, and between this structure there is this von Trosch pouch where the Prusak space is ventilated. The upper unit actually is ventilated to the tympanic isthmus, and we can see the tympanic isthmus is actually the only part through which can be the only part through which the episuperior epitympanum, the upper unit, can be ventilated through the mesotympanum, is made by only these two areas here, because the rest of the connection with the mesotympanum is limited by the epitympanic diaphragma. The epitympanic diaphragma is created by some ligaments, which are the anterior malleolar ligaments, the lateral malleolar fold, posterior incudal ligaments, and by two complete folds. It can be the incudomalleolar fold, the lateral fold here laterally, and anteriorly the tension tympani fold. Actually, most importantly, tension tympani has always different conformation. It can be complete, or it can be horizontal oriented, it can be vertical oriented. So we have different conformation, and depending of the conformation of this fold here, you can have a well-chromatized anterior epitympanic space, you can have a well-chromatized supratuber recess, or sometimes it is incomplete. So you have an additional route of ventilation to the from the protympanum to the epitympanum. And it's most important because studying this ventilation route, we also had a clinical and pathological correlation, which is the selective epitympanic ventilation syndrome. Actually, the selective epitympanic ventilation syndrome is a syndrome where the Eustachian tube correctly ventilates, so the mesotympanum, protympanum, retrotympanum correctly ventilates, but there is a problem at the level of the tympanic isthmus. So the ventilation problem is only at the level of the epitympanum. So in these cases, you will see a retraction pocket at the level of the epitympanum, and most importantly, you can access the tympanic cavity through an endoscopic approach, open the tympanic isthmus, and you will see that you will restore the correct ventilation of this unit. This is a quite interesting image. You can see after removal of the malleus, you can see here the tensor fold in this part here, and you can see the tensor fold here is incomplete. This meaning that the Eustachian tube here gives a direct ventilation from the protympanum to the upper unit through this additional ventilation route. Here there are some images, the Prusak space here. This is the lateral malleolar fold, which is actually the roof of the Prusak space, and divide the Prusak space or inferior unit from the upper unit. Here we have removed the lateral malleolar fold, so we connected the Prusak space with the upper unit, with the epitympanic space. Here we made a wide acticotomy. Here in this part here, there was the incudomalleolar lateral fold, the part of the epitympanic diaphragma. And then here, after a wide acticotomy, we can see all the structure of the epitympanum. The tegment tympani with the middle cranial fossa dura, lateral semicircular canal, and the second tract here of the facial nerve. Facial nerve, lateral semicircular canal. So after removing the bones on the medial part of the epitympanum, we can see some important structure after removals of the ossicular chain. Here, this is the cochlear reform process. It's very important during surgery because it's actually a very affordable point during surgery to guide your surgical operation. From the cochlear reform process, we have the tendon of the tensor tympani muscle, and just above the cochlear reform process, it's very important because the cochlear reform process guides you to the presence of the geniculate ganglion. Just above the cochleariform process, you will see the geniculate ganglion, which is divided in a precochleariform part here, which is the line on the posterior aspect of the cochleariform process divides the geniculate ganglion in the precochleariform part and postcochleariform part, the facial nerve. Then we have the second part of the facial nerve, the third part of the facial nerve with the pyramidal eminence and the tendon of the muscle, the stapedial muscle. Here you have the stapes with the superstructure of the stapes. Here you can see some images of these very beautiful drawings. In these images, you can see also this structure here, the cog. The cog is a bony crest from the epitympanic roof going to the cochleariform, going to the geniculate ganglion. And the cog is very important because also in this case, there are some anatomical variation because it can be more or less represented by dividing the epitympanum in an anterior part and a posterior part. So sometimes when the cog is very well formed, and you have, for example, tensor fold, which is very vertical orientated, the anterior epitympanum can be very small and can be also very difficult to explore. Then the hypotympanum, as you always know, is the inferior part of the tympanic cavity, and it's the part which is in front of the funiculus in the inferior part of the tympanic cavity. And the most important structure that you can see in the hypotympanum is the jugular bulb. Jugular bulb, which can be less or more procident. Here in this image, you cannot see very well the jugular bulb, but then in this image here, you can see a very well prominent jugular bulb, which sometimes is very difficult. You have always to explore to see in CT scans, which is the prominence of the jugular bulb, because in this image here, as you can see, it does not allow you to explore the round window. So it's very important to know which is the correct anatomy of these structures. Finally, the protympanum. The protympanum is the anterior part of the tympanic cavity. It's the most important structure that you can find in the protympanum are the carotid artery with the vertical portion, and then the Eustachian tube here. So Eustachian tube, the carotid artery, and just above the Eustachian tube, as you know, there is the tensor tympani muscle with the fold that we cited before. And then most importantly, the anatomy of the tensor tympani fold gives us some information of first the ventilation routes to the epitympanum, because sometimes when it is incomplete, you have an additional ventilation route from the protympanum to the epitympanum, and also the conformation, as you can see here in this area. The tensor tympani fold is complete, but it has a more vertical orientated conformation. So we have this part here, which is called the supratubal recess, because it is in a supratubal region. Supratubal recess, which is quite large, but you have always to know that the epitympanic space in this set, the anterior epitympanic space in this setting here is very less well pneumatized. So it's very important to know that the anatomical variation of a part of a region of the tympanic cavity means that another part of the tympanic cavity has other alteration, other conformation, which are very important during your surgical operation. Thank you for attention.
Thank you very much, Dr. Serafini. As a token of appreciation, I invite Dr. Charwas Jagtap. Please wait. I invite Dr. Charwas Jagtap to hand over the memento as a token of appreciation.
Sir.
And the certificate also. Just 1 minute. Yeah. And now I invite Dr. Neil Patel, two-handed temporal bone goat head dissection. Please proceed. Yeah.
Okay. Good morning, everyone. I'm Dr. Neil Patel. I'm currently associated with Dr. Khan, sir, at Sushruti ENT Hospital and Dr. Khan's Research Center. Well, my topic is endoscopic two-handed goat head dissection. It's only middle ear dissection. This is our basic setup. We have a endoscope which is hold on the proprietary endo hold, and you can see a temp hold, which is a square box like thing where you can easily fit the whole of the goat head. It is made for everything. Even temporal bones can be easily attached, wet or dry. It has specific two flanges on both the sides, which can hold the instruments as set up here. The trolley is also designed by us. It has specific slots, one after the other, for holding the light source and the camera systems. And there are also exhaust for the irrigation, and also the irrigation channel, which is a copper tube. This is the endo hold, basically. It has a clamp on the front side, where you can hold the endoscope. So we start with harvesting the cartilage. On the goat head, well, there are huge ears, so you can get so much of the cartilage, but the technique is same as the tragal cartilage harvesting. You can see very well. The cartilage is harvested, and the tragal perichondrium can be very well separated. For the goat head, the whole of the ear has to be chopped off, as its EAC is very narrow, external auditory canal. The cartilage and the soft tissue is removed, and you can very well see the cartilage here. Okay, so we're removing the skin of the external auditory canal, and further more cartilage can be harvested. The thickness varies according to the part of the ear, the external ear, which you are harvesting. This has to be totally removed in the goat head dissection, because the canal is very narrow and the endoscope cannot fit inside with the instruments. So now we can see the bony cartilage, the bony junction, and we'll be soon seeing how to fix the endoscope there. Yes, so now this is the whole bony canal which is coming up. It is still narrow, still you cannot easily do the whole of the dissection here. So this is prepping the canal. Now you can put the incisions and raise the TM flap as a normal one, but still we'll need some of the canaloplasty. Scope is yet a little bit far away from it. To get a better view, you can do the digital zoom, which is available in every camera system. Well, now we can very well see the middle ear. Yes, this is our bent flag knife, which we use. 12 to 6 o'clock incisions are very easy to make from the normal instruments, but we need bent instruments to raise the 360-degree flap with a 270-degree incision. So we raise it from both the sides. Only the TM flap is attached anterior superiorly. Now we are entering the middle ear, as you see the spaces. So now a little bit of soft tissue has to be removed, and now we can very well see the incus. Well, according to the goat middle ear, they have a huge incus and a short malleus. The malleus is also there, but it is horizontally placed, and it will come up. But the first structure which you see is incus. Well, this is our auto shield, which we fix on the normal handpiece, and you can fix the burr here. This basically changes your handpiece to a distally rotating burr. It has an irrigation channel and a suction channel built in, or you can irrigate it by your assistant also. So now we start the canaloplasty. Aluminum foil is kept to prevent the flap from getting injured. Well, in the endo hold, once you are fixed, all you need is a little bit zoom, which can be done digitally, or you can do the Rack-Pinion mechanism and do and physically take your endoscope inside the canal and outside the canal. So as we see, the canal is getting widened. And the flap is perfectly preserved. All right, now we need to remove this whole bone, because this is like this bone, it will always hinder you. So either you have to do canaloplasty or you have to flush it out with the canal, with the bone of the mastoid. Well, for dissection in the goat, all you need to do is not irrigate as much as we do in the temporal bone. You can do a little bit of canaloplasty, then just flush out the dust of the bone, and it will be easy. The goat middle ear has a huge hypotympanum and no mastoid, basically. So it is a perfect example for doing an endoscopic surgery. This is the middle ear view, which we see. Well, this here, as you can very well see, is the short process. It looks more like a long process of the incus, but it is actually a short process. It is longer than the actual long process, which is right here. And this is the IS joint, and this is the malleus, which is more of a horizontally placed. It will be attached even at the handle, at the umbo junction. You can very well see the anterior isthmus, the posterior this is the posterior isthmus, and also the epitympanum area. This is all you can see at this stage by just taking the endoscope inside once you raise the TM flap. You don't need to do any more dissection. All you need is a little bit of canaloplasty and raising the tympanomeatal flap. Then we prepare a cartilage shield graft if we are doing a normal tympanoplasty. Then this is our proprietary slicer, which has rounds of about 10 mm size, which is cut into it and embossed. So all you need to do is take your tragal cartilage and harvest it, put it on the round and cut away the cartilage. You always preserve the perichondrium on one side because it is the nutrient providing medium for the cartilage. Once you get the perichondrium inside and once it takes up the supply, trust me, it will stay for the patient lifelong. The next which we developed was the boomerang. Well, boomerang is basically a strip of cartilage which is cut from one side. The perichondrium is cut and the cartilage is cut on the whole side, but one side perichondrium is left inside intact. So it can bend like a boomerang. See, a perichondrium, the soft tissue is removed. You can cut the perichondrium very easily and the cartilage, but you should not cut the perichondrium on the opposite side. Yeah, see, now it can stay. As you can see, and the dimensions of this are 12 mm in length, 5 mm from one side, you'll have to do a cut. So one side will be 7 mm, which will stay in the hypotympanum, and the 5 mm side will stay on the stapes footplate. The whole dissection of the cartilage was done on an ASM grid, accurate specific measurement grid, which has laser etched grid, and you can very well see it under the endoscope or the microscope. You can very well make out the exact perfect markings and you can cut the cartilage accordingly. So now we put the graft, which is very easy. The graft has a V-shaped notch on the upper side, which is for the malleus to accommodate. Otherwise, it has a perichondrium on one side, and that is all you need to do. If you have the perfect measurements of your canal, then you can accordingly cut the cartilage and put it in the canal. For that, you might need to measure the canal at the annulus with your crocodile forceps. Take the same measurements on the ASM grid. Make sure the cartilage is at the same specific measurements and put the cartilage just in. If you slide it in, it will fix there in itself. It won't move at all. It won't lateralize, it won't medialize. And this is just repositioning the flap back. And this is basic a tympanoplasty. So now we move to the facial nerve decompression, which our dissectors might want to do. As I said earlier, facial nerve also in a goat canal is almost dehiscent in all cases, unlike ourselves. It's not covered in a fallopian canal. Most of the time, you'll find it lying right there. So all you need to do is a little bit of removal of the bone, a little bit of curating, and you'll find it right there, lying there. Yes. You can very well see the facial here. This is the facial. As and when we start removing the bone, we can see the round window and all the relations, same as the temporal bone of a human ear. Yes. This is a nice, huge facial nerve, which is coming. By this time, if as a dissector, you can totally remove the TM flap for your own convenience. So now we're removing the ossicles. Another thing to remember here is they have a big tensor tympani muscle. So you might want to remove it to decompress the facial up to the labyrinthine segment. Also the superior inguinal fold and everything was clearly visible. So now we start dissecting with the curette. It's better to dissect with the curette in a goat rather than use a burr. Because with the endoscope, we don't need so much of the bone removal. All we can do is a little bit of curetting. So this is the mastoid segment, which we are decompressing. Okay, now we move to the labyrinthine segment up to the first genu. Our curette is also bent, as you can see. It helps to maneuver your instrument inside the endoscope. You have an endoscope at the cartilage isthmus junction. You have suction on the other hand, and you have an bent instrument or your instrument on the right hand, and you operate it as such. So to facilitate the torque and the energy into the dissection, all you need is an angled instrument, and it will be easy for you to dissect. The huge thing, the huge chunk of muscle is the tensor tympani muscle, as you can see. Yes. So we are almost reaching the labyrinth. We are at the first genu. So now our dissectors can also try the facial nerve reanimation. We're going to cut the facial nerve. Okay. So similar as in trauma cases or whatever, that might be the cause. If you need to reanimate it, you can do take a glove, a small one, make a strip of your gloves on the ASM grid as shown. The measurements are around 4 by 8 mm. Okay, this is how you place the fascia or the temporalis fascia, as in a normal human temporal bone. You attach the ends of the facial nerve, and all you need to do is put the temporalis fascia over it and let it heal by itself. As we all know, it will take around 6 months to gain the actual results. So now we are removing the stapes, as we find in many of the cases where the stapes superstructure is eroded, and all we have is a stapes footplate. So we place the boomerang which we made, and you can very well see the boomerang will fit inside the hypotympanum. All you need to do is little slide it off in the hypotympanum, arrange it, and put it on the stapes footplate, and it won't move because it is fixed on both the ends. Yes, this is how it will look. All right, thank you. That was my time.
Thank you, Dr. Neil. I'm sure this will definitely help the dissectors. As a token of appreciation, I would like to invite Dr. K.T. Mohan sir, to hand over the memento and the certificate to Dr.
Amit sir.
Dr. Bharti Mohan, please. Now I invite Dr. R.N. Patil sir for his lecture on CT evaluation, classification of the extent of cholesteatoma, guide the endoscopic management of cholesteatoma. Dr. Patil sir.
At the outset, I would like to thank the organizers for giving me this opportunity of putting it in this lecture. I appreciate Dr. Mubarak, Dr. Sapna, and all the organizers have taken a lot of trouble to organize this workshop. And I appreciate them for making me the president of this Seocon. I thank you all, I thank them and all very much. Now I'll present my topic of have it little. What happened? Wire? It's okay. It is gone. I am trying to talk on little on CT and more on classification of otitis media and how it helps, how these both help in management of cholesteatoma. So first I will go directly to how I see the radiology, and here is one patient. Sound is connected, no?
Yes, connected.
Audio.
No, audio is not connected. You
Should
want
be
audio?
Okay. Okay. Here we load all our CTs on the laptop and then see the CT in the Radiant Viewer. And here we download the folders of the CT scan and see this CT scan. When we have downloaded here, we choose one number of views. They are all 0.5 mm, 6 mm cuts. And here I choose this and I choose the MPR on top. And I put it on a 3D MPR. I magnify it and go to any area of my choice. In this patient, the left ear is a diseased ear. So I'll use this and move to the left ear. And here I will move a little inside and see the mastoid. And when I decide this is the important area which I am to see, I move it to that. And all the three planes I will get. In this way, I can see that. And not only this, I can magnify whatever I want. I can magnify the ossicles and see the areas. And also I can take a line and draw a line, or I can take an arrow and mark an arrow, which is all this is possible in the software. And I can download it and screenshot. I can capture and save all these images also. So it's possible to do with this. So with this Radiant Viewer, you can download and use it for at least a month. And here I would go back to my presentation. So I have classified cholesteatoma into mesotympanic. In the early stage, it starts here. Can I have it little this side? Okay. So this is mesotympanic, I call it stage 1. Attic, I call it stage 2. Third stage is in the central mastoid, not going to the peripheral mastoid. Fourth stage is going to the peripheral mastoid, sticking and tentacles are going in the mastoid. So here, the fourth stage is adherent with tentacles inside the cells. And the last is extramastoid, which is going outside the mastoid, producing complications. So here I'm taking up the first stage. The first stage is in the mesotympanum, and all ENT endoscopic ear surgeons are doing endoscopic tympanoplasty for this. And here is a CT scan. You see that the peripheral, the mucosal edema in this case, attic is clean, additus is clean, and this is a mucosal edema which you see, and here attic is clean. You are able to see the attic on all the planes, and with this arrow I can show what is the problem. And the peripheral cells are all normal, so definitely it will involve only a tympanoplasty. Here is a video showing, please, audio. Look.
There's 1 second.
It's come. Started. No, it's not coming. I'm seeing the sac in the sinus tympani area. It's not coming there. I'm elevating it from there. I'm seeing the sac in the sinus tympani area and posterior area. I'm elevating it from the area of the round window, and I'm further elevating it.
See that?
Sound is, I should have talked.
Or you can talk, sir.
It is difficult. Okay. I'll just start this video again. And here, this is a past tensor retraction cholesteatoma, and I'm elevating the flap from the anteroinferior base flap, and we shift and remove the disease from the sinus tympani. Here I'm seeing that mucus secretion coming out from the additus. I'm elevating it out from the incus, and I'm elevating further down. I'm elevating it from the stapes. This is the area of the stapes and sepidal tendon, and now I'm seeing the stapes. I'm elevating it from the stapes. Further, I've elevated to the malleus also, and the incudostapedial joint are all mobile. Round window reflex is seen, and we put a graft. This is the way we have the next. This is another patient with a past tensor retraction cholesteatoma. We have lifted the area, and we have put an incus graft and then a cartilage graft. This is post-operative of the same patient. And now I go to the second stage of cholesteatoma. The cholesteatoma is going into the attic. So again, this is all ENT surgeons are doing an attic reconstruction. All endoscopic ear surgeons are doing with endoscope only this surgery. Here is a patient with a attic retraction cholesteatoma, which is the sticking inside, and it's going anterior compartment also. And here I'm elevating it from the attic area. I'm elevating from the tensor tympani area, from the sulcus tympanicus. This is the fold of von Trolch, and I'm going in the pouch of von Trolch, and I'm removing the mucosa of the von Trolch, and I'm reaching the area of the intraossicular fold. And further, I'm elevating it from the malleus, head of the malleus, and the anterior. And here I am seeing the anterior ligament of the malleus and the anterior buttress. We have to remove the disease from that area, otherwise some recurrence should not occur. So I have struggled to remove this. I'm cutting the anterior ligament of the malleus, and further removing the anterior buttress also, so that I get a clean picture, and I'm able to see the area of the eustachian tube, the supratubal recess, the anterior part of the attic is all clean. Then all the structures are mobile. There's no question of any reconstruction. I use a tragal perichondrium, composite tragal perichondrium with cartilage along with it, and this I put inside. And this is the post-operative view 4 years later. You can see, and the audiogram you see about 4 years later. Here's another patient of attic retraction cholesteatoma, and I have put a cartilage for reconstruction in that area. Now I go to the third stage of colostroma. When the colostroma is peeping back in through the adductus into the mastoid, it is not going to adherent anywhere. You can elevate it this. And here, most of us will do this work with this work. All endoscopic ear surgeons do this tympanic work with endoscope. But here, majority will do a soft wall reconstruction, majority of them. But a few like me and Dr. Tarabichi, we would rather do a cortical mastoidectomy and do a CAT. And while doing a CAT, we approach the epitympanum from behind. We have posterior tympanum from behind. So this also is with endoscope. So everything is endoscopic except the cortical part of the mastoid. So here is this patient who is having a colostoma. You see it is not mucosal layer is free between the disease and the mastoid. It is free. So there is a space there, and the peripheral cells are seen. So, but attic is involved. So definitely there is colostroma, and it may be worth trying a CAT in this patient. So here, the way I do from this area. Now this is a video where I have shown from the attic. You see the whole attic has been cleared. The colostoma is cleared from the attic. Even from the tensor fold area, it is being cleared. Here we are clearing it from the tensor tympanic tendon, the tensor fold, that area. And here we have the sulcus tympanicus was preserved. And here I'm doing a posterior tympanotomy. And we see that all the structure, even the notch of Rivinus, and everything is preserved. So you see the notch of Rivinus is preserved. So structural preservation will prevent retraction in that area. This is, sorry. This is another patient of colostoma in the ear. Here is it's a colostoma going from the mesotympanum elevated the tympanomeatal flap. I feel the colostoma is going back. CT scan has already showed me that the colostoma is going into the mastoid, and I open the mastoid and I find it in the area of the antrum, and I elevate it from the antrum. I elevate it further down from the area of the adductus. I elevate it from the medial wall of the middle ear, medial wall of the attic, epitympanic recess. I separate the colostoma from there, and I do a posterior tympanotomy. And with a assistant holding the suction, I do a posterior tympanotomy endoscopic. Then I put gel foam. I try to push the sac. I push it, invert it, and the whole sac is inverted into the middle ear. And it is only attached to the malleus. I remove all that, and you see the whole mesotympanum is clean. In the stapes area also, though there is mucosal edema, it is clean. And the facial nerve is seen, and the chorda is seen. Further, I remove the disease from the prosac space. I nip the head of the malleus, and here I am seeing the attic. The attic lateral wall is totally clean. The attic, all the areas are clean. I'm even seeing the mesotympanum in this area, and the whole window, all the structures are seen. And here is the malleus has been nipped, and all the structures, notch of Rivinus is preserved, structure is preserved. And here I put a graft covering only that defect which was having the colostoma. The remaining is all the original skin I have put back. Here I'm putting a incus on the foot plate of the stapes, and I'm checking through the posterior tympanotomy. I'm checking that it is sitting on the stapes, the graft is touching there. This is the pre-op view of the patient. This is the post-op view 7 years later. You see that incus is touching the drum here, and here this is the valsalva. On valsalva, you see the incus is touching the graft, and the hearing is quite good. Here, the hearing has improved by this much, and this is 7 years later. The pre-op hearing, little airborne gap remains, but definitely patient is clean and dry. Structural preservation is important. So it is a posterior tympanotomy is much easier with endoscope, and a better view you get of the mastoid. And here another patient of attic retraction colostoma. I was thinking of sending him. He's going to go to the army. So I put a cortical bone graft so that it looks similar, but he didn't go and join afterwards. But what I have been doing is, for this stage 3 colostoma, all the others are doing, they are removing this disease and doing a soft tissue reconstruction. But me and Tarabichi are the only ones doing here. Now I go to the fourth stage of colostoma, when there is the attic destruction is there, and the peripheral cells are thinned out. There is no cells in the periphery, and the colostoma is going to the periphery. I would rather do a MRM, and for this peripheral cells, I would go open up and do the MRM. Again, a majority of the surgeons, endo ear surgeons, will do a soft wall reconstruction for this. But me and Taravici, we are doing, I use a headlight for my cortical mastoid and endoscope for this colostoma, this part area. So when it goes to the periphery outside the mastoid, stage 5, I will do a radical mastoidectomy. So thus, we have classified colostoma into 5 stages based on the extent and how CT helps in evaluation and guides in endoscopic management of colostoma. So I would conclude that stage 1 is purely endoscopic, stage 2, attic also is purely endoscopic, stage 3, endoscopy for sinus tympani, attic, epitympanotomy, postotympanotomy, but headlight for cortical mastoid cells. Stage 4 and stage 5 are partly microscopic and some part of endoscope can be used. So endoscope for all tympanic work, whether it is mesotympanum, hypotympanum, attic, epitympanotomy and postotympanotomy, all is done with endoscope, only headlight for the cortical part of the mastoid. Thank you very much.
Thank you, sir. Thank you very much for the lucid presentation. I request, please hand over the memento to sir as a token of appreciation. Yeah.
Starting with the dissection, Gadre sir,
Yeah.
live stream.
Yeah. Now we have to felicitate these 3 people. Yeah. Yeah.
Yes, sir.
Okay.
Chairperson.
We felicitate the 3 chairpersons. Please come. Yeah, yeah. I know them. I request Dr. Sachin Patel to felicitate. Yeah. Please. Dr. Bharti Mohan sir. Dr. Satish Bagewadi. Thank you. Thank you. Yeah, yeah.
Now we are going to start with the cadaveric dissection by Professor Gadre, sir. I call upon Professor Daniele Marchioni, sir, Professor Prepageran, sir, Professor Vedi, sir, and Dr. Sanjeev from Nepal to kindly moderate the session. Please.
Please take the front seats. Yeah.
हा हा नाही, इकडे राहू दे. बाहेर बाहेर पण राहू दे. Correct. हा. नाही नाही नाही, राहू दे.
Hello. Yeah, hi sir. Can you hear us?
Mic चालू आहे का?
Sir, can you hear us?
I can hear you. Can you hear me?
Yes, very clearly, sir.
All right, wonderful. Sure.
Thank you.
नाही आता नाही कुछ आहे. आता सगळं I'm good.
Thank you. Again, the big boss. Yeah, I met him 4-5 times, like you. I met him 4-5 times.
Okay.
Thank you.
That's good. All right. So Let's get a pointer first. All right, thank you. So we have been asked to do this dissection of the temporal bone.
Hello. Hello.
Can you hear me?
Yes, yes, sir.
All right. So what we've been asked to do is we've been asked to do the dissection of the temporal bone for you. There are some fundamental rules that we need to understand. First of all, which side is it, right? That's important. So this is in the surgical position. Now in the hall over here, I have some anatomists. And when you have an anatomist, they are looking at it quite differently. They're looking at it from the anatomical perspective, which is standing upright. So all the anatomy images that you learn in Gray's Anatomy have to be turned through 90 degrees. So the vertex or the top of the head is towards here. The foot end is here. That is the root of your zygoma, and your occiput is at the back. Okay, so this is the process, which is the mastoid process. I often tell our residents that if it was not for the mastoid process and the facial nerve, I would not have a job, right? So this is probably one of the highest concentrations of different anatomical structures at one spot. And so there are certain fundamental rules to follow when we are using this instrument. This instrument is a tool that can be used as a cutting burr, but it is also a weapon. And so it is very important to understand how it turns. So for example, these drills, particularly the ones that we use in the operating room, turn as high as 70,000 RPM. Let's switch off the drill. All right. There it goes. So the drill is turning in a clockwise direction, correct? And notice that when the drill starts, particularly an electrical drill with high torque, you will see a kick. So if I keep the drill like this, just in my hand, and start it, you see how it jumps? So it's important to counterbalance that and to understand your instrument. Number two is the flutes of the drill are going to work best if it's turning in a clockwise direction. If I go from right to left, if I do this, that's where it's going to do most of its work. If I do this, it's going to roll like a tire on the road. So it's important to keep these few things in mind. Number three is you would like to use a drill that is the largest drill for the job. When you're doing an outside in dissection, you start with bigger burrs and you move to smaller burrs. When you're starting with an inside out technique, or you're starting at the drum and coming out, it just makes sense that you start with a smaller burr and move to a larger burr, okay? Number four, always try to look at the surface you're going to try to drill on. What does that mean? You do not want to undercut. If you undercut, that's how you damage the dura. That's how you damage the posterior canal wall. So let's start off. Let me have the suction, please. Let's get the suction. Let's start drilling. Oh, I see. Okay, that's all right. Suction machine lagin. I'll take it in my hand. Yeah. No. Everybody's. Oh, it is. We don't. Do we need? Oh, I see. We need a suction for this, so I can suck the fluid. All right, we don't want to waste your time. We're going to start drilling. So the suction, they're setting it up. So we're going to start the first cut. So it depends. So example, if you look at Mario Sana's dissection manual, they'll do a triangle like this. If you look at the House Year Institute where I trained, we make one cut here and we make a second cut along the temporal line, right? So it doesn't matter what you do, just be consistent in what you're doing, because your trainees depend on it as well. So let's start here. So we're going to start over here. Notice the drill is jumping. That's because the shaft of this burr is pretty long compared to the handpiece. And so you want to choke in on with your fingers to prevent that from happening. The other thing to remember is, if you look at bahar sa camera ka, haan chalto bahar sa? External camera. Then ह्याच्यावर फक्त focus करा. So if you are, thanks, perfect. So if, for example, you're looking at this instrument, if I hold it over here and I make a small movement at the wrist, it makes a big arc at the tip. If I choke in and go into first gear as opposed to fourth gear, you have a lot more control on the instrument. So a small movement of the wrist makes a smaller arc at the tip. Just common sense, right? So that's how you control your instrument. So I like to generally choke in. You want to, this is the area of McEwen's triangle, right? So you have the supramastoid crest, you have the temporal line and a tangent drawn to the posterior canal wall, subtends a triangle. It's also sometimes referred to as the cribrose area of the temporal bone. And so what you want to do is, here we can go a lot fast if we put pressure. The problem is, if I put more pressure with this burr, it chatters. Now, if I go this way, it'll tend to run off. I'm not getting efficient work. So you want to get into some sort of a rhythm when you're doing this. The other thing we always tell everybody, and this was something that was taught to me by Jim Sheehy, he always used to say, saucerize, saucerize, saucerize. Why do you want to saucerize? Because you don't want to work yourself into a small hole into which you want to get your instrument, your drill. You want to keep the area of McEwen's triangle, this area, you want to keep it the deepest. Oh my. Oh. This is now referred to as the central air cell tract. What I found, you see these little air cells here? You will learn to look at subtle differences in bone as you go through these temporal bones. It's very important to keep drilling as you even march through your career. It's important to do this. Let me have a smaller drill. Maybe that's what it is. Smaller burr. Yeah. And what you want to do is you want to get into some sort of a rhythm. As soon as you see the air cells, remember that when you hit compact cortical bone, the air cells start to disappear. You don't have air cells there, right? As you go from the periphery to the mastoid antrum, these air cells will start to become larger and larger as you go in. Are you all able to see that? Are there any questions?
Hello, sir.
Bola.
So this the mastectomy that you are showing us, sir. Usually, if we see that the disease is early, then we get the usually if the patient is having long-term history of ear discharge, we see very sclerotic mastoid. So any tips, sir, for doing a safe mastectomy in sclerotic mastoid, sir?
What are you saying? I'm sorry, I can't hear you.
Can't hear me, sir?
What about early surgery? What? Early disease?
no.
What?
What I was saying, sir, that if the disease is old, sir, if there is a long-term history of ear discharge, usually we get sclerotic mastoid when we do the CAT scan. So any tips for safe dissection in sclerotic mastoid, sir?
Right. So in we'll talk about that in a little bit. Let me get this. Let's get some of the work done. But I'll talk to you about sclerotic mastoids in a bit.
Okay. Thank you, sir.
So the tips are, just remember that the air cells that have, you will generally see some pinkish areas in the bone, and the bone will have a tendency to bleed a little bit, particularly if it is acutely inflamed.
Yes, sir.
Okay. So that's how you can tell. What the heck is this? I don't know what this is. This looks like there's some blood in the mastoid here. Let me have a Rosen needle or a Rosen pick. जरा पंखा ला हे बंद करायला घाल. Thank you. Yeah, thank you. This looks like this is a little bit of a postmortem bleed here, something, or I was just making sure I wasn't in the sigmoid. Doesn't look like that, so all right. So one of the things you'll realize is the reason why we say saucerize, saucerize, saucerize. Light जरा कमी जरा.
Microscope light.
It suddenly became a little dark. Yeah.
Microscope light increase it.
Maximum है ठीक है. Don't worry, it's okay.
Any difference of this step in pediatric case?
I generally do things very, very similarly in most cases. The pediatric cases, the bone is softer. So you see this compact bone that's coming up over here?
Yes, sir, we can see.
Hard bone, what is that? That is corner septum, okay? So you can see corner septum, which is an extension of the tympanomastoid suture line.
Yes, sir.
Now, I do a lot of the drilling during surgery for with the, at least up to the antrum. If I have a well pneumatized mastoid, if I'm doing a cochlear implant, for example, I don't go to the microscope till I get to the antrum, but that's just a force of habit. I'm not saying that's the only way you can do it, but that's how I do it. Now, the reason for saying saucerize, saucerize, saucerize is here, okay? If you don't saucerize, in other words, if you don't open up this whole area, your instruments are going to come in at a very vertical angle. If it comes at a vertical angle, your hands are in the way. Your instruments are in the way. If you open this up, then your instruments come in more flat. So is that clear?
Yes, sir.
Those are your mastoid tip cells. Is this the maximum speed on the drill?
I think it's the max.
Okay, that's all right. That's all right. Chalega.
speed of the distal is maximum? Maximum, maximum, no?
ठीक है, no worries. So the other thing you want to do is your posterior canal wall. See, I'm starting to see on the posterior canal wall, I'm starting to see compact bone right here, which means that if I push too far forward, you want to, if you're doing, particularly when you're doing a facial recess, you want to keep the posterior canal wall very thin. I tell the residents, you have to make it like bone china, fine bone china, Royal Dalton, nothing else. There you go. That's what we call a break for freedom. I think he's got a cholesteatoma. Double rare? What are you saying? Nobody's saying anything. Okay.
Back.
I have a little bit of a hearing loss. And so when I hear these extraneous noises, I don't know whether you're talking to me or not. So you should know when you're using your microscope, you should all your any instrument that you use in surgery, you should know better than the technician or the surgical technician how it's to be used. You should know what your interpupillary distance is, for example. That's not something that you should know how to use the exit pupil to your advantage. What the hell is that? I don't know. We'll find out. You want to open up classically we say open up the sinodural angle, open up the tip cells and open into the root of the zygoma. You want to open into the root of the zygoma because you do not want to leave cholesteatoma behind in the in the epitubal recess or the supratubal recess, right? Now, as you go towards the mastoid tip, your sigmoid sinus is moving away from you. So your sigmoid sinus is closest to you over here, where the transverse meets the sigmoid. It's further away from you as you go towards the tip. These steps become very, very important when you're doing lateral skull-based surgery, when you're doing a translabyrinthine approach, for example. You don't want to go back and redo a step. You waste a lot of time when you sort of going back and forth. You're going somewhere, then you're coming back to the same thing again. That's where the time gets wasted. So what I'm trying to do now is I'm trying to identify the sigmoid. In cricket, we used to have a term called a googly. Everybody in India knows what a googly is, right? Chandrasekhar used to bowl googlies.
Yes, sir.
So this bone is a googly. Instead of a leg break, you're getting an off break. I don't know what this structure is here. I don't know whether it's a. Somebody put a silastic sheeting inside or what? Let's, can we tilt this bones so that I can look at the posterior face? I think Dr. Sapna Parab has already operated on this patient. No, I want to go the other way. I want to see the posterior face here. There you go. Thank you. Okay. Now, what I'm doing is, what I was telling you is you don't want to undercut. What does undercut mean? Now, this is the edge of the bone. Can you see the edge of the bone here? If you go here, I'm undercutting. If you undercut the bone, that's how you get into trouble. You get into the dura. Okay, so you don't want to undercut like this. So if I'm dissecting on the posterior canal wall, I want to look at the face of the posterior canal wall. All right. You do not want to, that's why I changed the angle. In the operating room, I generally do not hold the head and move it. We tilt the whole patient. There was a case that happened when I was a fellow where a patient actually landed up dying because the resident pulled tilted the head and the tubes slipped out of the baby's mouth and they were not able to reintubate in time. My father used to say a young surgeon with a young anesthesiologist is a lethal combination. ठीक है. So you can see there's a posterior canal wall.
Sir, hello, sir.
Yes, sir.
Sir, what will be approximately the path that the sigmoid sinus would take over here?
All right. So the sigmoid sinus, can you give me a minute on this? Let me just dissect out the posterior canal wall.
Okay, sir.
Because I'll show you the sigmoid sinus. I don't want to take the bone out of the holder right now because this holder does not tilt. So since it's not tilting, if I take it out now, I'll lose it. But I'll show you exactly. I'll dissect it all out for you. Okay. So you'll be able to see the whole thing, how it goes. But I'm happy to show it to you. Give me a sec. So here, if you notice, I'm starting to see that the corticocancellous bone is going away, and now we're coming up on some compact bone there. So that's where I'm expecting it to be.
Yes, sir.
Let's take out some more bone. Why not? Well, while I'm at it, I think I should really thank Dr. Sapna Parab and my good friend Mubarak Khan. He's been a dear friend of mine for many years. And his wife Shireen and he have been very warm friends and guests and hosts, wonderful hosts to me all these years. So when I come to Pune, I oftentimes don't stay with my family, I stay with them. So here you can see that there are some zygomatic air cells that are opening up. Do you see that? Because you're coming up to the root of the zygoma, you can open those further. And this is the air cell tract where a lux abscess can form, right? So you have Bezos, Citellis, and lux.
Yes.
How I used to remember it was with a mnemonic. I used to think about it as British Council Library.
What was that, sir? What mnemonic, sir?
For remembering which is Bezos abscess, Citellis abscess, and lux abscess.
Yes, sir.
I used to think about it as British Council Library. We used to have a British Council Library in Bombay, now Mumbai. Opening up this area also becomes important if you want to push on the dura and find more space when you're doing acoustic neuromas. Remember that in the temporal bone, you're basically fighting for millimeters.
Yes.
So when you take out
Good
more
morning,
bone,
all delegates.
when you take out more bone posteriorly, you can look further forward. You understand? It's paradoxical, isn't it?
Yes.
You want to look in the front, so you're taking out more bone at the back.
Increase the angulation, sir.
What's that?
Increase the angulation of view.
Yes.
Right, sir.
Good morning, all delegates. We are inducing the case of right mucosal COM, that is Somnath Kadam. We'll be starting it in a short while. Thank you.
All right. Suction's blocked, I think. Let me do this. Let me just change the angle a little bit. So so now what I'm trying to do is I'm trying to find the incus. That's the next step, right? So I've changed my angle a little bit and I'm starting to look up towards the tegmen and towards the posterior canal wall. Thank you. So just like I identified the posterior canal wall here, I'm going to start identifying the posterior canal wall. What squawking noise was that? Did you hear that noise? This guy may actually have a cholesteatoma. Looks like a big sac, doesn't it?
That may be the mucosa, sir.
Yeah, it is maybe thickened mucosa. That's true.
Mucosa.
But generally, even in preserved bones, you don't see this kind of a picture. Do you have a duckbill elevator or some sort of a dissector? And try to take it all off. I'll take it. Anything flat, like a yeah, that a knife will work. Sure. Little irrigation, please.
We are defining for the tegmen mastoide, right, sir?
What is that?
Tegmen mastoide. We are,
What are you saying?
we are defining a tegmen right now.
What's he saying? Can you
Tegmen.
what are you? I'm जरा पंखा बंद करा. ऐकू येत नाही मला.
Uh-huh.
Ah.
So that is tegmen mastoid.
This is, yeah, correct. This is the tegmen mastoideum, as they say,
Tegmen mastoid.
or the tegmen of the mastoid, and what the literal meaning of the word tegmen is the roof,
Yes.
right?
Yes.
So you have the tegmen of the eustachian tube, you have the tegmen of the middle ear, and you have the tegmen of the mastoid. Correct. That is correct. So I'm going to change my angle a little bit. I don't like to undercut. It's the surest way of getting into trouble. We're about to tilt this bone. Yeah. That's good.
It's on.
There is no tegmen. One second. Is there there's a big hole on top?
Hello.
Yeah. They've already cut a big hole on the top here. It's a damaged bone. It's all right. We can show the labyrinth and facial nerve. So it's all right. There's already a big hole here. You see this?
Hello.
Do you see this bone? The bone has been cut in a very strange fashion. They've damaged the tegmen. That's okay. We can show the labyrinth and other structures.
Sir,
Huh.
before widening all these mastoid cavity, whether there is a means you first see the lateral septal canal, fossa incudis, additus, and then widen the cavity, or means identifying the landmark that lateral septal canal.
Well, the purpose of this exercise is not to do surgery, right? The purpose is to demonstrate the anatomy. So it depends on what you're looking for.
Okay.
Yeah. What are we doing here? We're trying to demonstrate the anatomy. The problem is, see this temporal bone here? It's been damaged. I think this is dura that's coming down. I don't know what this is. See this? It's tough. So do we have another bone?
Another bone.
Unless this is an encephalocele that has come down. So there's a big hole here. Let's do this. Let's yep. Yeah, this is a damaged bone. It's not a good one for demonstration purposes. Dusra hai? Yeah. Let's cut this off, huh? I think where do we do this first? You have a scissors? I should have checked the bone. It's my fault. I should have really checked this bone before we started. Yeah, there's no way. Yep, thank you. Yeah, this is tough. All right, never mind. So let's start looking for the. I hope they have an incus. We'll keep operating. They're trying to fix another bone for us, but while we are waiting, we can keep on dissecting. Let me focus this a little better.
The other ones. This one, sir.
Oh, sorry. This one?
Yeah. Both.
This is Zoom.
Okay, that's.
Yeah, this is correct. The right. Barabar hai na?
Ah.
हाँ. Little more irrigation. I hope the labyrinth is intact. It's a really strange cut. You can switch on the fan now. It almost looks like labyrinthine bone here, so. They were going to cut 2 bones and keep a 3 bones, but I don't know how they have them.
So the area you are dissecting, that is the area of lateral semicircular canal, sir.
Yep, because this looks like this does not, this looks like almost like posterior semicircular canal to my eyes. Okay, because it's very hard. I have no anatomy, really no. I'm trying to find some landmark, because what you want to do in ear surgery is you want to go from known to unknown, right?
Yes.
So I'm trying to find some known landmark that I can use. I'm seeing some air cells here, so I'm chasing those in. I think we are finding some structure here. There are some air cells here. A very sclerotic mastoid for sure. We always tell them to cheat towards the ear canal. So this is where you're cheating. Okay, let's change the angle a little bit. Sure. I think we're getting some semblance of the anatomy now. I'll just pull this out here and then We'll tilt it like so. Okay. Yeah. May have been an encephalocele too. We don't know. Tough, yeah. It's okay. You're gonna face these kind of things in surgery too, right? It's better to have it in the cadaver lab. Always try and use the largest. Tell them to, if you can tell them to be a little silent over there at the back. Now we are getting into a periantral air cell over here. Tell them not to worry. Tell them not to worry. Tell them not to worry. No need to. Nothing. This thing is turning. This suction is sort of turns on me all the time. And this thing just swivels. No, it's spinning. So what you want to do now is you want to start opening up towards the root of the zygoma. Okay. It's sucking. It's just.
This part,
Oh, I see. Which part is not sucking?
this part, there's a hook here.
Oh, I see.
Drain it.
All right.
Sir,
Yeah, go ahead.
sir, any tips for approaching facial nerve with that dissection?
Yeah, that's what I'll show you. I actually have a lecture on the facial nerve. What I try to do is I try to identify the short process of the incus.
Yes, sir.
And the incus marker is what I use. You can use the digastric ridge. You can use the tensor tympani tendon. You can use the stapedius muscle. I mean, there's lots of standard ways you can approach the facial nerve. But right now what I'm trying to do is I'm trying to find some normal anatomy, because it's a pretty diseased facial bone. And you're asking me about a sclerotic mastoid. It didn't look sclerotic when I started.
Yes, sir.
But this looks like labyrinthine bone to me. This is there's no air cells here. See?
Yes.
So I'm getting into the epitympanum right at this part here.
Can we see the incus, sir? No, not yet.
Not yet. I haven't seen that.
Yes, sir.
I told you it is a googly bone.
Right, sir. Now we realize what you were saying, sir.
This is, I think, like we're using right now. I think we're using a 4 millimeter burr is what it's looking like. Let me use one size smaller burr now. It's all right. You can keep on, I will keep on working with this for as long as we can. You know, this thing doesn't even sit here, see? It falls off. Do we have a tape? You can put it with tape. It's not fitting. The suction doesn't fit. Fits? Very good. Chalo. All right. So you can see the tegmen of the epitympanum right over there.
Yes, sir.
Also, the sound will change when the bone becomes thinner. All right. Nice long strokes along the seventh, okay? Where you expect the seventh to be. Now, some people will say use a diamond burr. Some will say use a cutting burr. Well, it doesn't really matter so long as you keep the bone clean and you want to keep the bone wet and cooled. The burr heat can cause apraxia of the facial nerve or even can cook the facial nerve, and you don't want that to happen. Now I'll take a 3 diamond. Yeah. So are you able to see the anatomy there? We have the
We can see, I think, the editors.
yeah, you can see the, that's right. So that's where we are at. And now what I'm trying to do is trying to see, I hope there's an incus there because, you know, lots of stuff is not there.
Yeah.
So we'll see what is there. And we often use the light trick, right? You use the refractive index of water being 1.3, something like that. You can also get some magnification from it.
Yes.
I generally try to dissect parallel to the incus. I think I just got a glimpse of the incus for a bit. Give me a second.
Yeah.
What I tend to do when I'm doing a cochlear implant is because we are trying to look down this way at the facial nerve, I take off a little bit of bone over here. I still leave a lip. You don't want to saucerize up top because otherwise the electrode keeps falling out. So I take out a little bit of the bone here.
Hmm.
Remember that the burr is being circular. It cuts on all surfaces, right? So when you should concentrate on everything. You don't want to be pigeonholing yourself into just looking at one side and the other side is cutting on a vital structure. All right, so now I'm going to change my angle just a little bit because I want to start to see if I can see anything, any other landmark. So the first structure I want to see is horizontal canal, which is probably this. And then you want to see the short process of the incus. I'm starting to see, I think, what's looking like the the superior suspensory ligament right about there.
Mhm.
You can see that? And then Dr. Noel Cohen used to always say, he said, get into a rhythm, you know, you you zip, zip and look, zip, zip, look, zip, zip, look. Also, one of the things you don't want to do when you're doing a facial recess is you want to actually find the nerve. The nerve is your friend, all right? You want to go and shake hands with him. You don't want to cut him off.
Mhm.
So what you want to do is you want to lower the whole floor. You don't want to presume where the facial nerve is going to be. If you start presuming where it's going to be, that's where you get into trouble.
And normally, what size burr would you use in this part, sir?
I generally use, I tend to start in surgery, I tend to start with a 4 or 5 millimeter cutting burr. And
Yes.
at this point, I'll go to like a 4 or a 3. And then as you start approaching the facial recess,
Yes,
you
sir.
start going to smaller sizes. I'll go to 1.5. I like the 1.5 a lot. There
Yes.
it is. Can you see that?
Yes, sir.
All right. Now let me zoom in a little bit. So what's the best way to face a googly?
Come forward.
When you're playing cricket, when somebody's throwing a googly at you, what do you do?
Put your leg in front, sir.
That's correct. So that's what I'm doing right now. So I don't know if you're able to see. Give me a pointer now.
We can see something, sir. There.
Dikh raha hai kya?
Yes, sir.
Yeah. So so your horizontal canal is going to be here.
Yes.
This is your incus right there.
Yes, sir.
Now, unfortunately, I'm not able to get a bigger zoom. I don't know why. It was that's the maximum zoom. Okay. No, there's got to be a way to. It was larger before. This is focus. Zoom. I want to zoom. Yeah.
Sir, that is the short process of the incus, I think.
Yes, that is the short process of the incus. Correct. So it's a very sclerotic bone. I wouldn't be surprised if this guy had an encephalocele or they've damaged it while harvesting the bone. So what I like to see is, I like to look at, yeah, we can't, that's a little better. Okay, we'll use it. Don't worry. Yeah, that's the maximum. All right, no worries.
Fine focus maybe.
Fine focus. Yeah. That's it? Okay. So over here at the back, you should start seeing the posterior ligament over here. Okay, so I followed the tegment. I started to see the superior suspensory ligament of the malleus and incus here. Can you see that?
Yes, yes,
Right.
yes.
So this is now in the epitympanum. So it is paradoxical, but what is happening is going towards the tegment actually prevents you from drilling on the incus itself. All right. So you want to move in that direction. You do not want to come here. Now, once I see the incus, I look at the length of between the body or the incudo-malleolar joint to the tip of the incus, and you multiply that length by 2. So you extend a line over here and pull it back over here. This is where I expect to anticipate finding the facial nerve. Okay. And we have done now, I think the residents have done about 45 cadaveric dissections to look at that relationship. We published our first 15, which I'll be presenting, and now we've done a much larger series. Now, to get into the facial recess very quickly, remember that the posterior canal wall, the posterior superior canal wall is not a straight wall. It's like a ski slope. It comes down and then it moves away from you. So if you dissect parallel to the short process of the incus, it'll actually throw you into the facial recess. Okay, so basically you are making a cavity in the scutal area, right? That's the scutal area. You understand what I'm saying, right? If you can put the irrigation just there. Thank you. Just over here somewhere in the general area.
So anteriorly, if we are means getting the glimpse of that chorda tympani, that is the anterior limit.
Yes, so your facial recess is bounded by the fossa incutis, the mastoid portion of the facial nerve, and the hint of the chorda tympani nerve. That's your facial recess.
So this facial canal is anteromedial to the lateral semicircular canal.
The facial canal is correct. Anterior and slightly medial to the horizontal semi. I'll show you the whole dissection.
Okay, sir.
Just be patient with me because we are having some technical difficulties. Okay. Now over here, oftentimes when you're drilling in the human being, when you're in surgery, you will start to see that there are areas like such as this where you'll have bone dust that'll fake you out. You'll start feeling like you are on the facial nerve, and you're not. I'm just going to change the angle of my microscope a little bit. There we go. This is like no, don't loosen it. Please don't loosen it, because when you loosen it, it's like wrestling with an elephant, right? You don't want to wrestle with an elephant. Right.
5G तुला नाही दिसलं का option?
आहे 5G. पासवर्ड काय त्याचा?
नाही आहे सेम आहे पासवर्ड. ENT B 5G बघ. त्याच्यावर बॅन हे 2.5 वर आहे.
What happened?
नेटवर्क बदल.
Your mic is on.
5G असलं.
हां नाही 5B 5. डिस्कनेक्ट करतो. 5G ते करा. 5G
इथं खाली बीच आहे ना.
5
हा, 5G.
5G वाला दिसतोय का? ते बंद कर बरं वायफाय बंद कर. हां डिस्कनेक्ट कर.
Now I'm starting to see a little glimpse of the facial nerve. See this? Right here is where I'm going to find it. This is sometimes referred to as barber poling. You start over here, go over the facial, and come at the back. Barber poling. A barber pole has these in America. They have the barbers, to mark their stores. They would have a little. It's like a spiral like thing that keeps on turning. It's sort of an attractive thing to attract customers. And that's called a barber pole. So like they have red, white, and blue colors that keep rotating outside the store. So this is what Jim Sheehy used to call barber poling. So you can see the horizontal canal right here. See this?
Aces. Sir, every time in facial recess, you first identify the facial canal, always?
Nowadays, I don't do it, but when I started, I identified it in every case.
Okay.
But nowadays, I don't do it because I'm sort of very, very comfortable. I know, how much space I need to get my my forceps to open and so on and so forth. Let me have a smaller drill bit now, a diamond. But here what I'm doing is I'm doing it for your viewing pleasure, right?
Sir, entirely whether that is the chorda tympani, the glimpse is,
होय बरोबर आहे. Correct.
कारण की ती एक पातळ लाईन गेल्यासारखी दिसते पिंकिश.
हो हो पातळ आहे. Correct. You're absolutely right. So I'll show you. Let me just focus it. Right there. This इकडे. Right here. Are they on the screen? Central?
Yeah.
It's okay. You have a smaller
whether,
one?
sir, whether in this cadaveric bone also you will get that herald cells?
What is the question?
That in cadaveric bone also, when you approach the facial recess, that the cells, that herald cells, it is called. That
Herald cell, not herald. It's herald cell.
herald cell.
Yeah, herald cell. Yeah.
So, whether
herald,
in cadaveric also you will get that.
what's that?
In cadaveric or formalized bone.
Yeah, you can. Yeah, you can see it. In fact, I'm already in the facial recess. Put some water over here. I'll show you. So you have in the epitympanum you have water. Now look what happens. Did you see it going away?
Yeah.
Yeah. So that means this is a facial recess hair cell that is communicating. You have 7. And if you look at the length of the incus from here to here, you multiply that same distance. That's where you're going to hit facial nerve. Okay. So Jim Sheehy used to always say, where's the facial nerve? The facial nerve is where you want it to be. So that's your facial. Do you see that?
Yes, sir. Yes.
So the bottom line is, even when you get a googly bone, right? You don't back off. I wish I could give you a little more magnification. Unfortunately, now what structure am I seeing over there?
The pyramid.
What structure am I seeing there?
Sir, superiorly the pyramid and incudostapedial joint, I think.
Correct, absolutely right. So you're starting to see, so you can see the chorda coming up here. The chorda comes off at a variable angle and at a variable distance on the 7th nerve, right? Now, oftentimes over here, sometimes the pyramid itself will be in the way. Be careful. It's very important when you're doing cochlear implant surgery to study your specimens, your CT scans, just like Dr. Patil showed in the previous lecture, very, very carefully. I generally tell the residents, you do the operation 3 times. Okay? You do the operation before surgery, you operate, and then just like a military operation, you have to have a debrief. So that's your facial recess. Now let's get a probe or a sharp picker. Yeah, that'll work. Yeah, that's fine. This is a Rosen needle here. So this is chorda, 7, short process of the incus, horizontal semicircular canal. We'll open those canals and I'll show you the anatomy too. Okay. So now what I'm going to do is, I know that the facial is here, so I know I can take off some of the bone over here. I can take off the bone over here. I like to identify the round window niche if I possibly can in almost every case. We don't have this is the smallest burr we have. Chalega, don't worry. Fikar nahi. All right, come. You want to irrigate? We'll do it later. Don't worry.
Up to what level that incus buttress is thinned out?
So up to you don't want it the answer is it depends. Sometimes you have a herald cell that is going up into the incus buttress.
Okay.
We now are try our best to try to preserve what low frequency hearing is there in every case. So I try to keep the incus buttress fairly thick. Also, my teacher Noel Cohen used to put a clamp on the. He used to put stabilize the electrode with. I don't do it, but he used to put a thing. So I just got into the habit of doing it. So about 1 millimeter or 2. So the answer is it should be adequate. All right. So I think I can see the promontory really well now. And this is where you're taking a little bit of bone in front helps you to look at in this direction at the round window niche. Okay. So now what we'll do is, I think I'm seeing a shadow of the round window niche. I think if you change the angle, there it is. Yeah. See that?
Yes, sir. Yes, sir.
कळलं ना तुम्हाला पुढे गेलं की पाठी दिसतं. You go front to look back. You go back to look in the front. All right.
But in jugular bulb,
What is that?
high jugular bulb, if you do
Correct.
that,
So, but that's what you want to study. This is good. Yeah. You want to study your CT scans before, right? So you know if there's a high jugular bulb. I don't think this has got a high jugular bulb. All right. So now you can, I don't know if you can they see it over there? It's too dark. Huh? I'll take a little bit of bone here.
sir,
Yeah.
that superior bony canal wall means that age is obstructing the thing.
No, I'm going to take some of this off here. Okay. You're talking about this, right? Now give me a cutting brush here.
Okay. Sir,
Yeah.
you have to centralize or and focus the picture little bit up because
No. What I'm going to do is I'm going to take off a little bit of the lateral ear canal wall so I can get some light in. The light is not very good on this microscope, so I just want to make sure that we get some.
But the audience which are sitting behind, they are just means concentrating on that external auditory canal. If you take it, centralize the picture up, then they will be able to.
I see.
Yeah,
Okay.
like this. Yes.
Like
Okay,
this.
okay.
But this is at the edge of my image on my microscope.
Okay.
मला दिसत नाही इकडे. There's a parallax error. So what you're seeing on the over there and what I'm seeing is completely different. Bola. The light will be correct. You're right, because the intensity of light is inversely proportional to the fourth power of distance. बरोबर है? I'll do that. Give me 1 second. You see the change in the sound versus this bone? Okay. Let's get it closer. खाली आणते. आता ठीक आहे का? Yeah. I'll tell you what. Can we put some thing underneath there so we can change the angle? Oh, you can?
Yeah.
Acha. Let's adjust the height. Are y'all centralized now or not centralized?
Yeah, yes, sir. It is centralized one. Just fine focusing will be required.
Yeah. I'll do it in a minute. They're adjusting the. Because you want to put an electrode in, right? So I think so, yeah. Oh yeah, much better. Okay. Now can you see it? Very good. Yeah, much better picture. Okay. Now I'll take the smallest bird. Diamond hai. Yeah, this is also a little on the large side, but we'll use it. It's a cadaver. He won't complain. All right, let's go ahead and drill.
Smaller burr if you have. Cochleostomy burr if you have.
1 millimeter चा आएगा cochleostomy burr.
Cochleostomy burr. 1 millimeter.
नहीं है. Huh? They don't. Okay. Is this the smallest one you have? Is that smaller? I think that one is smaller. Huh? Cutting, ठीक है. We'll use it. All right. We don't have a 1 millimeter cochleostomy burr. Don't worry. We'll still show you the round window niche. So here. This one here is what I was saying. This is the pyramid. Is the pyramid. I can drill a little bit of the pyramid off here. Well, let's do it. Yeah, yeah. I'm going to take off a little bit of the mucosa that's stuck to the pyramid here. Now, it's not something that I like to do during surgery. We don't have a cup forceps and usual stuff. All right. No, it's okay. So now I'm going to change the angle because I really want to see the round window niche. Okay. Can we change the angle of this microscope instead of changing the head? Thoda loose karo, dheere se. Yeah, that's good. Yeah. All right. And let's go in. वो नहीं चाहिए मुझे. ये झट से जाता है यार. सिर्फ यही करना है. ये टाइट करो. हाँ. और ये ऐसा क्यों ढीला हो गया? हाँ, टाइट करो. ठीक है, हो गया. ओके. हाँ. Okay, I think I can see the edge of the round window niche now. Can you see that? You can see a little dimple. So what I like to do when I'm drilling on the round window is, first of all, we like to go at very low RPM because we are also talking about hearing conservation. Yes. So we try to keep our drill speed at about 5,000 or less. We also give the patient some steroids. And what I'm going to do is I take off the anterior and superior lip of the round window niche. Now, when you're drilling like this, I like to, the Ansbach company makes a burr that is specifically designed for doing cochleostomies, okay? And the reason I like to use that is you don't want the shaft of the burr to cause heat damage on the facial nerve.
Conical one.
Yes. Yeah.
Also, contra handpiece is.
A contra handpiece may be useful. Sure. I have never used it, but I'm sure it is. Yeah. Now, in the old days, before we started to do round window insertions, we used to drop a vertical line from the round window niche forward and a horizontal line from the base of the stapes. And where those two intersected, that's where we did our cochleostomies. But now we try to identify the round window membrane itself, right?
So
Now
in-
I can show you the annulus of, I can show you the annulus of the round window. Give me 1 second. You can see a little whitish spot there. I don't know if you can see it on the camera. Give me a second. I can see it here. Little white spot. That whitish thing. Okay, let me focus for you.
So in case you are unable to see the round window membrane, so anterior-inferiorly you can go for the cochleostomy only.
Yes, that's right. So you're absolutely correct. That is why you have to have multiple tricks available to you. Okay. Can you see that white thing over there? That is the annulus of the round window membrane.
You are burying medial to the facial.
I am medial and anterior to the facial is here. I'm
Yeah, yeah.
anterior to it. I'm drilling on some bone to
And
create some space for myself.
anterior and medial. Sir, can we open the more cordofacial angle to see it?
You can. Here's what I've done. Now you got to remember that as you keep going down, you're also going closer to the jugular bulb.
Yeah.
And what you don't want is you don't want to hit the jugular bulb.
Now we are getting the anterior edge of that round window.
आता दिसतंय ना?
थोडीशी सर anterior edge दिसते.
हो मग तेवढी दिसली तर चिकार झालं. सांगतो का? कारण we are going to be drilling it away.
Yeah.
Focus में है अभी? है? Okay, चलो.
Yes, yes. So in extended posterior tympanotomy, by sacrificing the chorda, whether there is any in such cases we get some access.
What?
In extended posterior tympanotomy, by sacrificing the chorda, whether in such cases we can able to see the round window.
To see the round window, you need anterior, posterior. This distance has to be wide. By making this longer, does not of the same dimension. This dimension has to be wider between the facial and the posterior canal wall, right?
Yeah.
Then you'll see it. How does doing this extend it? If you're going to now, sometimes you have to do it if there's a high chorda that's coming in your way. You have to do an extended. But I don't remember the last time I cut a chorda tympani. I think it's important. I love my food. I want my patient also to love his food, right?
Okay. Yeah.
Then what happens is we start compromising. We said, "Arey, kuch nahi hota hai. Nikal dalo. Kya hota hai? Chorda gaya to kuch nahi hota hai." What do you mean by kuch nahi hota hai? It doesn't. Kuch nahi hota hai for the surgeon, right? So here I think I've just sort of gotten into the scalar tympani right here. Can you see that?
Yes, sir. Yes.
That black spot there?
Yeah.
Let me suck the water out.
Yeah.
Now, unfortunately, we don't have, I like to use a 1 millimeter burr. This burr is a little on the bigger side, but it's okay. The other thing in surgery is never be dogmatic. This is the only way to do it. There are several ways to bell a cat, right? So you don't. Let me have the rosin needle. That was a nice pick there. There is another instrument that is used in stapes surgery. It's called a McGee rasp. MCGEE. The McGee rasp it's 1 millimeter in diameter. And so you can use it to smooth out some of these burrs that are there. You see this? I pulled the round window membrane back there. You want to put the electrode. And then after this, what I'm going to do is I'm going to open the labyrinth for you and show you the inner ear. It's a well fixed, so this is what I call, this is the annulus of the round window membrane. You see that?
Okay.
That white thing? So I'm peeling it back. And now perilymph is coming out. Only one electrode, one phosphorus, that's fine. So this is what is known as a slim straight electrode. You see this electrode here? This is sometimes referred to as a slim straight electrode. No, this is an AOS.
So this is contour advanced.
This is contour advanced,
yeah.
the Americo.
It has
Acha,
to
okay, that's
stylet,
it.
I
Yeah,
think.
yep. It's got a stylet.
Yeah.
Okay.
That's why we'll need one to.
We'll need one to hold it with, correct. So let us show them the electrode. So the electrode we are putting in here is also referred to as a 612 electrode or the contour advanced electrode. Okay, so it has got a tip. There are 22 little electrodes. Can you see the electrodes there? These are called over here, these are called the 3 stiffening rings. So these are the electrodes over here. This is 1, 2, and 3 stiffening rings. And these are sometimes referred to as the ribs to hold it. So these are 3 stiffening rings. Can you see that? 1, 2, 3. This is, yeah, this is the stylet. Okay. There's a white mark over here, and that is, so what we're going to do is use what is called a advance of stylet technique. All right. So what you're going to do is you're going to come at the right angle first. Are we on the screen? कहाँ गया electrode? Just don't bend it because the stylet will bend. Yeah. Yeah, perfect.
Sir, whether that cochlear person is given this dummy?
I did get it from the cochlear rep.
Okay.
Because we do about 1 or 2 cochlear implants a week in our center. So it's considered a moderate size center. So I told the rep, can you please give me some? I'm going to India. Can you please get me some electrodes? These are the electrodes we get for our residents to practice.
Okay, okay.
So
Where did you put it?
No, we have
So
to
you-
request it.
So
Okay.
let's go to a low zoom out, please. So what you don't want to do is you do not want to hold the electrode here. You will damage the electrode. So I generally hold it by the first stiffening, or sometimes I'll hold it a little bit more proximal, depends on where we are at. You come at the right angle, and then you want to see, let's zoom in.
This one.
Left side ka hai. No, that's focus.
This is cochleostomy insertion or extended round window.
This is a round window insertion.
Okay.
I moved the round window membrane back. Remember, I told you about the annulus. Now, what is going to happen is that tissue there is going to obstruct me. Let me do. Yeah. You can even hold it at the stiffening rings. You don't want to hold it on the electrode itself. Let me have the suction.
Sir, whether in such cases, if we do the round window, means extended or round window, the cochleostomy just, so whether it will be easy to insert the implant?
It depends on your level of experience. If you think that it's necessary to take your patient's taste, do it. I don't do it. Right? तुम्हाला करायचं असेल तर you can do whatever you want. It depends on whether you would like to give your patient taste or you don't like to give your patient taste. So where I'm concerned, you want me to show you how to do an extended recess, I can show you.
So you mean to say you always go for soft insertion?
Yes, because then it becomes a habit. You start doing it one way, one time, another way, one time. Then even if I'm not conserving hearing, and I know that the patient does not have hearing, I still do a soft insertion. Yes.
I'll just get the 3 in and
I'm a creature of habit. So what happens is if you do something the same way each time, every time, you'll become an expert at that technique, right? If you do something one way this time, then some other way or another time, you're not an expert at anything. Give some irrigation.
Sir, generally, there are two schools of thought. One is propagating the only soft insertion. One is no round window, only go by the cochleostomy, like that.
I do, sir, you are asking me about how I do it. I'm telling you how I do it. There are two ways of eating with your right hand and your left hand, right?
Yeah.
So you decide. It doesn't matter. So so long as you're getting good results, whatever technique you use, I'm not against it. I have used both. When I started working as a fellow, I was doing solely cochleostomy insertions. But then over time I changed.
And sir, what is your experience about this pochette tympanotomy and varia?
I don't do varia. I don't believe in it. I don't think it should be done because I have seen complications of varia. I've seen electrodes coming out of the skin. So I do not do varia. So like I told you, I'm a creature of habit. I think I don't think, let's see, let's try it this way.
Excuse me, for the live surgery, I invite the chairpersons, Dr. Ajay Doifode, Dr. Khageshwar Raut.
All
and
right, now
Dr.
give me a second. So you see that white line? All right, let me have another forceps. So you want the white line to disappear. The crocodile is fine. So you want the white line to disappear inside the cochleostomy. Then what you do is you hold the stylet and don't move the stylet, okay? And then what you're doing is you advance off stylet. Like that, okay? And the stylet comes out. And then what you do is you have to go to the second stiffening ring. That covers, so you see the stiffening rings are out now. Maximum zoom. Yeah, unfortunately, I cannot zoom more than this. I wish I could show you. So see that? First stiffening ring is in.
Yes, sir. Yes, sir.
Second stiffening ring is in. That's it. Okay, so that's your, and then obviously you want to curl it. That's why if you don't have this ledge, it will jump out. It will spring out at you. So that's why you want to keep a ledge over here. Okay. So that's how I do all my things. Now, I'm going to show you do we have time? Ask Parab madam, if you have time to show you the labyrinth, I'll open up the labyrinth for you.
Sir, we'd like to shift to the live surgery now. Please.
All right, fine. No problem. No problem.
Thank you. I will come back to you shortly.
All right, fine. Finish the live surgery. Perfect.
Sir, we have two screens side by side here, so you can dissect also and show us.
I can keep on dissecting. Oh, that's lovely. That's so nice. Okay.
Yes, sir. We have.
But I want to see this tympanoplasty too. I want to learn from my guru.
Mubarak sir, are you hearing this? I guess he's not having the speaker there.
All right. So now one word of caution. You see, when I'm taking this electrode out now, when it comes out, it's curled. Don't try to insert it. Okay. They do not recommend that you put the stylet back in and you put it back in. We used to load the stylet in the old days. It's not, you can damage the electrode and everything will just coil in the basal turn. It won't go up. So that's okay. 632 is reloadable. 612 is not. Yeah. This was the 612. All right. Yeah, we'll put it in the. We'll put a 2mm diamond. It's okay. Whatever you have, I'll use.
Sickle.
All right. Yeah. हाँ बोल. ऐकतोय.
Hello.
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 Can you hear me?
Yeah, we can hear very well. Yeah.
It's a bad save.
Please.
Not a bad save. on the top case.
Good morning to all.
Yeah, very good morning.
Yes, first of all,
See it, right? दिखा है ना अच्छा दिखा ना सबको
hello.
Dr. Khan, go ahead. We are watching you.
Yes.
Uh-huh.
Okay, can you present the PPT for the guest? गदरे सर का डिसेक्शन चल रहा है साइड बाय साइड.
Yes, yes.
Yeah.
Whatever. Mubarak,
He does a wonderful dissection, so please keep that dissection going on, okay, side by side.
So see this. This is the horizontal semicircular canal over here. I'm going to blue line it for you.
Good morning, one and all. Our first patient is 31-year-old male, case of right mucosal COM. The patient came with chief complaints of right ear discharge since 3 years, which was
Make these
mucopurulent,
long.
non-foul smelling,
You know where the
profuse,
seventh nerve is, right?
non-blood tinged.
So you want to just make
He also has a history of
Goes
right
like
ear reduced hearing since 3
the
months.
other thing is if this is your horizontal
On
semicircular
otoendoscopic
come
examination,
over here.
there was a large
The
central
seventh is going to be right
perforation,
next to it.
foreshortening of
Come
handle
on
of
this side.
malleus, and a tympanosclerotic patch on anterosuperior quadrant. On pure tone audiometry, there was 25 to 30 decibel hearing loss in low frequencies and 45 to 50 decibel hearing loss in higher frequencies. Now I request Mubarak Khan sir to take over.
Hi, Mubarak. This is Ajay here.
Yes, Ajay.
Can you do a white balancing? You know, the picture is quite reddish here in the auditorium.
Okay, I will do. This is a new camera, that's an Olympus 4K. Okay, and here I can see a fantastic picture. Let me do the so just clean the Karthik la bolo रे जरा. काय चांगलं घे ग.
Okay, I'm starting to see a little bit of a blue line. Now, if you use a cutting burr, it'll go
Audio
much
visual people, can you reduce the volume of this temporal?
कार्तिक कुठे आहे?
chalega.
Meanwhile, we'll introduce the three moderators. Dr. Ajay Doifuda is from Mumbai, in practice since 20 years. Associated with Nanavati Hospital. He was president of AOI Mumbai for 21-22. He's a member of
इसी का जा रहा है ना? वो उधर अच्छा नहीं
International Working Group on Endoscopic Care Surgery. Dr. Khageshwar Raut is professor and HOD at Bhubaneswar, secretary of the AOI Odisha. He was the organizing secretary of Seocon in 2022, which was held at Bhubaneswar. He has 32 articles in various journals. Dr. NVK Mohan sir is from Kolkata. He is in practice since 2008. He is practicing in cochlear implants. He has been president of the NES, that is the National Neuro-Otology and Equilibrium Society. And he has many papers to his credit. Please carry on.
I'm just creating some space so people can see. Now, what we'll do is we'll start blue lining the horizontal semicircular canal. Okay. So notice that if you look at the dome of the bone, the labyrinthine bone, it is lateral, correct? It is lateral to the facial nerve, but the lumen is medial to the facial nerve. So if you look for the lumen to find the facial nerve, you're in trouble.
Both people manage.
They are managing.
Yeah.
Reducing the voice.
So Mubarak, we saw,
Yeah.
in interest of time, you have, infiltrated and started. So can you, for the novices and the PGs, can you kind of give your protocol of preparing the ear canal for an endoscopic ear surgery?
So let's start from the first. I already infiltrated. You can see a stay suture here. Okay.
just
Yes.
to get that 1 millimeter, that is what important, at least for me, okay, for the two-handed endoscopic ear surgery, because the endoscope is mounted here. I am using it's very nice 2.7 millimeter HD endoscope from the Olympus. Okay, so if you just look at the stitch, okay, this is a stay suture. Okay, it is taken at the junction of cartilaginous and bony junction. When you pull it, see this, okay, you get 1 millimeter.
We can't see the postoral area. Maybe the camera can zoom out, or we
Okay.
can have an external picture also. Oh, now we can see it.
You can see that
Yes.
it comes from like this, and just pull it. So you get that extra 1 millimeter, and very important for manipulation of the two instruments along with the endoscope. 3 millimeter endoscope is very good for the endoscopic ear surgery. Professor Daniel is there. The working group has worked on that, and 3 millimeter they recommend for the endoscopic ear surgery, because you get that 1 millimeter extra. Let it be a single-handed, let it be a two-handed. You need a space for manipulating the instrumentation. So before the surgery, 1 day prior, you can see we have applied the hair removing cream, that is wheat. So the hairs are taken out. It's very important. When you are manipulating the endoscope in and out, the touching of these hairs to the endoscope blurs the vision, so that you are taking endoscope in and out and cleaning the endoscope. So here you can avoid that by preparing the external auditory canal. Okay.
Okay.
Yes, and then nice infiltration, and I do all my cases under general anesthesia, okay? Because I work in private practice, so not a single case I do under local anesthesia. So anesthesia is very important, and my anesthetist give me 90/60, and the pulse is very important. So you keep the pulse below 70. Okay. So what's the now here? They have also given me a good feel. What's 90/60 and yes, and pulse is 70. So that's a very important. And along with that, you can infiltrate routinely like a xylocan with adrenaline. So let's go and just try to compare it. All the techniques are similar with that of microscope, but note the difference with the endoscope, how the panoramic view you are getting and how you can beautifully do your surgery. So this is a type 1 tympanoplasty. You can see the large central perforation. I have freshened the margin. Little bit of wet ear, but it's not a discharging ear. So that's why you can see the hyperemia. So I will, after freshening the margin, so I will take incision. Depending upon the perforation, I modify the incision. If it is a smaller perforation, so I take a transcanal incision, just a 10 millimeter or 8 millimeter away from the little bit bigger flap, because this is a large perforation, almost a subtotal perforation. Okay, picture is good.
Picture is very good.
Yes.
Mubarak, just a quick question. Where do you place your endoscope?
Now the endoscope is at, see, let's come out. I am using my rack and pinion mechanism of endo holder to go in and out. See this. This is the beauty. This is not a simple holder where you can keep the endoscope at one particular position. You can keep moving this endoscope. See this, okay? You come out. So I am keeping the endoscope in the outer 1/3, that is at the isthmus level, okay? So I can manipulate both the instruments. Whenever I need to go inside, I will go in, and then
the audiovisual zoom in on the external camera, because we are not able to understand what you're explaining.
yes, please. Can you use the external? Yeah. Can you see the external camera?
Yes, yes.
Yes. So here is the rack and pinion mechanism. Okay.
No, we are seeing only the endoscope.
Only the
can't see the holder. We can't see the holder.
Yeah, here, यहाँ पे.
Maybe the PIP picture can be enlarged for a bit.
Okay. So can you see
Can you
this?
switch the images? Yes, 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 yes. That's
Yeah, see this. This is a rack and pinion mechanism, okay? And this is the whole endo holder. It has got all the actions, okay? We don't need much actions here, but you can have this simulate the left hand, okay? And this is the very important action that's called a rack and pinion mechanism. This can become a motorized one, no problem, but it's here, it's a mechanical. So whenever you want to go in smoothly, so just go in. See this, okay? Let's go to inside. See the beauty.
Yeah.
Okay. This is not the zooming, huh? This is just moving the endoscope in and out the way you are using your left hand, right? See this. I have totally come out, go in, right?
Yeah.
Yeah. Yes. So let's go. Give me xylocaine with adrenaline pack for this. Yeah? So
now can you switch back, please?
yes, please.
Switch the images again.
Give me xylocaine with adrenaline pack. Yeah. Halka. So this is the Ivilon pack. That's a nasal sponge soaked in adrenaline. Note the suction. Okay, this is taking care of the heat as well as the fogging. There is no fogging here. Okay, I'll show you if you take out the suction, there will be a fogging. So let's go for the incision.
Dr. Khan, what anti-fogging solution are you using?
Which come again?
What anti-fogging solution you are using in this case?
No, this is Savlon only, but I hardly need this the defogging. Okay.
Okay.
Yeah, because this suction takes care of the fogging. Huh? Whenever I want to clean, when the endoscope gets blurred with the small blood or too much of fogging, then you just wash or irrigate the endoscope with the normal saline or ringer lactate.
What kind of light is it? Xenon?
No, this is not xenon. This is LED.
Okay.
So almost I make a 270-degree flap. Take a time to.
Okay, you are using the light at what intensity?
Here, because this is it's a automatic balance, because this is an fantastic system from the Olympus. Is the camera, so it automatically Karthik, what it does? It focuses. Light is at what? No, for the light source, what is the? It's a automatic balance control, so it gives an intensity depending upon the.
Okay.
Yeah.
We
So
have.
it keep on changing. Huh? Can you show the system just with the external camera? I can see a fantastic picture here. You know, what's the beauty of endoscope? See this, because everything is in front of you. And this is what panorama, everything is in front of you. Anterior wall, posterior wall, superior wall, inferior wall. You are not going to miss anything. Take a time, always in the posterior superior part, that's a thick skin, that's a vascular strip. This flap is very important, okay? Even if that small bleeding is there, suction will take care of that. Preserving this flap is very important because the squamous epithelium is going to grow from here only. So take a time to elevate. Very thin skin in the inferior part.
So start elevating from the superior. So in two-handed endoscopic ear surgery, you need to bend certain instruments while you are working. I will show you during the cholesteatoma surgery. For the tympanoplasty, you can use the routine instrumentation, but you have to bend certain instruments like a flag knife and then angled suctions. Xylocaine adrenaline pack. I don't use those cotton plagate because that lint is left behind, and that's the reason for the granuloma postoperative series. So simply use those nasal sponge. Suction is blocked. Suction. उगाच endoscope वर टाकू नकोस. छोटा पाहिजे. Intermittently, you can just shift the audio to dissection. Okay.
Left.
See, it's very thin skin. Take a time to elevate, okay? Because beauty of endoscopic ear surgery is to see and then proceed, okay? The prime important thing is to have an excellent camera, minimum 3 chip camera, good medical monitor, because you are seeing everything on the monitor. So you need to have those system. If you use a single chip cameras, you will see those red hue on the monitor. So that's not a recommended thing. If at all you want to be an endoscopic ear surgery, invest in good 3 chip or the HD cameras. We will compare because we have this Olympus system and then another Japanese, that's Akino. I will be operating the second case with the Akino. So we'll compare and we'll see. So now if I want to go little bit in, you can just go like this. Using the rack and pinion. Yeah, थोड़ा सा ले. So the small bleeding, we can control it with the suction cautery. No, that's all. Small suction. Those are the suctions which are just insulated. Small innovations, that makes your life easy. Try to compare it with the, yes, I am not, see, hardly I am taking out the endoscope, okay? In and out. So this suction is very important. It's not just for this. This takes care of the heat as well as your fogging. Okay, we have reached here. So give me the forcer. We have kept this on a autofocus mode. I hope the picture is good there.
Yeah,
So now I will be changing it to the manual mode. Yes. So let's see. I'm just focusing. Because I want a little bit more crispier picture. This is not good. Okay. Okay. Now give me the flag knife, the angled flag knife. This is how you have to bend the instrument when you want to work here. Huh? So I will go under the anterior flap. Dissection is going on.
Irrigation?
No, I
Hello?
think dissection has stopped. Only one screen is live now. That's yours.
Dissection is not stopped. Dissection is going on.
Yes, please. So please keep it in. Yes.
All right. Nainami, I was listening to you, Mubarak.
Oh, sir, dissection kara very important, sir.
No, so I'm showing them the I'm showing them the inner ear. I've dissected out the horizontal semicircular canal.
Yeah, Dinesh, wo peak mein rakho.
Let me have Rosen.
Dinesh.
Yeah, now we have that dissection picture also.
Yes, yeah. Let it be on the simultaneously go on.
Right.
Okay.
So,
Yeah, because
this is the horizontal semicircular canal. Facial nerve is over here. That's the ampulated end of the horizontal canal. If this is the ampulated end of the horizontal semicircular canal, your ampulated end of the superior canal is going to be right here, next to it.
Right.
Okay. Your horizontal canal is like this. This is your posterior semicircular canal right here going to the common crus. And over here, you can start to see the lumen, the blue lining of the superior semicircular canal. You see that? So
Yeah.
now we'll just open up the superior canal and then you'll see the irrigation. There it is, eh?
So to the youngsters in the audience, Mubarak has done an excellent job raising the tympanomeatal flap. When you embark on endoscopic ear surgery, this is the most difficult part initially. You struggle to raise the tympanomeatal flap. You, irrespective whether you're doing one-handed, two-handed, there is bleed, and there's struggle.
The whole, you can see the whole superior.
The patient, he elevated the flap, went into the right plane, and once he reached the annulus, the bleeding issue is sorted. So a lot of patience is required. This.
All right.
Normal saline.
Let's turn it a little bit. Kya hua? Oh, there's a hole. All right. So here you can see now, we can show you. Want to change the angle a little bit.
Ball point.
This is better.
Ball point. So you have to control the suction, okay? The flap, when it is a very thin, you have to take care of your flap.
See this?
So the control is in your hand and the right suction side. See this, how thin
here.
Flap is there, okay? Yes. Give me the forceps.
So are they able to hear me now?
Yes.
All right. So you can see Can you see the superior semicircular canal here?
Yes.
So this is your, I'm going to turn the angle. So I've identified the horizontal semicircular canal. Can you see that?
Yes, sir.
All right. Now just remember that the bone of the labyrinth at the horizontal canal is lateral to the second genio, the facial nerve. However, the lumen is medial to the facial. Facial is lateral to the lumen of the horizontal semicircular canal.
Correct.
So the ampullated end of the horizontal canal is next to the ampullated end of the superior canal. And I have dissected out the superior canal for you here. You can see this groove that's going like this and going like this. This is now going to the common crus. Common crus will give rise to the posterior semicircular canal going like this. And the ampullated end of the posterior canal is going to be medial to the facial nerve. Okay. Now, you see these cells over here? This is the subarcuate artery here.
Yeah.
Okay.
Sir,
Now,
what about the Trotman's triangle? Trotman's triangle.
Trotman's triangle was where this hole is. Why do you want to know about Trotman's triangle?
No,
When we are talking about labyrinth?
because more PGs are there, so they generally such questions are asked the Trotman's triangle and solid angle and all that things to them. So
No, the Troutman's triangle is between the jugular bulb, the tegmen, the sigmoid sinus, and the posterior semicircular canal. That bone is referred to as Troutman's triangle. Okay. That is where we had this encephalocele right here. You understand?
yes, sir.
So
Yes,
that
yes.
this area of bone over here, this is Troutman's triangle bone, but I'm doing labyrinthectomy. So let's not distract. Okay. Let's stick to the point. Let us get this done. So now this is the subarcuate artery. Okay. Now you have the superior semicircular canal and the ampullated end of the horizontal semicircular canal. There is a nerve that gets into that. That is called the superior vestibular nerve, right? The internal auditory canal is always caudal to the subarcuate artery. All right. So if you start dissecting here, you will never find the IAC. You will go into the petrous apex, you will go to the fifth nerve, sixth nerve, and so on and so forth. You have to dissect here because your IAC is going to, your internal auditory canal is going to be between the ampullated end of the superior canal and the ampullated end of the posterior canal. So it is going to be between that point and that point.
Yeah.
Right? Because what is going to come in at the ampullated end of the posterior canal is the singular nerve. Right? So if you want to find the IAC, it is going to always be caudal to the sublabyrinthine, to the subarcuate artery. It is going to be between this point and that point. So now to dissect the IAC, we will drill this bone in this direction. Okay. So now what we're going to do is now y'all can watch Dr. Mubarak Khan's surgery, and I will now start dissecting.
Yes.
Yes. Hello.
Khan, now we are with you.
Yes. You can see now I have completely denuded the malleus. A beautiful malleus you can see completely denuded. And give me the flag knife, which is angled one. And you can see in the antero-superior area, there is a white plaque. That's nothing but a tympanosclerosis.
Yeah, this is a very common site where you will get the tympanosclerosis.
Note the beauty of the endoscope. Everything is in front of you now. You will not miss anything. Again, the anatomy. Anterior wall, posterior wall, superior wall, inferior wall, malleus, lateral process of malleus, prosac space, posterior overhang, incudostapedial joint, anterior isthmus. Okay? You can see the round window niche here, and we will go and see again. This is a tympanosclerotic plaque. So again, I'm undermining here. See the ease of doing the surgery, because if everything is in front of you, you will not miss anything. Obviously, the anatomy is little bit different endoscopically. So you have to get hand, eye, and monitor coordination.
You want
That
to
comes
see?
with the practice.
Go ahead. So adjust your interpupillary distance, whatever is yours.
So Mubarak, a very nicely denuded malleus. Any tips on where to start and how to denude the malleus, especially if you're doing one-handed?
That's quite tough when you are doing with the single-handed, because I find it, because I use the suction, and I'll show you, because you need to sharpen your instruments for, see this, you need to have a very sharp sickle. After 10 surgeries, you need to sharpen it again and again, okay? So I sharpen it under the microscope. I use a microscope for sharpening the instruments, not for the surgery. Okay? And with the diamond bar. So the crux is, you start from here, incise the periosteum, okay? Come up to the umbo and go up. Another thing, if you have got the nice forceps, you can start peeling it out. But with the peeling, what happens? Many of the time, the periosteum is not inside. Some squamous epithelium may, you may live there. So sharply incise the periosteum. The way you elevate the perichondrium during the septoplasty. So sharpen it, come here. If you feel there's something is there, I just take a malleus nipper and cut the small piece of umbo. Okay.
Okay.
Yeah. So now we will take this out. Before that, some anatomy. See the beauty. You will not miss anything. See this. Incudostapedial joint nicely covered with the mucosa. I'm going to take out this bone little bit to see whether the posterior isthmus is blocked or not. I can see the nicely opened anterior isthmus. Okay, we will put the suction and then I'll demonstrate it. Okay, let some irrigation. Take care of this flap. It's very important, because if you are not using the right suction, the flap comes in your suction and everything is lost. Keep irrigating. During the COVID time, I used to irrigate with the 0.5% povidone iodine. हे केलं का आपलं हे PRF? So let's move fast. Okay. Give me the sickle.
So what is your pre-op protocol for a typical case like this?
Pre-op, we have to first assess. I completely assess whether the patient is having the allergy. If the patient is an allergic, and I take care of the allergy, I tell patient about the outcome of the surgery. If it's a completely dry, nose is quite good, there is no allergy, so I hardly use any antibiotic. If it is a discharging ear, I make it dry by the antibiotic, antihistaminic. And once it is dry, at least for the 4 weeks, then I go for the tympanoplasty. If the patient is an allergic one, so I give antihistaminic post-operatively at least for 3 to 4 weeks. Even I do the allergy test prior only, and give the immunotherapy for that patient, only for the allergy. Otherwise, for the dry, simple dry perforations without nose problems, no antibiotic post-operatively, only antihistaminic and the painkiller.
So apart from the routine investigations, do you do any specific investigations? Do you do a HRCT temporal bone?
No, for the simple tympanoplasty, no. But for the all cholestatomas, yes. So take care of this, because the tympanosclerosis means there is a long-standing inflammation which is going on. So this is the area. This you can see that. So this is the area for the tensor fold. This is the supratubal races. We will go and see that. So the block is here.
Mubarak,
Yes.
I've got one question for you.
Yes,
See, now
sorry.
for the beginners, you see, especially if they're doing it single-handed, a
Mhm.
lot of this movement during endoscopic surgery is, like the instrument is going in and out in a constricted space. Sometimes there is a, chance of, going and hitting the ossicles. How would you advise them to prevent that kind of a injury?
I didn't get what injury?
When you're introducing the forceps or instruments in and out of the, especially when if someone is doing single-handed,
right?
Sometimes, the hand might slip and go and strike the ossicle.
Yes. That's really a.
How would you advise this, juniors especially, to guard against that?
Can you show with the external camera? So use your little finger. Just show this. Yeah? Just external. And support your instrument. See this. Can you show? Can you see the external camera picture?
Like you do in temporal bone dissection, drilling.
Yes. So you have to support your instruments like this, huh? With the little finger on. At least for me, for the two hands, I do like this. Okay. So obviously you will not use those shoulder. So you support it with the little finger and then go on doing like this. Okay.
So that is the important point. The movement should be at the wrist and the finger level, not at the
Absolutely.
shoulder level.
Not at the shoulder. Otherwise, this happens, right?
Yes, exactly.
Yeah, so,
Exactly.
yeah, so you support it with. So let's go, because we have elevated completely. Again, irrigation. We'll take little bit bone posterior superiorly to see whether the posterior isthmus is blocked. So little bit anatomy. A wonderful book by Professor Daniele Marchioni on endoscopic ear surgery. All people who are interested in endoscopic ear surgery can just go through that. Beautiful anatomy he has described.
So Mubarak, there is a question from the delegate. Does the endo holder obstruct your vision or come in your way of your surgical movements?
External camera picture se dikhao how flawlessly I am doing that. Yeah. So it doesn't obstruct anything. It's a simple concept. It's not just some rocket science. Okay. So simple concept. You are holding the endoscope. You are using it as a third arm. That's all. And with your two hands, you can beautifully do the surgery. It's agreed you can do it with the single hand. There's no question. But everything cannot be done with the single hand. Tomorrow you will see those extensive cholesteatomas. Okay. And without using the microscope, how you can do that? So you need that holder. And it's not just as an holder. It need to be a dynamic holder where you can keep moving. Okay. Go in and out. So it's not just as a static. So just some granulations here. So we'll take this out. Yeah, better. So now cure it. I'm going to throw out that annulus, because in such situation, angled one. My all instruments are bent. This is not the, these are. So now how to cure it? Again, you have to rest. See, this is a dangerous again instrument going like this. Okay. It's not, it should not, you should not go like that. So just gently go inside. That's all. No pressure, no force. And for this, I have bent the instrument again. No, so this is a, see the angle given to this. Just engage, no extra force, that's all. And with the suction, take it out. Again, engage, out. No force, nothing. Corda.
So these instruments are bent with hand or a special instrument?
No, I have created the tools to bend this. Okay. So you have to create that tool. You can't bend this. This is very hard instruments. See, this is for the from up to down. And if on the other side, look at this bend. Okay. So this is for downward to upward like this. Okay. Just to show you. No extra force. Huh? Much work you can do with these instruments and these angles. So you need to create those tools to ease your surgery. That's all.
So if we get our instruments to you, you'll bend us and give it.
Flesh. No, we are in a process of developing this all instrument set for the two-handed endoscopic ear surgery. Believe me, I don't have a microscope in my OR. I have kept that microscope to teach my fellows that's a first tool to hold the endoscope along with the microscope. So both the things are at the one platform. Huh? Ajay, you must be knowing that. Huh?
Yes.
Yeah. Okay. Just to see.
So basically, what we have done is we have opened up the internal auditory canal over here.
Yes. We will go ahead.
Nerves. It comes up there, becomes the second genu. The first genu is over there, turns down, goes to the stylomastoid foramen. This is your digastric ridge over here. Okay. So there you go. So that we've dissected out the IAC. We are basically torn up the bone. All right, we are going to be completing our dissection here, and we will give the whole screen to Dr. Khan.
Dr. Gadre, fabulous dissection. You can hear the round of applause from the audience.
Thank you.
So, incudostapedial joint, stapedius tendon, anterior crus, posterior crus, anterior isthmus. There is an edematous area, so you are not able to see, but you can go just little bit inside and you can see. Okay. The mucosa is quite good. You have to see the mucosa over the promontory. If it is a nice, healthy mucosa, need not to worry about it. There is no block here. I will just show you how to open the tensor fold. Sorry. Yes, take this, clean. So if sometimes it touches to the, your endoscope gets, so just clean it. Clean. Otherwise, I hardly take out the endoscope. Only problem, if you are doing under the local, you have to support the head. Okay. Otherwise, if the patient moves, there is a chance that your endoscope might damage the middle layer. So be careful when you are doing with the endo holder and with the local anesthesia. But not to worry, your assistant can just support the head. And again, both the little fingers are on the patient's head. So you will come to know if the patient is moving.
So you're saying about removing a part of the annulus, and when do you remove those cases?
That's a good question. In such cases, just see if it's a large, not and almost a subtotal total perforation where the annulus is only remaining. In such cases, if you're just elevating and putting the graft, the problem is the mucosalization, because this annulus has got the mucosa on the medial side. So you are keeping the graft underneath. So that gives a trouble. Huh? So in case of the subtotal perforations, in near total perforation, I take this out and throw it. It's no problem, that hardly it makes a difference. But for the small perforations, medium central perforation, you need not to do, you can just go for the underlay, okay?
So this prevents post-operative myringitis and
myringitis, mucosalization. That concept is from Dr. Suri, huh? And we have done a histopathology of all annulus. So definitely on the medial side, we came to know that there is a mucosa. Huh? So best technique is to have an interlay. So this is nothing but but I use a cartilage, so it helps me nicely healing. There is a healing is a fast when you are removing that annulus, and even nice vascularization of the graft. Huh?
so in all cases you use cartilage, or in some cases your graft changes according to?
Only for the soldiers. Temporalis fascia, otherwise cartilage, because still the army doesn't agree. Take that cartilage, okay? I don't know why. There is no difference in audiological outcome. काय दिलंस? Caesar कशाला दिलेस ना? मला ball point नाही.
Yeah, you have nice paper on that, you know, the hearing outcomes post cartilage tympanoplasty.
Yeah. See how thin tympanomeatal flap is there, but you have to preserve that. See this? Huh?
Yes.
And you need to take care of the suction. Huh? Right suction. Give. Very thin.
What is the anterior superior limit of your flap?
Almost to 270 degree I have elevated. Now I will undermine it. I will show you. Huh? I have come up to the 3 o'clock. Huh?
Okay.
Hello, Mubarak. I am Dr. Vedi.
Yes, sir.
Suppose there is a anterior canal wall bulge. In such case, if you are saying the anterior canal wall bulge is more bony one, how you tackle with this case?
So for the endoscope, it doesn't make a difference for the if there is an anterior overhang. Okay, because the endoscopes are meant for that. You can go beyond and see. See, even there is an overhang here, huh? But still you can see. Go beyond that. If quite overhang, then I do a canalplasty in very few cases. Otherwise, you don't need that. See this, if I'll go a little bit near, I can overcome that. No need to do the canalplasty in each and every case. So let's undermine. So from here, I have elevated, I have undermined here, come up to this. And now this part is remaining. So let's
Are you elevating the annulus also, or?
now I'm keeping the annulus down, and then I will take out that annulus.
Okay.
Okay. Okay. So now we'll take out the annulus. This is our annulus. Okay. Give me the forceps. See that? Okay.
Yes.
Okay. Complete annulus. Then just bring it down. That's all. Out.
Very nice.
Yes. Now, see this. You can see the eustachian tube too. Yeah? See that?
Yes. Yes.
Okay. Do that. So we'll harvest the cartilage. Give me the.
So is it a routine practice to send the annulus for histopathology study?
Yes, because I wanted to see Suri is propagating this total annulus excision. Huh? So we thought that let's see whether if he's seeing that mucosa is there on the annulus on medial side. So routinely we started sending it, and our pathologist started reporting it.
Why
Yes.
are you irrigating betadine in between? Any?
This is 0.5. Okay. Since the COVID, I have become a fan of this povidone iodine. So whatever small infections are there,
Okay.
it is taken care of. See, this is the most difficult surgery I am telling you, type 1. When it fails, still there is no 100% result for this surgery. So there are many factors. So we are doing a lot of trials error to get that number. That's all. Give me the PowerPoint.
So we saw the IS joint was a little bit idiomatous. Do you use Dexa, Pledgets, or Cottonoids to topically to decrease that edema, or you flush the aditus area with the steroid solution?
No, I usually not, but whenever I see a typical allergic mucosa, if the patient is having the allergy in the nose, so in such cases, I definitely use a dexamethasone. Okay, but now what we are doing is now we are using. I will show you platelet-rich fibrin plates we are using. So that take care of many things. Still, we don't have a literature and the data to support that, but clinically we are seeing a good result with those PRF sheets, what we create from the patient's own blood.
So can you elaborate on that?
Yes, now they have taken out some 20 ml of blood from the patient, and we have centrifuged it at 5,000 rotation for 15 minutes, and you get that platelet-rich fibrin, and we create a sheets out of that. So these are platelet-rich fibrin, which has got a lot of growth factors. Lot of many dermatologists, many orthopedicians, they are using this for many things, right? So why not to use it? In the middle year, it is said whenever you are using the PRF or the PRP, it has got a lot of growth factors, and wherever you keep it, it has got the stem cells too. So it functions, or it takes the function of that tissue. If you keep it over the promontory, means it functions as a mucosa. If you keep it over the skin, it will take a function of the skin. So these are the hypothesis. We don't have a study, but clinically we are seeing a nice results, even in the cholesteatoma and all. So in such situation, see, keeping some dexamethasone and all, it will hardly help. This is due to the chronic infection, edema is there. So just put a piece of that PRF over it and put a graft, that's all. Give me the Xylocan. And as it is taken from the patient's own blood, so not to worry about anything.
Maybe later on you can show us that centrifuge machine, or if the technique can be shown, if time permits.
Yes.
The delegates would be interested in knowing about this more. This is something new.
Yes. See this. Already the sheets has been created. My staff has created that. See this beautiful sheet. This is like a stylus stick. Can you see that?
They are all centrifugal product.
Hello.
Yeah, what is this?
This is PRF sheets.
Okay.
Created from the patient's own blood.
Okay, just looking like temporalis fascia.
So this
This
is
create perioperatively.
Come again?
You create this perioperatively or preoperatively you make this?
Yeah, during the operation only they have
During the
created.
operation only.
Yeah. The anesthetists take out the blood and centrifuge it, and they give us this. In the next case, I will show you how it is done. Okay. They have already created it. So we will take the graft now.
Does the anesthetist charge extra for that?
No, my anesthetist charged me very heavily because for every case it's a general anesthesia. So
In Mumbai, definitely they'll charge more if we employ them for extra work.
Yes, but believe me, now that anesthesia has become so nice, they give fantastic hypotensive anesthesia. They maintain that pulse, so it's nice to work peacefully. Yes. Clean this. So we will harvest the tragal cartilage from a small incision. Yes.
So you infiltrate the tragus at the
Already it has been infiltrated. So keep outer 5 mm for the cosmesis. With this forceps, you can just protect like this. And then harvest as much of cartilage, because you can harvest around 1.5 by 1.5 in the adult. Okay. And the same tragal cartilage, we reconstruct mastoid and all. You need not to take out much cartilage. Tomorrow I will show you how to create a pseudomastoid with this cartilage and do the soft wall reconstruction and avoid the cavity problems. And endoscope has got the role there to avoid those things. So I'll show you how.
So this is a regular forceps which you are using to give traction on the tragus?
Yes, our routine non-tooth forceps. So with one stroke, go through the skin and the cartilage. This we don't want. I think infiltration role has over. There should not be any bleeding whenever you will be doing suction. Suction. See the beauty. I am looking at the monitor. You can see everything, cartilage, perichondrium. See this?
Yeah, very clear.
That's the beauty of the camera. So on a lighter note, why to trouble your eyes? Looking through the microscope. Gadre sir will hit me.
All microscopic ear surgeons will hit you.
But all the juniors must see this and this. Use the endoscope because it's there. I kartes. Use the endoscope because it's lying in your OR and suction करती थे दिसलं वजह है.
Mubarak, you have revolutionized endoscopic ear surgery in India. You know, what Dr. Patil, Dr. Murthy started,
Sure.
taken it to the next level, and a lot of youngsters are, you know,
Suction cautery law.
interested in doing endoscopic.
No, here I would like to give a credit to R.N. Patil sir because I was an avid criticizer of endoscope when I first arranged the endoscopic versus microscopic workshop in MIMER. Sir must be there. He knows. But I saw the beauty. Well, very patiently he's doing, and what for that fantastic view haunted my mind. But I was at that time only. काय करते सर 2 मिनिटं बघू दे मला
I remember I was there for that work.
You were there, sir?
Yeah.
So, but at that time, how the innovation started, at that time only, I tied the endoscope to the microscope because that was only the possibility at that time, and the concept of just attach came. And then I came to know, oh, it's so nicely you can do it. You with the endoscope and with that holding endoscope along with the microscope. And then I thought, why not then exclusive endoscope holder? Okay, and the things moved like that. So credit goes to Professor R.N. Patil.
He's here with us.
Yes.
Patiently watching your surgery.
Yeah. Because
Sir is praising your surgery.
Yes, he's a master. Yes, suction. Dusra lao. So I'm learning still that's patience from R.N. Patil sir.
Patience has a different synonym, Dr. R.N. Patil.
Yes. वो कुछ भी होने दो दुनिया में उधर. He's आराम से अपना देखते चल रहा है सर्जरी चल रहा है.
He's a very meticulous surgeon.
Yeah. See the perichondrium? Yeah, so yeah. इथे लाव एक स्किन हुक का कष्ट करतेस एवढं. Look at the beauty of this endoscope and this panoramic view. Yes, better.
So you preserve the perichondrium on both sides of the cartilage
Yes.
when harvesting.
Harvesting, yeah. Harvest as much of cartilage as possible because you have to create a good graft. You can create a shield. You can create palisades.
What care has to be taken when you are harvesting the tragus?
Just preserve the perichondrium on both the side and preserve this flap. Okay, any of the time this gets torn. So then that's a reason for your chondritis.
And anteriorly, if you go too anterior, then
No, you hardly go anteriorly. There's only some vessel is there sometimes that bleeds.
Okay, that this is a vein.
Vein. That's not a big problem.
Yes.
sometimes if you go too anteriorly, then you can enter the TMJ joint capsule. So that
Yes,
in
sir.
your early learning curve, you should remember not to dissect too anteriorly.
नहीं, उतना anteriorly जाना ही नहीं है.
Sometimes,
Yeah, yeah.
Hello, Mubarak.
Yes.
I'm Dr. Arshad from Bangalore.
Yes, Arshad.
See, about 2-3 weeks back, one of my
इसको
friend, Dr. Ravi Sachidanand, he uses cartilage in
हाँ.
Bangalore. I saw him operating in one of the local workshops.
हाँ.
He takes an incision there, like how they use for a parotid, no?
हाँ.
In front of the tragus, and from there he harvested the cartilage.
Okay.
Because I'm a head and neck surgeon,
Mm-hmm.
it's more convenient for me to take a cartilage from there. Anteriorly. He
Anteriorly.
yeah. Just like how they use for parotid.
Oh.
He says hardly any scar.
Okay.
Front. He took an incision. Yeah, I saw him taking it there and harvesting the cartilage.
But this is a hidden
in front of the
incision.
tragus.
So it is more hidden. You can do, but
Yeah, that's better.
rather it is a more hidden incision, so it is more preferable.
More of a head and neck surgery.
Can you share the mic so we can delegates?
But after harvesting, you have to cover the residual cartilage with the skin. You should not expose any cartilage. That is the common cause of perichondritis.
But with this, it hardly gets perichondritis. If
I have faced a couple of
avoided the damage to the skin.
Yes, if you should not damage the flap, skin flap.
So the idea is, I mean, there are people who do things in different ways. And another thing which I saw recently was one of the surgeon was advocating opening the antrum, the mastoid tip cell first.
Mastoid tip?
He opens the tip first. I think Dr. Subbaraidu, I think in. He opens the mastoid tip first, drills. From there, he follows it along the posterior canal wall to the antrum.
Okay.
He says, why do you want to struggle, marking those linea temporalis and, the spina Fenley and the triangle?
This all things should go now.
He's basically a cochlear implant surgeon. So he finds it more convenient to open the tip first, then he goes up along the posterior canal wall to the antrum.
With the endoscope, you should now.
Yeah.
Should not give now the cavity.
People doing different things different ways.
Yeah.
There's no hard and fast rule. That's what I'm trying to tell.
It's not always possible to expose the tip cell. Even very highly sclerotic mastoid, you cannot find. So it is, but if antral cell will find it even extremely sclerotic.
Come.
Once you export in, you can do in your own way.
Yeah, exactly. And just to go back to the harvesting of the tracheal cartilage, especially I think this is for the juniors there. One thing that you need to keep in mind is that we leave a small, strip of cartilage on the exterior aspect so that we don't, damage the contour of the tragus. Otherwise, it becomes very cosmetically unacceptable. So that's one thing that you should keep in mind.
Yeah, that's true. Just 4O or the 5.
The inferior sometimes it exposed. So you have to be careful after harvesting.
And you need not to take it out. किती number चा घेतला? 4 रखे. Just take a 5O. So you need not to take this stitch also. This is a 4-0, so that's. Exactly. So this incision is almost hidden. You can't see anything later on. See, I have preserved the cartilage there. Can you see that?
Yes, yes.
Yeah.
Some of the patient they complain they can wear this earphone after this cartilage harvested. Do you feel?
I haven't.
Dr. Khan, any patient have complained the difficulty putting this earphone?
No, not at all. Must be, now I am doing this for last 20 years. Just I have faced one or
Constant falling of earphone.
just perichondritis one that is due to the only damage to this skin. Otherwise, there is no problem. That may happen
Yes.
if you not preserve that
They
upper.
complain, doctor, I am facing problem putting this earphone because it's not plugging, not fitting properly. It's a constant. There is a 2-3 complaint I have received.
Okay. If you are not preserved the outer 5 mm cartilage, then that may happen.
Yes. That I. Yeah. Those patients I advise not to put earphone rather than you have to use headphone.
Anyway, headphones are better, isn't it?
Yes.
Noise cancelling headphones are better than earphones. Less noise, very strong.
Stitching this incision is good idea actually. It will prevent this cartilage exposure. It will prevent perichondritis.
Even they have given me a 4O. If you take a 5O, we will not see anything, huh? Yeah. Okay. Got please. We'll peel off the perichondrium on one side, and we will use create a shield graft. And I will try to, if it isn't quite big graft, then I will create a island. Give me the. So the cartilage divide of the perichondrium will be facing towards the promontory. So in a long run, many of the chondrocytes are lost and the graft becomes a very thin. Okay, that is what I have observed. So you need not to slice in such cases too. So it's more than, this is a 10 millimeter. So it's more than 10 mm. So I will create a nice island. Give me the. See, this is the perichondrium. The perichondrium, this is a good perichondrium, so I will be preserving that. This is with connective tissue, so I will be throwing out. But during the cholesteatoma surgery, I use this perichondrium too for reinforcing. See how to take it out.
Yeah.
Sir. बोला ना सर अहो काय सर गंमत करताय.
Dr. Khan, do you feel difficulty in harvesting and putting In the elderly patient, sometimes it's calcified cartilage, so it is brittle so much.
Yes, in many adults, you get that. If it is a too brittle, then I harvest the conchal cartilage. Okay, so you don't use that if it's a too brittle. Huh? See this is very nice cartilage. Huh?
Okay.
And the perichondrium is so nice here. So I'll create a island. I remember
You are peeling off for this convex surface of this cartilage.
Come again?
Convex.
Hello?
Yes.
No, I didn't get.
No, so you are peeling routinely this convex surface or from concave surface?
No, not concave convex. You have to see where the connective tissue is maximum. So take out that perichondrium. Otherwise, perichondrium is quite good.
Okay.
So I was telling you, my first Mentcon paper was this cartilage tympanoplasty. And I remember at that time I searched on the net and then I got a fantastic PowerPoint presentation and lot of information from one man that's called Professor Arun Gadre.
Okay.
So I copied that. I still remember beautiful diagrams, creating like this perichondrium, island grafts, palisades, and everything. Still, that PowerPoint presentation is there. Yes. So myself and Swapna has copied that, so you have described that all, everything in that beautifully. So those, I am just doing the innovation based on that. Hello, sir. It's all. So now, taken it out. And then you can use this also pericardium for the small perforations, okay? That's all. Yes. So now we'll create an island. This is a small defect, need not to worry. Yes. Mala clean kar. Circular. So this part will go anteriorly, this will go posteriorly. So I'll create a island. So just putting a cartilage as an graft is not a tympanoplasty. You have to craft it nicely. And full thickness cartilage has got definitely some problem. But if you put a cartilage like this, over the period of time, it becomes very thin, okay? This will be facing the promontory and a few chondrocytes are lost. In the revision cases, I have seen that again and sent for the HPR, it will become very thin. But if you preserve the perichondrium on both the sides, that cartilage works forever. सर काही बोलायचं याच्याबद्दल सर तुमचं कार्टिलेजच्या बद्दल बिकॉज यू हो सर still our army doesn't accept this, but I think in USA there is no problem for them for cartilage all the time, no? Yes, Germany all the
What is the size of your island?
Yeah, that's here 10 millimeter I am keeping See this is a down to 10 millimeter, okay?
Okay.
So this will take as an
As malleus groove.
malleus, yes. Okay.
Yeah, perfect.
Yes. So if it is a bigger one, we will again sculpture it. Ela ह्याच्यात ठेव. Put it in the graft press so it becomes a nice again. So let's go. This is a nasal pack. Merosil, soaked with adrenaline. Because the cotton plate, you leave behind many of the time the lint. Yeah. Photosuction. Flush.
Is very good.
Good.
Yeah. Mubarak, there's a question.
Yes.
From here, we can see that, we're not able to see the anterior part of the middle ear well from here. Can you see it from the screen on your screen?
I will show you.
So, the flap, we can see more of the flap.
No, I'll show you. Yeah, normal. Ball point. नहीं ये पकड़ बॉल पॉइंट. Can you see now?
Yes.
See this? This is the body plate separating the carotid, and this is the eustachian tube. Little bit of bleeding, it's no problem. We will just do the suction. See this. Okay. See this? Okay.
Yes.
Ajay? Yeah.
Yeah, very nice. Very
Yeah,
beautiful.
good.
You can see.
Yeah, see this eustachian tube, everything. I will just show you how to open the tensor fold. I have apna cobra do. Again, those are two angles which has been given to that peak. Kela is just to ball point. काय आहे की नाही कुठे?
एमआरएमच्या डब्यात आहे. हा दुसरा कुठला?
नाही ना, हा नाहीये.
तोच पाहिजे.
हा नाहीये. This is not this.
हा तो एमआरएमच्या डब्यात आहे.
अरे तुमने रखा नहीं. So this is the area actually. So you have to give the two bends. They have not kept in this area. I'll show in the next. So you have to just hold it and just rotate like that. So you can open the tensor fold. That's all. This is not the right instrument. So give me the circular. ठेवायचं ना एवढंच रांतल्याचं. काय कसं
एमआरएमच्या डब्यात ठेव.
काय करू एमआरच्या डब्यात आज आहे का एमआरएम?
काढते सर ते.
दुसऱ्या केसला का?
पलीकडे
So just this is a yes. So that's better. Now force it. 5, 6, this is 5, around 9. So let's. Even if the mucosa is lost sometimes during the adhesive otitis media, I use that PRF sheets. Okay. Just give me the cartilage. We will see how it fits. Another दूसरे ओटी में ये कर सकते हैं अगर प्रेपा हैज कम. ग्लोमस के लिए कहा? हाँ हाँ दिस टी प्लास्टिक को ले लेंगे उधर लेकिन उसका अरे I will just assess if it is a big one. I'll modify it. Sickle.
Inauguration ceremony.
अब देखो क्या का इनॉग्रेशन जबरदस्त. I think this will fit perfectly. So I have to just rotate it. See the importance of taking this 270-degree. So it will go down. Don't push it much. So this flap will come. If this is a curve one, we'll just see after reposing whether it's fitting perfectly.
You made a notch for the malleus handle.
Yes.
And the cartilage is resting lateral to the malleus.
Yeah. Very thin. See, it's perfectly fitting, okay? I will. एक एब्जिल सिकल में I will rotate a little bit because there is a small gap.
Mubarak.
Yes.
Now that cartilage is bare, or you are going to keep that perichondrium which you have taken out over this cartilage?
What, sir?
This cartilage is bare now to the exterior, or you are putting something over it?
Over?
over this cartilage, what we are seeing through perforation, you reconstructed by the cartilage. Okay, now cartilage is there, you are putting that PRF over this.
Yes, over this, yes.
Okay.
So these all small things is taken care.
And,
it has
and
become.
now means you are not using temporal fascia nowadays?
No, only for the soldiers.
Okay.
So this has become a little bit dry. So use the ab gel. And this flap is very thin. So
Mubarak, there's a question.
yes.
Anterior, inferiorly, we can see a small area which
Yes.
is still deficient.
There's no problem for that, I'll tell you. Because what happens, you have taken out the annulus, and when you are putting the PRF, I'll show you. This was you're telling about this, okay?
Yes.
So I have to level this flap and it will come over it, and need not to worry for that. Now you can adjust from here.
Can you put this perichondrium over there?
No perichondrium and all. I will show you. I'm putting the PRF sheets there.
PRF platelets.
Yeah.
But Mubarak,
yes,
if part of the cartilage is actually, touching the canal wall, bony canal wall, will it not hamper the vibration, conduction of sound?
Hardly it makes a difference. You are talking about this, no?
Yes.
Yeah. So I'm just seeing whether to make it little bit smaller so that it will go this part. This part you are talking,
Yes,
right?
yes.
You're right. So I'm just judging that now. I'm taking out little bit of cartilage so that it will go, and only the perichondrium will be there. Give me the circular. Yeah.
Sir will reach in 10 minutes.
Yes.
We have few faculty has arranged for
ठीक है ना.
So after that we'll start global.
चालेल. No issue. Okay, this is
Yes.
piece.
A little superiorly also required.
Definitely we will do. Don't. So just do everything gently. That's all.
Snugly fit. Yes.
Yes. Now it will go. Suction चालणार द्या ना जरा. मीरा. Suction चालणार. Yes. Now it will perfectly fit, right? Take this out. थोड़ा सा क्लीन करना चांगलं रेझर आणि सक्शन चेंज. नाही क्लीन केलं. त्याला लाव ना जरा काहीतरी श्रावला नुसतं घासू नकोस त्याच्यावर. हा. हे बघ. Now it's better. Little bit from the up. Still I will take out. Don't push much. Just simply take that out. It will come like a cutting your cheese. Slowly and gently. Yes. That's better now.
Yes, much better.
Yeah. Yeah. Now let's go. Give me the ball point. चला fast. काय शोधायला लागलं instrument आहे. Now that's better. And this flap will come here. Okay.
Yes, yes, perfect.
Yes, that's nice. Now that's good. Huh? And even this will take care of whatever small flap which is lost tympanomeatal flap. Okay. Is it okay now?
Yes, yes.
Gadre sir, kuch sir opinion sir. Gadre sir. Nice slide. No, I didn't use this. Yeah. नहीं इसको आइलैंड और ये किया इसका हाँ हाँ तो बरोबर हे now it looks better. Okay, give me Abgel soaked in the you have to keep a 0.5 or more, then it will not curl, otherwise that's yes. Very thin skin, but take care. So in a second case, this is, I've done it very slowly so that we'll understand the things. Then in the next case, we'll try doing some different thing. Okay. Now PRF. Platelet rich fibrin. So because this skin is something unique, this is a migratory thelium. So dermatologists use it for the rejuvenation of the face on the skull. Why not here? It has got a unique function. Now it looks better, sir. Okay. Khageshwar?
Yes, perfect.
Looks good. Any suggestion? Ajay?
Can you zoom in a bit and show us the anterior edge a bit more?
Why? You go inside, take this here, okay? That you're worried about that small, right? Small
Yes.
anterior inferior. Need not to worry because there is a cap is there. Now I will put a PRF over it. See, 3/4 of the perforation margin has to be covered by the graft for the nice vascularization. That small thing doesn't make a difference. See this, okay? Even you will see small gap there, but need not to worry for that. If this whole flap is covering the cartilage, nice vascularization is formed and this skin grows over it.
पण ती आतमध्ये नाही जाणार स्किन त्या खड्ड्यामध्ये.
नाही जात. अजूनपर्यंत नाही गेलेली 20 वर्षात.
So I asked him if the skin won't migrate inwards into that defect. So he's saying no, it doesn't.
इसके लिए तो बोला ना वो कार्टिलेज बढ़िया काम करता है कोई यस थोड़ा सा पहले जो फेल्यूर होता था वो भी अब कम हो गया है थोड़ा सा ये पीआरएफ की वजह से ओके सो आई विल advise try using the simple
how
thing.
to put this PRF? Are you elevating the flap and putting the PRF?
No, now here it is not needed, but if the mucosa is lost, if there is some what you can call tympanosclerosis.
Can you please some piece of perichondrium our audience asking? at the little defect area. Can you put?
No, I'm not going to put anything there. Okay. I'm not worried about that gap. Huh? We will ask the DY Patil team to post the post-operative result. Okay. Yes. So, see, this idea came from Germany because Robert Milinski uses a lot of silastic. Wurzburg has gotten good research on the silastic sheets, putting over this tympanomeatal flap. Initially, I used to use a lot but it's very costly. The blue silastic sheet. Their research say it nourishes the tympanomeatal flap, and under the silastic small silicon sheets, the squamous epithelium grows very nicely. So now, based on that, we have created our sheets. Patient's own blood, platelet-rich fibrin.
PRF. Okay.
PRF. ये छोटा yes nowadays वो 1-2% और बढ़ गया result. सर ये सिंपल है, ज्यादा कुछ नहीं है.
Are you putting overlay or underlay?
नहीं, overlay over the skin. क्या ग्राफ है? Yeah. Centrifuged. Yeah. And it has got lot of growth hormones. Lot of research needs to be done because we don't have a data, but clinically we are seeing a good results. Huh? Nice healing, well functioning skin.
Yes.
ये देना. Ballpoint. Even if the bare bone is there, so it takes care of that. And in mastoid, I am seeing a very fantastic results. So wherever I am doing the reconstruction, even for the ossiculoplasties, I am covering this, whatever cartilage ossiculoplasties I am doing, cover it with this PRF. Survival is becoming very good with that. And it comes free. It's patient's own blood. Just you have to take some time and centrifuge it and create.
Send the blood at the start of the case?
Yes.
What is the longevity of this PRF?
It dissolves in 1 week.
Okay.
These are platelets. These are nothing. These are platelet sheets.
And fibrin. Okay.
Yeah.
Perioperative period you prepare or before?
During the operation only. During the operation. The anesthetist does this, or our Rafiq in the OR, he makes that. Okay? Rafiq. Or Mira.
Mubarak,
Yes.
about the hearing result post-operative.
Yes, sir.
Because whenever we thought about the temporis fascia graft or fascia lata graft or only the perichondrium, We
Yes,
think
sir.
about the millimeter thickness of the things there. A normal tympanic membrane thickness is that. Now
Yes, sir.
here the cartilage is much more thicker. So
Yes, sir.
vibration point of view and sound transmission point of view, how was the result compared to the other thin material which are mimicking the temporis fascia?
Sir, absolutely there is no difference. Previously, whenever I was putting the full thickness graft with a perichondrium on both the sides, there was a problem. Few patients used to complain the tinnitus, heaviness in the ear. But after doing the slicing of the cartilage and the putting the cartilage like this, dry the mala, there is hardly any difference. Okay? It's comparable results.
In how much time does this PRF epithelize?
No, this dissolves. This gets dissolved in 1 week. So the idea is to provide the growth factors for that sensitive skin. And if you are putting these PRF sheets inside in the middle ear, so it functions as a mucosa only. That is an idea. That's an hypothesis. Okay. So it has got the stem cells to hypothesis. I don't know. Research needs to be done. Dry. But definitely the literature from the dermatology is quite interesting because they use it for the rejuvenation of the face and for the scalp, for the hairs. So there's a lot of literature from the dermatology. Dry. So why not to use in the ear?
Dr. Mubarak?
Yes.
Taneja this side.
Yes, sir.
Yeah, I'm using this plasma for the last few years, and we have got couple of publications. But your technique of making a fibrin is different, but platelet-rich plasma has got definite role, and we have got more than 6 publications published in the Journal of Otology.
Yes.
And it gives a wonderful results. Practically, after using platelet-rich plasma, I can say my results of tympanoplasty are almost 100% in terms of accepting the graft.
Sir, वो 100% से थोड़ा डरता हूँ मैं, sir.
Yeah, almost. I'm not saying in terms of hearing. I'm saying in terms of and whenever you get secondary perforation on 8th day or 15th day, just put a platelet-rich plasma, 2 drops over it, and it heals well. You get 1 mm or 2 mm perforation. In some of the cases, even those heal well. And for the last few months, I have started using a second dose of platelet-rich plasma on 8th day and stopping all antibiotic and everything. I give 1 shot of platelet-rich plasma in endoral region and post-oral region. Perhaps that's giving me good results.
Lot of research needs to be done on this platelet-rich plasma and the ear, even in the nose, because the idea came from Dr. Sapna, because she uses a lot of these sheets, creating these sheets in the rhinoplasty. Okay. So I thought that why not to use, because then I remembered Wurzburg. Those stylistic sheets can be prepared like this. And then I saw clinically, because I completely work in a private. My all patients are paying. So every time I'm searching that how it will become 99, because 100 is not possible. So this is giving a good result to me. Even for the traumatic perforation, a simple, you can take blood and put this sheet over it heals faster. That's all.
Yeah, just after freshening the margin, it
no freshening, don't touch. Just work back that perforation margin and put this stylistic sheets, the PRF sheet. and the healing is within 1 week.
Mubarak,
Yes, sir.
I'm Dr. Vedi. As you are talking, more and more research should be there, and you are using all these things, so it is okay. The results are there. But few people nowadays, they are claiming that they are reversing the congenital hearing loss and many sudden hearing loss by this PRF.
No.
This thing should be first. They should research. They should.
There is no basis for that. Huh? There is no basis. Even I am using this by taking the support of lot of research from the ortho people, orthopedics, and from the dermatology, because they are using this, and their idea is to have those growth factors and the stem cells. But I don't think that for that congenital hearing loss and what sudden sensory neural hearing loss, I have not seen any literature in a good journals.
Yes, that is the message I want from your conference also.
Yes,
because
yes.
I don't want to quote the name from our region, but people are just saying that without going for that cochlear implant, that doctor is doing the things with this, the same blood, and we will get the result. So
Absolutely not, sir.
Such things should be stopped by all our association and all in this. Yes, if research is showing all the things are good, then why not? But
True, sir. True.
We should.
Yes, sir. So thank you very much, sir. Dr.
Thank you, Mubarak.
Sir, Ajay,
Yeah.
Yogeshwar.
Very nice demonstration.
Yes. So I think there
Very
is
excellent demonstration. You can start the applause.
Yeah, good.
Dr.
I would like
Mubarak,
to
Dr.
call on-
Mubarak, Dr. Mubarak, since time is there, I think you can explain the technique, how you can make platelet-rich fibrin.
What, sir?
How you make this fibrin? You can your staff explain it?
Yes,
can
yes.
you can
So you
re-explain that.
you have to draw the 20 ml of blood depending upon your requirement. For the mastoid, I need a 40 ml of blood because I need a lot of sheets there. So draw 20 ml of blood, keep it in a centrifuge. We have a centrifuge in our OT. A simple centrifuge machine comes at around some 11,000, 12,000 rupees. I will show you that machine. So you keep those 20 ml of blood in those tubes and rotate it at 5,000 rotations for 15 minutes.
Okay.
And you get a complete platelet-rich fibrin separated from the RBCs. So take out those platelet-rich fibrin and then press it.
Okay.
You press it, you will get the things like this.
Just
do you in the next case, I will show you how that platelet-rich fibrin look and how we press it and make it. Okay.
Just one question. When you withdraw the blood, do you add anticoagulant to it or do you
No, nothing. No anticoagulant. No anticoagulant. Immediately you centrifuge. Okay.
Okay.
Immediately you have to centrifuge during the operation only. You withdraw the blood and centrifuge it and create the platelet sheets. No antiplatelets and all.
So practically, you will be getting from out of 20 ml, approximately 8 ml of platelet-rich fibrin, isn't it?
Yes. So 20 ml, you will get a nice upper half of the platelet-rich fibrin and create a sheets by pressing it. That's all. That's very simple.
I would like to call on stage Dr. Jeevan Vedi sir, Dr. Sanjeev Kumar sir, Dr. Ajay Doipode sir, Dr. Khageshwar Rao sir, and Dr. NVK Mohan sir. I would like Dr. Prakash Kulkarni sir and Dr. Sachin Patel sir to facilitate all of them. Sir, please sir, on the stage sir. We need a photo with you all.
So Olympus people have provided this fantastic system that's a 4K And it's really fantastic to work on this. I hope you must have enjoyed the beauty of that endoscope and the camera. So it has got a lot of features like an auto focusing, and then everything is a digital one. So it is just the cost is a little bit higher, but it comes in combo. It's about 60 lakh, but it comes with a monitor and then camera unit, light source, and the endoscope. So this is a whole package. So that's in 4K. But the HD system, I think it's a little bit lesser, around 25,000. That's also is good. You will see that during the Daniel, when you will be doing the cadaveric dissection. So you will see that. And then we'll compare it with the Aquino. Let's see, let's judge how you can see the endoscopic cameras and what's the difference between 4K and SD. Yeah. Yes, thank you. Yes.
Okay, so now we have some lectures lined up.
Yeah.
I would like to call Dr. Dhruvo Roy, sir. And the chairpersons for the session will be Dr. R.N. Patil, sir. Please, sir.
things, and we used to think, okay, this is the what middle ear surgery is about. We used to see, we used to do dissections. We used to, first thing in the first year, last months of first year is you denude the male ears. So these are the things which happened to us. But then I had heard about my master class, and I came to Talegaon. And this was the time when we saw endoscopic ear surgery by Mubarak sir and Sapna ma'am. And that changed us. This is the first picture I took, which was the picture of endoscopic ear surgery, live surgical dissection in the master class. So that was the first time when I started to see the anatomy of middle ear very clearly. It changed what I thought of the middle ear. I mean, I used to only read about and see the pictures of Procerus cochleaformis and all those things. But in the microscope, in the normal microscope, which most of the medical colleges have, it was not very clear. So first time I saw these things clearly, it was in 2018, I think. That was the time when I came to Talegaon first time. And that actually made me think, should I take the jump? Should I move to and learn endoscopic ear surgery, or should I go on with my microscopic ear surgery, which was a norm that time? We did dissections here. Dissection is the most important part. We all think that, okay, we are doing microscopic ear surgery. We all are trained in microscopic ear surgery, and we also have done multiple dissections using microscope. So we suddenly, if we think that, okay, we'll be experts in endoscopic ear surgery, that's very wrong. We have to have dissections in endoscopic cadaveric bone dissections also. We have to practice on the endoscope with the cadaveric bone, like we have practiced in our residency days over the using the microscope on the cadaveric bone. So dissection is very important. First you do dissection on the cadaveric bone, and then you go to the patient, even if it is the residents or the senior faculty who are trying to move on to endoscopic ear surgery. Dissection is very important. It gives you a very good hand-eye coordination in the ear. We all are good in nose, but in the ear it gives a hand-eye coordination. So dissection was very good, and we used to dissect for hours on that time. So that gave us confidence that, okay, we can move on to the patient. Now, endoscopic ear view offered, as the previous people have said, capability of wide field visualization with minimal exposure, and looking behind the obstacles or overhangs and seeing into the recesses which require much less surgical exposure than demanded by the conventional outside-in approaches. So from here to here, this was the view which endoscope gives. Microscope gives a tunneling effect if we do not go by the post-oral route. But with endoscope, we bypass all the obstacles, and we see a bigger picture, bigger field of view. So this was the picture which I took in my residency when I was first doing second year or something. And this was the picture when I used to do my endoscopic ear surgeries. So difference is wide. As a resident, as a fresh consultant, if you start doing these things, the difference is very much. Now the beginner's plight, being trained in the microscope in residency, I was far more comfortable with doing surgeries with microscope when dealing with ear or larynx. So if we all have a particular habits of doing things. If we are trying to wear a trouser, if we have a particular leg which we first put in. So if you can go today and know that which leg you try to do first, and then the next day you try to do the opposite leg, you will be very uncomfortable. You will even can wobble and fall down also. So try this, and this was the thing which we do when we try to shift on to the endoscope from the microscope. So there was a bit of hesitancy in me also. So I started with a combined approach. I started doing with the microscope, and in between, I started to use endoscope in that. These were the first few cases which I started doing. I used to do microscopic ear surgery, then I used to put an endoscope and do remaining work in that, whatever I can do. So these were the first few cases. The problems which I faced initially, there was a lack of three-dimensional view. Three-dimensional picture is not there because the microscope gives a binocular vision, and I had to rely on my motion parallax to access the depth perception. So there is a bit of depth perception problem. And also, if there was a problem, if cave selection is not correct. the canal is very narrow or curved canal. So there was some difficult cases initial. These are the initial problems. And also, just sir said, I used the light source on the 100% capacity, and I charred a TM flap in that. So later I asked sir, and he said, okay, you push it to 25, 30, 40%. So that was the time I learned a new thing. And space for instrumentation was very less, because our conventional instruments, sometimes they do not work well in the narrow canals, and camera quality, we don't have camera sometimes, and endoscope and the screen issues are there. So these are the initial problems. We start with this graph. First, usually I was clueless. I didn't know what I don't know. And I used to think, okay, it's an easy thing. If I can do with a microscope, why can't I do an endoscope? Then I was very confident in my initial few cases. That's the beginner's luck. Then suddenly there were few difficult cases. So I was very discouraged. I thought my microscope thing was okay. Why should I go for an endoscopic thing? But gradually, if you keep pushing on, then there's a phase then when you start to learn. And then you go on to achieve the mastery, which our masters are. So this was the first initial setup. I used the just attach first one, which was initially launched by Dr. Khan. And the good thing was, when you teach, you learn. I started with my residents, my junior residents, my juniors. I told them, okay, I'll do, you also do. We both will mix up and do things. Sometimes they were doing, sometimes I was doing. So I was able to say if they are doing some things better than me, because everyone has a different hand. And also they were seeing me doing the surgeries. So it was a give and take thing. We both used to do, and it was with few time, after around 3-4 months, we both were well versed in that. So the learning curve in microscope, you start to learn very early, but the endoscope, it's a steep learning curve. You take time, but in the end, you do your thing properly, and then you reach the same place. But it is very important you don't lose heart in the first phase of this endoscopic learning. Gradually, I realized that using endoscope, it has made inside out technique easier for me. I started avoiding post-oral approaches even in the narrow canals. I used to preserve the anatomy, normal anatomy, better than before, which I was doing using the microscopic surgeries. And conventional canal wall down surgeries, they have decreased now. I used to do a lot of canal wall down when I was a resident, third-year resident in SR, but now they are very less. And now, restoring the normal ventilation route, I am more confident that I have restored the route better now, and I can assure patient it will be fine now. So slowly, you tend to better your anatomy. You go on from first few initial hesitant cases to do a more difficult cases. And then you start to teach also. Benefit curve of microscope and endoscope. Now, if you do the things gradually, you go on and you benefit more from the endoscope. Now patients know, now every day now patients come, they say, we want a scarless surgery. We want a surgery for the forces. We want to go for surgeries which do minimal suturing. So that's what endoscopic surgery is about now. So you go on for benefit, and the benefit is much more than a microscope. But at some point, you have to make a balance, which you want to do, which you don't want to do. I now select initial, these were the initial 5-4 years. I select cases with relatively wide canal and straight canal. These are the points which new residents and the people who are trying to shift onto the endoscopic surgery should remember, that select cases with a relatively wider canal and straighter canals. So you are it's easier to do your surgeries, and you use a Tarabishi suture. You can do your own modification in the suture, like we have seen in the surgery during today. Dr. Mubarak used a Tarabishi suture. He used a single suture, but sometimes he used a double suture also. So modified Tarabishi suture. Sometimes people put a third suture on the tragus also. Sometimes we try that also if the canal is very narrow. And irrigate, or you get irritated. Keep irrigating, don't worry. There was some people saying that why do you irrigate the canals so much? But please do as much irrigation as possible. Your endoscope will be cooler and your endoscope will be clearer. There will be no fogging. always examine the retrotympanum, epitympanum, hypotympanum using the angled endoscopes. It helps to keep the last finish of the work. Examine the antrum after doing inside out surgeries and see the extent of disease, and please follow the disease. This is the main dictum using the endoscope. You have to follow the disease, stop where the disease ends. You don't need to go further away than that. You know that the disease is still there only. Please leave the anatomy, rest of the anatomy as it is. Do not play with it. Access the oval window, round window, and the suction tube opening. These are the areas which we sometimes tend to forget. Please see these areas, see any disease there, and clear that. We have to change, adapt, shift, transform. This is what surgery is all about. You can't be very fixed. We have to be flexible. And gradually, we have to add in our arsenal. We have to see what we can do new things in the surgeries. From tympano, from myringotomy, tympano, mastoid, you can gradually shift over to stapes and more things. But sometimes if you are stuck, please don't be very rigid. You be flexible. You can shift back to the microscope. That is a very good thing with the just attach, that you use it on a microscope. So you have a microscope ready at your hands. If you are having some trouble with the endoscope, you can just switch on the microscope and you have a microscope there. So just attach gives you that flexibility. These are the few cases which I had some problem and I had to shift from endoscope to the microscope. So you have to be flexible in that also until you are exclusively doing your endoscopic ear surgeries. Go back to your dissection table again and again. We never learn everything at once. We have to go back and back to the endoscopic dissection table. We have to keep on doing dissections and doing better anatomical understanding. And we make up targets. Next 6 months, I'll be doing my mastoid. Next 6 months or next 1 year, I'll be doing my stapes endoscopically. So we have to make targets and we have to see where we are in that growth curve. Either we are lagging or we are on that schedule, because sometimes we tend to keep on being in a comfort zone. We think, okay, we are now doing tympano, I am happy. Now we are doing inside out episiotomies, we are happy. But you have to keep on adding your targets. Okay, my target for 2020 is I have to do mastoid surgery. 23 is mastoid, 24 is stapes. So you have to move on that. There's always an old way and there is always a new way. There is no right or wrong way of doing things. So please, you just follow your whatever you want to do, but you do it in a better way than your previous generations have. That's how we add on to our specialty. Thank you.
Thank you, Dr. Amit, for sharing your experiences. I request Dr. R.N. Patil, sir, to felicitate Dr. Amit Rana. I call upon Dr. Dipen Dave, sir, for his presentation, Journey from Microscope to Endoscope. Dr. Dipen Dave, sir.
Good afternoon, everybody. Myself, Dipen Dave. I am senior ENT consultant at Nadiad, which is birthplace of Sri Sardar Vallabhbhai Patel. I am practicing there since last 25 years. Next. Slide. I have done more than 1,000 microscope ear surgery in initial 20 years of my practice. I have done all type of canal wall up, canal wall down, even combined approach, stapedectomy, all was done in 20 years of practice with microscope only. And in 2018, I come to know that Dr. Mubarak sir is also doing a good endoscopic ear surgery. And I met him in one Gujarat State Conference at Diu. And I find out that it is very good working. So I come to Talegaon for this fellowship in 2018. It was 9th master class. So I learned this endoscopic ear surgery from Dr. Mubarak sir and Sapna madam, and then started at age of 48 years. At age of 48 years, I started endoscopic ear surgery in my private setup. And then initially I started my private setup around 50% of failure rate was there. I use cartilage pericardium graft and even in some patient temporalis fascia graft. But again and again I have to learn. So I come in 12th master course in Dr. Mubarak sir's setup. Then I realized I have so many mistakes during endoscopic ear surgery that makes my failure rate very high. So I started correcting all mistake that was some everybody knows eye and hand coordination, fogging of this endoscope, that putting endoscope in proper way. That all thing I again and again by seeing my own videos, I realized that we can do it. And so since last 5 years, I am maximum doing endoscopic ear surgery in all tuber-tympanic cases and few selected cases of aticoantral disease. Failure is not trying. So we should try again and again, and we can also get good result. One other thing which I felt in my journey, microscope that I was using since 20 years, that was I was going to upgrade, and that was costing around 8 to 10 lakhs. So I purchased a handhold of Dr. Mubarak sir, that was only 1 lakh. And endoscope, everybody is having that in their setup. So I think endoscopic ear surgery is also quite cost effective for initial beginners, because if you purchase microscope and then you start microscopic ear surgery in your setup, that will cost around 10 to 15 lakhs, including some other instrument also. So this you can get in within 5 lakhs of cost, everything, monitor and camera and everything. And that can be used also in another surgeries, nasal surgery, oral surgery, everything. So I think it is quite cost effective. At least then another thing, it is also we can discharging such patient in same day. That is only day care procedure, and it is also, everybody knows it is scarless. So patient is also having good post-op feelings. And now after doing so many around 100 endoscopic ear surgery, I always prefer for beginners to learn endoscopic surgery rather than only microscope surgery. And for beginners, if they do some practice on cadaveric dissection, everything, that is also beneficial for them. Thank you very much.
Thank you, Dr. Deepen, for sharing your experiences. I call upon Dr. Santosh Shivaswamy, sir, to please felicitate Dr. Deepen. Rajendra Bora. Rajendra Bora, Santosh Shivaswamy, Arun Patel.
I would like to call Dr. R.N. Patil, sir, Dr. Rajendra Bora, sir, and Sir Santosh, sir, also you. I would call Kulkarni, sir, to facilitate all of them. Okay, camera. I'll take a picture. So we declare a lunch break right now for about an hour. We have a screen already downstairs. So as and when the live surgery start, you all can watch from there also or come here. Okay. Thank you. Thank you, sir.
सर आपके जैसे फोन आ रहा था कोई
Yeah. Hello, OT, can you hear us? Yeah, hi, sir.
Hello, hi, can you hear us?
Yes, yes, very clear, sir.
Do you have a pen? We are waiting for the endoscope to come. Can you sorry? I'll just go through the scans very quickly while we wait for the endoscopes to come, yeah? So this is a glomus tympanicum. So if you look at here, sigmoid sinus, jugular bulb, sigmoid sinus. So how we differentiate from a jugulare and a tympanicum is the jugular bulb here. So the jugular bulb is not enlarged, then the glomus tympanicum. The best glomus tympanicum to do are the small ones. Unfortunately, this is not a small one. It's quite large. You can see the entire middle ear space is filled with glomus tumor all the way maybe to the attic. This part, I'm not sure whether it's a fluid or tumor. So this is going to be a bit difficult and tricky because there is no space for us to go at all. So it's not the best case for endoscopic, but we shall try the best we can. The other structures are quite normal, as you can see. The superior semicircular canal, subarcuate artery, the lateral semicircular canal, the IAM, the geniculate, lateral semicircular canal, malleus incus, the facial nerve coming across. The others are quite standard, but usually it'll be quite nice if we have some space. Here you can see the tumors actually going to the eustachian tube as well in the anterior part here. The ossicles, although preserved, you can see are displaced at this part here. So that there will definitely be a conductive element. And you can see how the tympanic membrane is literally bulging here because of the tumor. So which means that most likely the tympanic membrane will have we cannot preserve the tympanic membrane in cases like this. So while we're still waiting for the scopes all to arrive, and we'll get back to you once the endoscope system arrives and we're about to start. Any questions about the scans?
Yes, sir. Yes, sir.
All right, thank you. Thank you.
Hello. Can someone please brief about the history of the patient? Dr. Rashmi?
I scrub, yeah? I go scrub. We have the monopolar suction. Good.
Hello? Hello? Dr. Prepageran? Okay. No, he went for
Now is the case of a 44-year female, case of left glomus tympanicum. She had complaints of tinnitus from left ear since 2 years, which was insidious in onset and gradually progressive in nature. It was continuous, pulsatile type. She also had complaints of left ear reduced hearing since 7 months, which was insidious in onset, gradually progressive, and the patient could respond to normal conversational speech but couldn't hear whispers. On otoendoscopy, a red mass was seen behind the tympanic membrane and the external auditory canal was congested. On HRCT temporal bone, a well-defined enhancing soft tissue lesion along the medial wall of the middle ear at cochlear promontory and extending to epitympanum and abutting the incus and malleus with focal erosions of bony facial canal was seen. Mild indenting along the eustachian tube canal, no erosions of walls of the inner ear or cochlea was seen. This could represent the paraganglioma. Changes of left side chronic otomastoiditis with secretions or fluid in the left mastoid air cells antrum, middle ear cavity with erosions of handle of malleus. No obvious significant abnormality was seen in the right temporal bone and both inner ear. On pure tone audiometry, 30 to 35 decibels of conductive hearing loss was seen. Now, I would like to request Prepageran sir to continue. Thank you.
You want to take out the head ring? No. You want to take out the head ring? No, we'll try.
You want to remove the head ring?
It's okay.
Put the head ring.
We will try. We'll try and see how it goes. Is this sterile? No. Is this sterile? No.
No, we'll covering it with the microscope.
Okay, understand.
After everything is fixed,
Cover
we'll cover it.
I see. Okay.
But first light to cable.
Yeah, you can see that. नहीं क्वेश्चन पूछना है ना वरना देख के क्या फायदा
कई टाइम की जगह बढ़ गया थर्ड डे और सेकंड डे थर्ड डे
वो घूमने जाते हैं ना they come there only for roaming around they're not interested in the program actually
दीपक मुझे बोले एक दिन के लिए जाकर आएंगे मैसूर में था ना मैं इस कपड़े भी नहीं लेकर गया अंडरवेयर भी नहीं है मेरे पास
Yeah. Can the scope camera system go here a little bit? I think this is the other way around.
Camera is
Okay.
hello are we connected not connected hello
Can you make the view a bit bigger? Hello, hi. We are just adjusting the scope holder. Okay, that's fine.
You'll have to fix it.
hello sir hello
Yeah, okay. Let's cleanse first. So how do you? Yeah.
Okay.
How do you make it bigger? The image bigger? No. Can you guys hear me?
yeah
Okay, so I'm using the, I see, the Aquino system as well as the endoscope holder by Professor Mubarak. So
It's the irrigation.
let me just see whether I can get the.
would this be a class B or class C tumor
Sorry?
would this be classified as a class B or class C tumor
I've got no idea. I just know how to operate.
seeing the city
I've got no idea what class tumor is this. I just know how to do the surgery. Okay. So let's see. Okay, so I'm just looking at it, whether we have enough space in the ear canal. Okay, good. Okay. Infiltration. I'm just getting used to the system. Small suction. Okay. I'm just getting used to the system. And let's try with this endoscope folder, yeah? Okay, so this is not easy. Endoscopic glomus is never easy because of the space. So first time I'm doing this surgery outside my country. So let's see how it goes. Okay, infiltration. Is the view clear on the screen?
Yeah, it's fine.
Yeah, okay. Can you see the tumor pulsating?
Yes, yes.
So how do you go closer? Which one? This one. Oh, okay, beautiful. Okay, this is the beauty of the system, yeah? So we can actually go closer and you can see, okay. Just leave it here. Can you see the pulsation there, guys?
Yeah.
Yeah, so we are definitely going to have fun. The glomus tympanicum is stuck to the tympanic membrane, and there's no space at all for me to go around it. So we might not be able to preserve the tympanic membrane. Okay, come, infiltration.
Infiltration.
So I'm just going to withdraw a little bit so that I have more space. And let me see whether I have enough space to go on both sides. Okay, okay. Let me see. Let me just get used to the system for a while, yeah, guys.
Yeah. On from both sides of
This one is curved.
one from this side.
Okay, hold on. So,
Yes.
okay, here.
Yes.
And the patient is a lady, so her ear canal is not big. Wait, let me get the sucker in first. So the ear canal is a bit narrow as well.
Now you space on both sides.
Okay. I'm just getting used to getting both the instruments in at the same time. I can't see my instrument. Maybe we should put a suture up here. Yeah? Can I have suture?
No.
Just give me a few minutes. Let me get used to the setting, yeah? Okay, maybe like this for the time being. Okay. And where's my suction? Suction goes here. Okay, understand.
Professor, do you want to use the external stake canal suture?
Yeah, we're getting that now. It's a lady who's quite small in size.
Okay.
So this should be fun. Narrow ear canal, nice big chubby fat glomus. So suture, guys. Okay. Just getting used to the system. All right, okay. Right?
Easy for you by
Coming further away, is it? Okay, from far. Okay, let's go. Let's try this and see. Here, is it? Okay, come. Where's my suction? Okay, I see. Okay, good. Come, let's infiltrate, guys, before we start. Infiltration?
one Cadeveric stitch.
Okay, let's put Cadeveric stitches on. Just 1 minute. Let us put some external sutures to help. Can you put for me? So we'll just put a suture through and through. Okay. Can you have a cut scissors first? Okay. Okay, cut. Can I have another suture so that I can put a cartilage here like this? This is back to you. Another suture, a smaller one.
Infiltration.
And let's clear this for a while. Huh?
That will let you do that.
I see. Okay. This is too big, but never mind. Okay. Stitch. Can you cut this? Okay. Let's see. Hope we have more space now. Okay. This way. Okay. Better, right? Okay, suction. Let me get my suction in.
No, same you will between 2.7.
Okay, come infiltration.
Sorry, so give me infiltration.
Okay.
I'll do that.
Okay. This thing's on the way. Maybe we should have a top light so that I can see. It's too dark here.
Light.
Okay, can you put it back again?
But now you can.
Okay, so now we are just going to do some infiltration.
Lelia, sir.
The ear canal is quite thin as well. Now let me infiltrate the entire ear canal. Okay, can I have some cotton ball, please? Or what's that, Maricel? I'll give this back to you. So I've got this one who's helping me. He's very comfortable with the endo holder. Can we have a top light on so that we can see what's going on? Just, yes, a little bit, that's all, so I can see what's going on. Yeah, thank you. Okay, can I have a straight forceps? This is okay. This is better, okay. So now, usually we use cotton ball, but I like this idea of mopping with a Maricel. So this hopefully will distribute the high dose dry section everywhere. Okay, can we have a blade then? This is back to you. Okay, a blade to elevate the flap. Oops, did I press something wrong? Okay, that's fine.
So you're comfortable from here? Should I give the instruments from there?
No, it's fine, don't worry. So I'm just getting used to the system, as you can see. Okay. Cotton ball, or what do you call it? Use Maricel, right? Okay.
Don't remove the suction hand.
Okay. So I usually operate with holding the scope with one hand. So this is one of the few times I'm using the endo holder, and I'm operating with both hands.
You want to put Maricel there and then suck on it?
Yes, please.
It's under that.
So as we elevate the flap, yeah, put inside, is it? Okay. Okay. You don't have a smaller one.
No.
Okay. So I've got this one who's helping me with all the, oh, nice. So it's just a matter of getting used to it, eh? Okay, good. Okay, so now comes the difficult part, elevating it from the eardrum. Let's flush with saline a little bit. Yes. You have a bipolar ready? Let's get a bipolar ready. Okay, now I'm going into the middle ear space. Right, can you see, guys? So there's a good chance that we will not be able to preserve the tympanic membrane, yeah? You flush the saline again. Ah, there, started bleeding again. Okay, let me lift up the tympanic membrane a little bit more. Okay, flush with saline again.
Yes. I saw that,
There. There. Can you see, guys? The tumor is being exposed.
Yeah.
Can you flush the saline again? Can you bring this one more? Yeah. Can you guys see the tumor has been exposed now?
Yes, yes.
So you will notice that I'm not a patient surgeon like Mubarak Khan is, yeah? I was born premature and I've always been like this for my surgeries. Okay, flush the saline. Okay, guys, okay so far?
Yeah. Yeah.
Okay. Flush the saline again.
One was removed.
Okay. Get a bipolar ready as well. So let's flush. So this is number 3. How many specs are inside now? 3.
Yeah, 3.
Okay, can you go a bit closer? And the scope goes a bit closer, you.
Yeah, yeah.
Okay. Okay, beautiful. Okay, perfect. Yeah. Boss, you're here. Is that Mubarak at the back? No. Come, look at that. That's fine, it's fine. I'll just take it up. Hey, this endoscope system is very nice, huh? It makes you, once you're used to the system, you're literally operating like with a microscope. Yeah, it's just a matter of getting used to the system. Can you see, guys?
Yes.
Okay. There's one more up there, right? Crocodile. Okay. So the head is moving, is it? Okay. There you go, guys. Okay.
Can you touch the endoscopic instrument?
Okay. So just give me a house elevator. Put the sucker in again. Okay, can I have a house? Can you go a bit closer? We'll just go a bit closer to show you the glomus, yeah? Okay, guys? Okay, that's nice view. Okay, now, can I have a bipolar?
Bipolar.
Yeah, let me see this. Okay. I'm going to try to see whether we have any plane. Your bipolars are ready, right? So you see there's no plane at all. Can you guys see that? Usually, it'll be nice if you have a small, tiny plane somewhere. Okay, can I have a MERSA? A small, tiny MERSA. A small one. Okay. Yes. Okay, boss. I think it's just too big, guys. The MERSA is a bit too big. We need, yeah, we need a smaller one. There, the show has started, the bleeding. Okay. So what I usually do is I usually use a cotton ball, but you see, once you're in the right place, there. So that is the plane that you want. Now you want to dissect the tumor away from the promontory. Guys, can you see? That's promontory, guys, can you see? I think the head is moving, the patient's head.
Head is moving. Yeah.
Okay, there. How do we stop the head from moving? No. Huh? Good. Perfect. Yes. Okay, come. So now let me see whether I can remove the upper part as well. Okay, so I'm going to place the marrow cell. Okay, one more. Okay, go in. It's a bit too big though. Okay, I think your marrow cell is a bit too big, guys. But it's okay. Yeah, that's okay. Bipolar already. So the idea is to use the marrow cell to dissect the tumor from the promontory, guys. Can you see that? Yeah, flush your cell line again. So now, the advantage a cotton ball will have is that it gives more pressure, I think, compared to a marrow cell. What do you think, boss? Yeah, no, it's okay, it's fine. But I was just thinking, you see, a cotton will give you more pressure than a marrow cell. Yeah. No, it's okay. Bipolar, come guys. Let's remove the tumor.
And here you need that pressure.
Yeah, here you lose that pressure, but it's fine. So I know I've peeled off the tumor from the promontory itself, yeah?
The upper part is remaining.
Yes. Can you give me a monopolar? Oh, go in. So to go in this direction, is it?
Monopoly?
Yeah, give me a monopolar sucker.
No, not this one.
Maybe we can, yeah?
Can change the.
Maybe we can come out a little bit more. Just sucker, fine. So now we're going to use a monopolar suction that, okay, let's see. So what I need now, Skokta. Are you guys okay with this on that side? Sucker working. Okay, suction. Okay, can we have I think your sucker is blocked, I think. Okay, want to change sucker?
Very small one.
Okay. But don't you find this endo holder amazing, yeah? Once you get used to it. Used to it, yeah. Yeah.
Drive like it in car.
Yeah, exactly, yes.
Suction is just see that this suction is not blocked.
But can you see that the amount of bleeding we had just now?
Yes, sir.
You just have to be patient. Put the. Is it go inside here? It's not fitting nicely, but never mind. It's nice to see that you guys have the same problem that I have. Suckers block all the time. Okay, it's not fitting well.
Yeah.
Just be patient for a while. Okay, now good. Let's flush the saline again. And is this bipolar? Will it fit inside? It's too big. Oh, okay, maybe we can withdraw the scope a little bit more.
We can withdraw the scope.
Okay. I need to take out the. Okay. Okay. Yeah. So it's okay, and then going. The endoscope holder is beautiful, yeah. It's just that I'm not used to the endoscope holder. Yeah. So let's go in. But did you see how we raised the tumor from the promontory? So we are also using a camera system that we are not used to. Akino, is it?
Make some zooming little bit so you can keep the endoscope away.
Okay.
Right. Now it's okay. Now you can keep the endoscope little bit away.
Okay, good. All right. You don't have a smaller bipolar than this, no? No. Can you go along the floor? See how most of the bleeding have already stopped, guys? Can you see?
Yeah.
Okay, now I need a crocodile. I'm going to take off the endoscope of the patties. Okay, crocodile. Flush your saline again. Isn't it supposed to be like this? Yeah. Okay, good. Crocodile? Crocodile? Yeah, sucker's blocked. Sucker. Is there a smaller one than this? No. Okay.
Section change.
Boss, you have to design a monopolar, boss. A bipolar for endoscope here.
This concept only we can take. This small concept only.
Yeah. You design an endoscope bipolar, boss. A small, cute one.
Yeah, like this only. You go and
Down, floor. Okay, let's go. Okay, I'm going to remove one by one. Oh, we don't have no monopolar sucker? So we
want to cut.
cauterize, yeah. Either with a bipolar or a monopolar, so that we can. Wait, let me place the scope at inferiorly, so that I have space to go up both direction. Okay, and maybe you can put plastic up here. Yeah, and now. Okay, now let's just. Okay, I think this view is good. Okay, let me try. So I'm just going to dissect the tumor away from the promontory by using this. We are having a problem with the bipolar because our bipolars are all too big. I can't reach. It's too big, guys. Okay, then give me the monopolar burner then.
Hello,
Yeah.
Dr. Prabha. We're just wondering, I mean, would it be a good idea to do a bit of a canalplasty and then proceed? That would give you some space for the bipolar.
I can't hear, sorry.
We were just wondering if if a little bit of canalplasty would help you with some space to get more instruments, wider instruments in.
No, I think we should be okay. We'll just try and see. Actually, the fault is mine. I'm just not used to the system. That's all. Yeah. Okay, there we go. Okay. Crocodile. So someone has got the pedal for the bipolar and monopolar, right? So I'm now going to remove one by one. The sucker is still blocked, guys. This is just like home.
Normal section.
It's okay. Even at home, it's like this, is always blocked.
No, the other section is not blocking, the quadri section.
Okay, come. Yeah, but then I got nothing to cauterize with. Use the bipolar.
Yes.
Okay. Okay, see, the minute I take it out, you are bleeding. So I need a bipolar so I can cauterize the base. Can we get the
Make an installation on that section.
Okay, that's fine. Okay, no, that's fine. It's fine. Don't worry. Here, quick, give me another one. I think, can you just give me a cotton ball? I think it'll be easier for me. Yeah. Give me a cotton ball with adrenaline. So let me just remove this. The scope is dirty again, guys. Can you flash the scope for me, please? Okay. Can you flash the scope?
Yes.
Just 1 minute, yeah, guys. Let me get the scope flushed. Okay. Okay, so now I'm using a cotton. Okay, so I'm using the cotton to dissect. Can you see, guys? Okay, there. See, that's promontory.
Yes.
That's a promontory that we're dissecting away.
Okay.
There, can you see, guys? That's
Yes,
promontory.
yes.
So I just need a bipolar that will work, that will go into that area, and then I can actually cut bipolar everything. So problem is our bipolars doesn't reach that area. So we are trying to get something that will reach that area. Can you just go again? This. So if we get a bipolar that works, we should be okay. Okay, let me see whether I can reach with this bipolar. I can't reach, guys, but anyway, let me try. Okay, burn. It's sucker block again. What's that cotton ball? Guys, we need a bipolar that can work. Okay, otherwise, I'm just going to dissect the glomus tumor with a cotton ball for time being, while we wait for the bipolar to come, yeah, guys? The image is fine. The image is fine. Wait for it, guys. Let's just get a bipolar that works. But you can see how I've lifted up the glomus tumor from the promontory by using a cotton ball. Here, guys, can you see? Wait, let me go closer.
Yes.
Can you see the promontory there?
Yeah, we can see. Yeah.
Yeah, so what I need is to cauterize the.
In the section we touch pottery here, monopolar.
Oh, okay. So our bipolars are not working. One more cotton ball. So the problem is our bipolars are not really working. So I have to use a monopolar to do the surgery. One more cotton ball. So I'm going to put a third cotton ball inside while I change the monopolar to a third cotton ball. And you can see how the bleeding. Okay, there. Let me press this for a while. Okay. Okay, now can you change the cautery then? The problem with this suction is moving, it's rotating left, right, center. Okay, good. This is monopolar. Okay, good. So now. Okay, burn. Cautery, please. Okay, good. Okay, now, by right, you should do this surgery with a bipolar, guys, not monopolar. Yeah? So we don't have a bipolar that is working well. Flush with cell line. Cotton ball 1.
Cotton ball.
Yes.
Okay, good. Can you see promontory, guys?
Yeah.
Okay. Burn. Oh, you're using monopolar touching. I see. Okay. Yeah. One more. Yeah, just open. Just try and see. It's a bit too big, but try. But just burn again. See, the problem we have is that our suckers are not, our bipolars are not working. Okay, that's fine. So I've already dissected the tumor out of the promontory, as you can see. That's the other cotton ball. Okay, there, guys, can you see the tumor there?
Yes.
And there's a promontory. Okay, monopolar burner again. Yeah.
Some problem with the camera.
Burn. Burn. Can you get a, if you can get a bipolar that works, it'll be good. Burn. Come again. Okay. Watch the sun again. There's one more cotton ball, right?
Yeah.
Okay, good. So that's one more cotton ball. I think all the mirrors, all this one is out. Scope, that is tumor. Any more cotton ball inside? That's a tumor being dissected away with a cotton ball. Can you guys see that? Okay, there. There's a cotton ball with the tumor that's being removed away. Okay, can you clean the scope again? So the problem we have is that we don't have a cup forceps. So you can only do this once you've lifted up the tumor from the promontory.
Do you have also 3 millimeters? E questo è 4.
All this because our bipolars don't work. So when you do a glomus tympanicum without a working bipolar, it becomes like this. You just have to be calm and continue with the surgery. Okay, another cotton ball. Do we have a bipolar? Okay, let's try this bipolar and see whether it works or not. My God, this is too long, guys. Yeah. Can I burn again? Burn. Take a cotton ball again. You understand our problem now, right? Are you guys still in the audience?
Yeah, we are always with you. We are
Yeah.
watching you.
So the problem, as you can see, is that I don't have a homeostatic mechanism, but otherwise we'd have finished a long time ago. Burn? Is this working? Yes. Burn? Okay, good. So instead of cup forceps again, cup forceps, huh? So instead of using I've already dissected the tumor out of the promontory. So by right, what we need to do, okay, I'm just gonna got a bipolar? Good. Let's see. Yeah.
Oh.
You need something like a bayonet that is curved a bit, you know? Let's see.
Then I'll check.
Let's try because they've opened another bipolar. It's not going in.
This is... Ah, ecco, infatti diceva che c'è cazzo. Però ci vuole un raccordo, questo qua.
It's too big, guys. You know, let's try this. It's the only bipolar we have, right? Yeah.
I think this. Però forse quello lì è troppo grosso. Ci
Clean
vuole...
the scope again.
Hello?
I am checking the voice. Hello. Hello, can you hear? Oh, hi.
So
How are
Daniel,
you?
can you hear us?
Yeah, we are checking the instruments
Clean the scope again.
just before to start the dissection. It's possible to have more light in the endoscope because you can see that. No, the light. You can see that. Go. Go. El massimo. It's so dark. No, è troppo. Non vedi che è... It's too dark.
Too dark.
I don't know why.
Yeah, okay.
I don't know what's happened. Ma no, ma vedi che...
Yeah.
It's too dark.
Please increase the zoom.
It's dark.
No. I can't go in. I can't reach.
Dr. Daniel, can you please?
The light is too dark. Sige.
No, cannot lah. Okay, burn. Mana pula burn? Burn.
Oh, se vuoi proviamo con l'altra ottica. Ma questa qua è troppo scura. We can change the endoscope. We can...
Mana pula burner working?
Ma vedi che questa... This is not good because...
Can we change?
Button ball again.
But,
Because it's off here. I don't know if it's
credo che cambi poco.
because it's dark.
One cotton has fallen down, huh?
Fallen down.
Yeah.
Ma vedi che...
Go closer.
Per mettere a fuoco come si fa? Scusami.
Okay, we need a bipolar now.
The focus is automatic.
How much is your, can I have a pick? Or elevator?
Downside is
This one. Where is the focus here?
Focus blocker.
Oh, this one. Let me check. Ah, okay.
Can you guys see this?
Yes, yes, yes.
I'm definitely the tumor from the attic, if you can see.
giallo.
Facciamo il bianco.
And that's the tumor coming out from the attic
We
region.
can do the white.
Problem is after this, we gotta do hemostasis. That's the problem now. Okay, come elevator again. Are we getting another bipolar? No. There's no other bipolar.
Ce l'hai una lentina grande? So I don't know if somebody can hear me. We can start the dissection.
Yeah.
This is formalin patients. So my plan is to remove the eardrum. Mi tenete fermo qua che si muove. And also after this, we have to study the anatomy of the transpromontoidal approach. So we can start with the dissection. Of course, when you are doing this in a formalin spaceman, you can see that the skin is really like a plastic. So it's not possible to perform a right flap.
Not going in. There's no space. It's too short. There's no space. I can't go in.
And it's
Let me go in first then. Okay, let's try this. Scope again.
Ce l'hai un'altra lentina o è solo questa?
Can I remove the plastic from that?
Uguale?
Hold on. Burn.
Più grande non va bene.
Burn. Put stick. Bipolar, guys. Burn.
Allora, dammi una pinza presa. So now we have to remove the eardrum because with the formalin it's quite impossible to do a tympanometal flap like in a living patient.
It's not working.
Non prende niente.
Bipolar's not working.
No, non prende niente.
Cotton ball again. Crocodile.
Falcetto, ma non so che cazzo c'è. We have to remove all the eardrum in this case because the flap is.
I can't see anything.
So good.
Okay, burn again, monopolar, for whatever it's worth.
circumferential incision of the skin.
I think your monopolar is too high. Can you make it 15?
तो reduce करो ना 15. 15. Correct को.
You burn?
Hai anche il dissettore curvo?
Burn. Can you clean the scope?
We are reaching the anterior annulus now.
Okay. Burn. Burn.
Sure.
Where is the Mubarak?
Anterior annulus.
Where's the sucker by the one that they used just now? Mubarak's one.
The same section. And this is the handle of the
It's not working.
malleus that we have
No.
to cut
Yeah.
over there.
Yeah. I don't think can go in.
Dammi quello curvo.
This is too short, you know.
Che è enorme questo.
Can you give me that?
This is the curve instrument that we have to following the annulus. No, fa cagare, è troppo grande. Can following the annulus anteriorly, and after we can detach all the eardrum. Ok, dammi un coccodrillino. Delle forbicine ce l'hai?
Then we could have done, no? वो चलता है ना, that can be done.
Ok, dammi ancora il dissettore curvo.
You can't see anything.
Ok.
Hello. Professor Prepa, we'll like to mute you for some time till the time the hemostasis is taken care of.
Sì. Perché? Dammi la pinza presa. Ok, tieni qua, pulisci, cazzo, è una merda. Pulisci. Se non prendo un cazzo di niente, Dio ladro, tieni. Cantate, vabbè. Se c'è qualcuno che sa l'italiano. Okay, so now we remove all the drum because when you want to do something like a flap, you need a cadaveric spacement without formalin and fresh. So it's
Hello, can this cadaveric dissection skin be enlarged?
Hello, can you hear me?
Can you enlarge the view of your? Yeah, thank you, thank you.
Okay,
You can see
so
it better.
now we start to remove the eardrum because when you are doing a dissection with a formalin cadaveric dissection, it's better to remove the eardrum because it's not like when you are doing in a fresh cadaver or in a living patient. It's not possible to do a flap, or you can do, but it's quite hard to maintain the flap in the position. So the aim of the dissection is to see all the anatomy of the tympanic cavity. And so now we can start to see the anatomy. Dammi una forbicina. We can start with the middle ear. Attenzione a questo cazzo di... Ragazzi, mi aiutate? Ok. Non muovetemi. Non muovetemi. Okay, we can start with the middle ear. You can see already here, this is the subcochlear canaliculi and the funiculus and the fustis, and here there is the subiculum, And the pyramidal eminence, you can see here now the anatomy. Now we can start to drill the external auditory canal in order to improve, to gain our space. Ce l'hai una fresa?
Dai, doc.
O una curette, dammi una curette.
Prepara la presa, doc.
Che cazzo è sta roba? So we can correct both. Do you have a straight curette? This is curve.
No, ha detto.
No? This is not a good curette, but anyway. Non si riesce a cosare. Now it's better to drill because this curette is not so. Dammi la fresa. So it's better to drill.
Per lavare ce l'abbiamo.
Lavare.
Abbiamo il pizzettone. No,
Va all'infinito. Ma va anche l'acqua?
No, no, questa.
Ah, sei tu che mi davi l'acqua? No, no, dammi l'aspiratore.
Aspiratore?
No, ragazzi, c'è che cazzo? Doesn't work. Ci vuole l'aspiratore più grande. We have to wait the suction that is doesn't work. Per favore.
prendiamo questo qui.
Ma prendi quello che vuoi, dai.
Cambio.
Allora, leggo da lavare, bisogna lavare poco.
Tieni, vedi se puoi usare questo per lavare, Ale, non lo so.
No, guarda.
So now we have to wash and clean. We are using a 4 millimeter endoscope that, in my experience, the best endoscope is a 3, because in order to working inside the tympanic cavity, the 3 endoscope is the best. And also, and you need a straight curette, not angle curette. But anyway. Scivola e poi prende anche. Can we have a straight curette? Prova a sentire un attimo. Ma cioè, no, ma normale, otologica, cioè non è che chiediamo.
Only curved.
It's not possible to provide for only curve.
Okay. Okay.
Lavare. Bisogna fare attenzione perché questa, ok, la lava molto però, cioè non fare i cazzetti. E vabbè, prendi una siringa e la butti dentro. No, così non va bene, ragazzi. And when you are doing this, the best drill is the piezoelectric, of course. Dammi la curette, quella schifida. We have just a curve curette here. I'm trying to use, but it's not easy because the curve curette is not so essential here. Non va. Non va. Oh. Dammi l'aspiratore. Io. Lava. Lava. Ok, altro. Yes. Dammi una lentina. Oh. You can see that the skin is really thick because it's a formalin. And the light of the endoscope, it's quite dark. Anyway, we can. Non viene via neanche se la paghi. Non viene via. No. Non viene via. Che strumenti. So we can start to see the facial nerve, but now we have to remove the skin. The only way to remove the skin is with the drill. We enlarge our dissection in the hypotympanic cells, just in order to improve our view. Questo che non lava forte, aspiratore. No. Lavare. Lava, così. Alt. E adesso dammi aspiratore. Ce l'hai più piccolo? Okay, so now we can start to see the facial nerve under the incus, but of course it's not sufficient for the approach. Tenetemi fermo per la cazzo. Dammi una lentina, non riesco a lavorare. Ci si riesce a muovere perché è un canale stretto. Okay, so you can see now, this is the corda. And here we are, the facial nerve under here and the pyramidal eminence is here. And of course, now we can try to move the ossiculary chain. It's good. Dammi accurate. We can start to see, of course, the Eustachian tube that is here with the tensor tendon muscle. And this is a curve, correct, that is not so functional in this kind of surgery because you are not able to correct in appropriate way, but I can try to use. Ok. Aspiratore. Aspiratore. Ma perché cazzo non mi dici? Mi sei davanti, sei. Sì, dammi un falcetto che è una merda. So now, after the drill, we can see better here the hypotympanic cells. Of course, we have to move the corda. Oh, the corda is gone better. Dammi la forbicina. So we can cut the corda. Aspiratore. Aspiratore. We can remove the corda. No, non va. Non va, ragazzi, su. Dammi un coccodrillino. So this is approach for transpromontorial, of course. When you are doing this, you have to always remove the corda. No, ce l'hai un coccodrillino. Io. Okay, so now we can see better the facial nerve that is here. Dammi un falcetto. We can see better now the anatomy after corda removal. We have the facial nerve is here, the second genu of the facial nerve. The third portions of the facial nerve run over there. And this is the styloid prominence here. And we can see over there the incudo-malleolar joint that is here. And this is the anterior ligamental fold of the malleus. Can try to push the skin that with the formalin, it's quite difficult to maintain in the space. And you can see here, this is the ligamental, the incudo-malleolar lateral fold. You can see that I put here and you can see the ligamental fold over there. Where is the isthmus? The isthmus is under here in the medial surface of the ossiculary chain, and medially with respect to the body of the incus and the head of the malleus. In order to see, you have to check with the 45 degree. If you want, we can check
You have a
with
monopolar
the...
burner. I can't reach there.
Sorry?
No,
se non da con I peli. Fatemelo con I peli, pulisci.
The device is okay. Can you see?
We can remove more bone from here.
Can you all hear now? Hello?
Hello?
Can you have the other picture, please?
Hi, can you all hear me?
Oh, okay.
Okay.
I think it's done. It's better now, yeah.
Hello? Can you hear me now?
Yeah, Professor, we can see.
Okay. This is definitely a challenging case. No
I mean,
bipolar works, suction monopolar is not working. It's a good thing I saw Ganesha on the way. Can you see we removed most of the tumor already? That's a tumor from the eustachian tube here. Okay.
Yeah.
Okay. Promontory is clear. So the only tumor we have left is here along the ossicles. Okay. But I tell you one thing, if the bipolars were working, our suction monopolars were not working either. So I had to cauterize, I had to use cotton ball to dissect and put put a plastic along the suction to cauterize eventually. Okay. But I think the moral of the story is, no matter, even when all your instruments don't work, just remain calm and continue. Improvise. Don't get upset. Don't throw a tantrum. Just improvise and go on. That's your malice is here. Can you see, guys?
We can see the malleus.
Okay. Yeah, that is the eustachian tube.
Yeah.
Okay, let me see if I can cauterize. See, the problem with this bipolar is it's too short. So I can't even put it inside. So see, burn. Okay, it's fine, fine. We're almost done anyway. Okay, there you go. Can you see? That's the eustachian tube opening. Flush the saline. Is it clear, guys?
Yeah.
So this is the classical surgery of what do you do when nothing works? Keep calm and continue, dissect. So there's a bit of, there, you see? Promontory, round window. This, a bit of, so this is the part that after removing the tumor from the eustachian tube, here, can you see?
Yeah.
So eustachian tube, promontory, and this is where the ossicles would be here. So the only tumor that is left now is here along the facial nerve. Is that clear, guys?
Yeah, clear.
Okay. How do we stop this bleeding? Monopolar. Okay. We are trying everything we can. So Khan's got a beautiful monopolar suctions. But the problem is sometimes it works, sometimes it doesn't. Okay, but let's hope it works now. It must be me because when he uses it, it works very nicely. But okay, sucker block again. Okay, now let me just clean up the whole thing. Scope is dirty. Okay, clean the scope again. Hold on, the sucker's blocked for a while, guys. Change back into normal sucker. So those of you who were watching this just now would have seen how we struggled without bipolars that work and monopolars that did not work. So I ended up doing most of the dissection by using purely the round window, guys. Can you see?
Yeah.
Round window. So we did the entire surgery by using
cotton,
yeah. Cotton and a prayer. And this one next to me has been very helpful. He's been giving me monopolar after monopolar, bipolar after bipolar. None of them are working. Okay, so can you see, guys? You focus a bit.
Yeah.
So the only thing that is left is here. Remember, we are dealing with a benign condition. Okay, can I have a pick or something? Clear, guys? Yeah. Something that is curved that I can use to remove a tumor. Every time you remove a bit of tumor, it starts bleeding and we have no instruments to stop the bleeding. That's the problem. Okay, that's now tumor from the attic. By using a ball probe. Let's hope it doesn't bleed too much. Or sometimes you can just use, what's that? The staples will be here, way down here. So this is the only tumor that is left behind. Come. Can I have a cup for that? So this is the only tumor that is left behind. Can you see, guys? That is at the attic region.
Yes.
Sucker blocked again. No. So we remove this, we are done. And next time when my bipolars work at home, I'll be so grateful. There, guys. That is the tumor from the attic. Guys, can you see that, guys, now?
Yeah.
Okay, so your stapes would be here. The tumor from the attic. That's bleeding. So now what are you going to do? Cotton ball again. So this is a classical case where when everything goes wrong, nothing works. Keep calm, go on operating. Don't get upset. Don't try to be a hero by shouting and screaming. It's nobody's fault. Happens to the best of us. Cotton ball? Some water? Clear, guys?
Yeah.
Are you guys awake?
Yeah.
Okay. So I just have to remove this cotton ball, stop the bleeding. And I think I'm going to stop here. Any questions, guys?
Somebody was asking, what about an aticotomy out here? Would it help in any way?
No, not really. You can do an aticotomy if you want to, but usually you can remove the tumor like how I did just now. Because the tumor is all like a balloon, you know. So like how when you catch the tumor and just pull it out, the whole thing just comes out very nicely.
Okay.
Wait?
How is the bleeding stop?
So this one is asking me how will the bleeding stop? On a song, on a prayer. How do you think we did the surgery so far? Nothing worked so far, right? Nothing worked. Pressure, wait for a while. I give you a better example. Give me a bone wax. I'll stop all the bleeding. Give me a bone wax. Bone wax. Were you watching how we did the surgery with no bipolar, nothing? Okay, see that, guys? That's the only source of bleeding we have from the eustachian tube area. So what we usually do with this round window there, can you see, guys? Can you go a bit closer? They're not getting a clear picture. What's that? I don't understand. What did you say?
Nothing. They are not seeing the picture clearly there.
Okay, guys, can you see this now? Hello?
Yeah.
Okay, there. So the final bleeding point is way up here along the eustachian tube. Okay? Flush, Visala. This one is taking a deep breath. I think he's also glad the surgery is over.
No, sir. What else can be done?
What else can we do? Yeah.
You can do an etiquette and expose the whole thing and then.
No, it's fine. There.
Now it's only a small portion.
There, you see? Chances are whatever's left behind is very small. Give me a ballpark here. Yeah, we can. Or it looks quite clear. You can use the endoscope and see. When you have no hemostatic mechanism, let's not try to be a hero. Okay, that's the attic region.
Yes.
There. You see, guys? That's your malus, by the way. Huh? That's your final tumor from the attic region. Removing the tumor is fine. Stopping the bleeding is going to be a big problem now. There. Can you see, guys?
Yeah, you're taking out the remnant of the tissue from there.
That's the tumor from the attic.
Yes, from the attic. Yeah.
So now we'll have bleeding now from there. So Roisan, what shall we do? Cotton ball. Hi. Okay, so I'm going to pack the cotton ball. Now the cotton ball is at the two places that's oozing. Attic and the eustachian tube. The rest is okay. Huh? The guy, can you see?
What is that tissue in front? Is that
Come again?
That tissue hanging in front of you, in front of the cotton ball? Is that tumor tissue or it is the flap?
Hold on.
Some tissue.
I'll remove that for you as well. This one, the small cute one here.
Yeah.
Okay, there you go. So with the cotton ball, I'm dissecting out all the remnant of tumor that might be in the attic. So now you've seen a a big glomus tympanicum. Okay. That's attic, guys. Can you see?
Very clean, very clear. Yeah.
Can you see the attic now?
Yeah, there's no tissue out there anymore.
Huh? So there. Flush again, select.
That looks good. Yeah.
What's the problem? That's the attic. Clear? Can you guys see that? There. So now I just need to stop the bleeding from the suction tube. And I think Rizwan and I should have a coffee together and celebrate extensive glomus tympanicum with no hemostatic mechanism. Okay. Okay, good. Guys, what do you all think?
Very nice.
Cotton
very
ball
nice.
works, huh? Okay.
Very nice.
Shall I stop here? Can you please give Rizwan a big clap of hand for giving me suction after suction after suction? Malice is here, despite nothing works, but still give me everything one by one to the. It's a bit too late. No, I will face the surgery. Guys, clear, guys?
Yeah.
Any questions you want to ask? I just want to tell you one more time. We did a big, extensive glomus tympanicum with no space, with no bipolar or monopolar, and a suction that didn't work most of the time. All that we did by dissecting under the along the tympanicum, along the tympanic,
Yeah, Professor, can you have a closer view of the attic area?
Yeah, go closer.
If
Focus.
possible.
Flush. And did you see how finally all the bleeding stopped?
Yes.
Okay. Any cotton balls all out, guys?
Yeah.
Okay, guys? Where? I think I'll stop there. There, all is good. Dissection tube is there. Hypotympanum. That's the round window niche. That's the attic. Okay, guys? Cotton ball all out.
Can we?
Malice is here. Okay.
Can you shift to the other OT?
Come again?
We want to go to the other OT for cadaver dissection.
I can't hear. I'm so sorry.
You have done a nice job. We are appreciating it. Very nice.
I'm so sorry. I can't. We can't hear. There's too many people talking at the same time here. But any questions before I finish? But
we'd like
can
to
you all
have-
appreciate how we did the surgery with? That's your Malice, yeah. But can you all appreciate how we did the surgery with no bipolar, no monopolar, little nothing work, and that's the attic that is clear, promontory, round window niche. Okay, come.
Is it possible to identify the stapes there?
Stapes.
Yes.
It should be down here. This region. That's the region that I didn't go anywhere near.
Okay.
See? There's a bit of tumor left behind there. That's the tumor that I didn't want to take out because I have no monopolar, nothing, but no homeostasis mechanism. Go closer. Focus a bit. Stapes should be here.
Yes.
Suction. Flush your saline. Let me see. Let me flush out all the blood clots. Okay. But not bad, huh? We actually stopped all the bleeding with just cotton ball. Can you go a bit closer and focus? Paper should be here. The foot plate should be here. Okay, guys?
Right.
Okay, guys, thank you very much. I'm going to stop here again.
Thank
This
you
is
very
a-
much.
This is a beautiful
Big
case.
round of applause for you for completing the surgery with such constraints.
But it's a good case to show you, don't give up. Even if nothing works, if Mubarak calls you, it will go well. Thank you very much again. I'll see you all later.
Thank you very much. Thank you very much.
Leave it open.
Leave it open. Yeah.
Stacking with them.
The other question is, I don't reconstruct my glomus tympanicums. I'll wait for a few years, no recurrence, then only I reconstruct. Is that okay?
Okay.
Thank you very much. Bye-bye. Thank you.
Thank you.
Okay.
Can we focus on the dissection now, please?
Yeah. Just one second.
Hello. Can you hear me?
Yes, sir.
So just to describe, we remove the ossiculary chain, we enlarge just a little bit the atticotomy, and after when you remove the ossiculary chain, You can see immediately the facial nerve in front of you.
Careful,
You can
Doctor,
see
okay.
this is the facial nerve,
I'll wait for you for coffee.
and the cochleariform
for
process is
coffee.
here.
Can you off
And
my-
this is the cog. You can see that the cog is really important landmark
There's nothing else.
in order
Everything
to
is out.
understand where
Can you-
is located the
Audiovisual people,
ganglion.
can you please mute Professor Prepageran's mic? Yes, sir. We are back with you.
So, can you hear me?
Yes, sir.
Okay, so this is the cog. You can see the cog. The
Yes.
cog is a landmark in order to understand where is located the genicular ganglion. The genicular ganglion is in between the cochleariform process and the cog. So under here, there is the genicular ganglion, and this is the second tract of the facial nerve, the second genu of the facial nerve, the third portions of the facial nerve turn over there.
Yes.
And the lateral semicircular canal is this one.
Yes.
So we can see here the promontory region with the Jacobson nerve.
Yes.
The Jacobson nerve run over the promontory region and turn here under the cochleariform process. You can see here.
Yes.
After turning this way and going in this way and reaching the GSPN anteriorly over there.
Mm-hmm.
This is the fustis, and so if I following the fustis, I know where is located the scala tympani, and this is the subiculum, and the ponticulus is this one. You can see the ponticulus.
Yes.
If I close, you can see here the ponticulus, and
Yes.
with staples. Now, if you want, we can try to dissect the facial nerve in order to see the genicular ganglion. To do this, we have to. Unfortunately, with the formalin spaceman, it's not so easy because the muscle are really rigid and the ligament are really rigid. So sometimes it's not so easy to do this, but we can try. We have to remove the cochleariform process here, like this. Shall I?
Una lentina.
Ce l'hai più piccola? And now you can see that when you are doing a fracture of the, dammi un falcetto, a fracture of the cochleariform process are really close to the genicular ganglion, because under here I can push the muscle and immediately I can see here the facial nerve.
Yes.
So we have to be careful. And this is the channel of the muscle, you can see here. And you can see that the tissue is rigid. It's not possible to move anteriorly because come back, because it's a formalin. So anyway, and this is the muscle. And the facial nerve is this one. So now we can check better. You can see that under the muscle, there is the facial nerve, the genicular ganglion.
Mm-hmm.
Now we can try to correct. We remove the cog. Under the cog, there is the middle fossa.
Sorry? Little fossa.
Under the cog,
Mm-hmm.
there is the dura of the middle fossa. You can see that this is a defect of the middle fossa because this is a spaceman and is a formalin temporal bone, but and this is the facial nerve. So you can see that the facial nerve is really close to the dura.
Mm-hmm.
And this is the dura of the middle fossa. Dammi un falsetto. So in order to understand better, this is the genicular ganglion, you can see.
Yes.
And this is the line of the middle fossa. This is a defect of the middle fossa because the spaceman was cut here. So we are not able to have integrum dura. This is because the spaceman. but the spacement. But you can see that the dura descending here, and if you can see, this is the GSPN, this one, join the dura over there, and the facial nerve, the genicular ganglion is here. So just to check in a close view, and the channel of the muscle is here, and I pull the muscle anteriorly in order to decompress the nerve. Aspetta, me lo pulisci questo? So again, we can see better here the soft tissue of the facial nerve. I can try to clean just in order to improve your view. Okay. Now I think that is possible to see. You can see. And now we can cut the tendon of the stapes. So the facial nerve, you can see that the second genu of the facial nerve is here, tympanic segment of the facial nerve is here. This is the genicular ganglion, and the labyrinthine portions of the facial nerve turn under here and running over there. The projections of the fundus of the internal auditory canal is here. Now we can check the vestibule. Dammi una forbicina e un uncino piccolo. In order to do this, we have to cut the tendon of the stapes. And after we can try to remove the stapes. No, ci vuole qualcosa che and we are inside the vestibule here.
Yes.
So now, dammi un falsetto. Now we can check better the anatomy. We have the genicular ganglion here, tympanic segment here, the vestibule, and the cochlea is here. We can see that here inside the vestibule, there is like a brown spot. This is the spherical recess where the inferior vestibular nerve is attached. So is a landmark in order to find the fundus of the internal auditory canal. We can remove the pyramidal eminence because you can see clearly where the facial nerve runs. Dammi una curetta. Spiratore?
Spiratore.
Spiratore? No, fammelo bene. So now we have more space. No, ragazzi, bisogna metterla, va bene? Sì, sì. We can check closer. And look now the anatomy in this way. Dammi un falsetto. I'm sorry because it's too dark. I don't know why. When I turn the endoscope, become dark. I don't know why. So this is the funiculus bone. The subcochlear canaliculi is under here. Probably this is the bulging of the jugular bulb, and the fustis is here. The funiculus is here. We remove the ponticulus with the pyramidal eminence. We have the vestibule and the facial nerve, and this is the Jacobson nerves. So we can start, and the lateral semicircular canal. We can start to enlarge the vestibule, correcting. Just a little bit, not too much. Screte is quite big, but anyway. Okay, so we are enlarging here and we can see the medial wall of the vestibule. And now we can start to see the cochlea. No. Hold on again. Can start to see the cochlea. Where is the carotid artery? The carotid artery, of course, is below the Eustachian tube, here in this position. You can see. Dammi un falcetto. This is the cochlea, and the carotid run over there under these cells.
Have we lost transmission?
So, audiovisual.
Audiovisual?
Audiovisual.
I think we lost transmission from the hall.
Only you understood that we are lost. Because all are speaking. You can look around, you understand.
चाय स्टॉल्स में मिल रही होगी पता नहीं हाँ ना ना ना
है ना
ना कोलेस्ट्रॉल नहीं
ऐसे ही
तुम्हारे पास कोलेस्ट्रॉल कल है शायद
उन लोग टेक्निक করতে হলো কারেন্সি করতে হলো
I'm sure he'll this
Organ rising, Babu. Organ rising.
organ
What? Some problem there. Okay.
अभी चली बत्ती मुझे भी पहले पहले से
Let me know when we are ready. Yeah? Are you able to see in the room?
Yeah.
Hello.
Yes, we are able to see you, sir.
Are you able to see?
Yes, we are able to see.
Okay, because we didn't know if there was a problem with the connection. Anyway,
Yes.
so look now, the fustis bone is this one, and look the orientation of the round window membrane. You can see the round window membrane, the
Yes.
orientation. Okay, so this is the round window membrane, and if I put here my instrument, I can open and look what's happened. I go directly to the vestibule, and this is the scala vestibuli. I have to go to the scala tympani. I have to put the membrane over there, and we can see that the scala tympani is under this, so is in this direction. You can see.
Yes.
Now we can check better removing this bone between the vestibule and the cochlea. And we can understand better the condition of the basal cern of the cochlea. Okay. Coccodrillo. So we remove this part of the bone.
Yes.
Aspiratore. And now we can check the scala of the basal cern, the scala tympani and the scala vestibuli. You can see that here there is the scala tympani, and over there is the scala vestibuli. Dammi un falsetto. And this is the round window membrane. You can see the round window membrane.
Yes. You can also see the hook region.
Look, this is the membrane. The original position of the membrane is here. And you can see that if you're following the membrane, it's really important that you go down to the scala tympani that is here. Instead here, this is a scala vestibuli connecting with the vestibule, you can see.
Yes. Dr. Marchioni, for the benefit, especially of the juniors, would you like to demonstrate the hook region a bit better, please? How the orientation of the scala vestibuli and the tympani changes.
Sorry, I didn't understand.
I was wondering if you could demonstrate the hook region a bit more clearly. The hook region of the cochlea.
The hook region of the cochlea. So now, this is the anatomy, in my opinion, the most important anatomy is here. There is the basal cern of the cochlea. This is the round window membrane. And you can see here, this is the scala vestibuli that connecting with the vestibule, and this is the scala tympani. But now we can do all the dissections of the cochlea, and we can see better also the other part of the cochlea. Probably we have to drill, because now the bone is quite hard. Aspiratore. And you can see again.
Yes.
And another important aspect is this. Dammi un falsetto. Look now the fustis bone. The fustis bone is this one. And you can see that the fustis bone become the floor of the scala tympani. You can see?
Yes.
This is the floor of the scala tympani. So it means that if you are problem, ossification, as you please, just to following the fustis, and you know where is located the scala tympani, because the fustis is always the floor of the scala tympani. You can see that it's possible to see clearly. Can you see?
Yes.
Another important detail, look, this is the subcochlear canaliculi, and sometime when you are drilling the cochlea, oh, I don't know what's happened here. When you are drilling the cochlea, you can find a hole like this, and you can think about, oh, this is a scala tympani, because it's a parallel tunnel with respect to the scala tympani, and it's not the scala tympani because it's below the fustis. Can you see the fustis is here?
Yes.
And this hole is below. And this is the subcochlear canaliculi. And the subcochlear canaliculi, you can go directly to the petrous apex, close to the carotid artery. Dammi una curetta. But it's really important to know this anatomy for this reason, because this is the funiculus bone. The funiculus is here, the fustis is here, and between the fustis and the funiculus, you have the subcochlear canaliculi. That is a really deep canal that is close to the scala tympani, and sometimes you can have some confusion. You can see.
Yes.
This is the scala tympani, and this is the subcochlear canaliculi. I don't know, it's so dark. Dammi da lavare e aspirare. Now we can clean the surgical field. Ah, no, dammi quello più grande, quello più grande. E lava molto, dai. Ma che cazzetti lì. No, non me lo metti bene, cioè io non so, ma poi. Non va, non va. The suction doesn't work, please. Can you help me? The suction doesn't work. Forse non va lì. Now we try to understand why the suction doesn't work. Anyway, dammi un falcetto intanto che almeno faccio. Dammi un falcetto, dammi un falcetto. So now we are waiting for a suction because it doesn't work. Anyway, we can review the cavity, the facial nerve, lateral semicircular canal, dura of the middle fossa descending ear, a genicular ganglion, the muscle tendon that we push anteriorly, the vestibule with the middle cavity, and this is the spherical recess, the basal cern of the cochlea with the scala tympani and the scala vestibuli here, and the fustis bone representing the floor of the scala tympani. Now it's working. Now it's working. So now we can try to open the middle and apical cern of the cochlea. In order to do this, probably we have to drill because it's not so easy. It's quite a hard bone, and we can try to do with a curette, but in the majority of the cases, it's not so easy, especially if you have a formalin patients. It's not easy. I try to clean for you better. Dammi un coccodrillo. We can try to remove as much as possible this tissue. Dammi un forbicine. Just to clean, because the muscle is really rigid in the formalin. Okay. Do you have a question? No.
Hello.
Yes.
Sir, can you show transcochlear approach to the petrous apex?
Yes, of course. We are doing the transpromontorial approach.
Yeah.
This is one step of the transpromontory approach. And we always, when
কি করে করেছে প্র্যাকটিসে কি রুটে করবে মাইক্রোস্কোপ কি করে করবে এখান দিয়ে ঢুকেছে কোথায় যেটা আমাদের কোথায় পোস্টারে ঢুকেছে উড়িয়ে দিয়েছে হ্যাঁ কেনা তেনা উড়িয়ে দিয়েছে হ্যাঁ পৌঁছা বলে পৌঁছা শেষ রেডি ব্রাইন্ডি করতে প্লাস্টিক সেন্সরগুলো কেন দিয়েছে ফেশিয়াল almost 360 degrees and case only the pure 360 degrees and case possible now the patient was hanging recent in the within the call side হ্যাঁ পুরোটা ডিসাইড করে পেশেন্টে ট্রান্সপোজ করে তাদের দিক থেকে উপর থেকে ইয়ে করে গ্রেড 3 নাকি কত হলো পেশেন্ট না গ্রেড 6 গ্রেড 6 ছিল আগে থেকে ছিল হ্যাঁ ওটা তো আর রিকভার করতে না করতে টাইম লাগবে 5 কি ছিল পেশেন্ট হ্যাজ বিন সেভড সুতরাং রিকভার করতে একটু টেক ওভার ইয়ার খরচ করেছে গ্রেড 3 হ্যাঁ গ্রেড 3 বাট you can't expect anything different than grade 3. Hello. ডিল করছে ওরা কথা বলছে না অডিও ওটা কি করবো মুবারক খানের সামোটি টিমপ্লাস এত টিমপ্লাস দেখে আমি কি করবো বোর হয়ে গেছে এত ভালো একটা কনফারেন্স Dealing with middle channel. नहीं सर अरे एक सिगरेट तो पीता है सिगरेट का छोटा भाई
Hello, Dr. Marchioni. Hello. वो उनकी ये कट गई शायद, ये probably he's become new.
Hello.
Hello.
Hello, can you hear me?
Yes, sir.
Okay. See, now
Hello. No, I think we lost your voice.
hello, hello, can you hear
Hello.
me?
Yeah, we can hear you now, sir. We can hear you.
Okay, yes, because there was a problem with the microphone. Anyway, this is the middle and apical turn of the cochlea, and the basal turn is here, and the vestibule is here, and the facial nerve, of course, is here, under here.
Yes.
Okay. Ce l'hai un. So now, dammi un falsetto. Now, if you want to do a if you want to do a transpromontory approach, we can remove also this bone like this, just in order to improve the view on the facial nerve. That you can see the facial nerve is here, and this is the canal of the facial nerve, and the geniculate ganglia is over there. And where is the labyrinthine portions of the facial nerve? Turn over there, turn immediately over the cochlea, entering into the fundus of the internal auditory canal. Where is the fundus of the internal auditory canal? The fundus is here, in this triangle of bone that we call it the cochlear vestibular bone. The cochlear vestibular bone is the bone between the cochlea and the vestibule, this bone. If you open this bone, you can go to the fundus of the internal auditory canal, where there are the nerves, the cochlear nerves, the vestibular nerves, and the facial nerve more deep. So if you want to reach the fundus, you have to drill here, the cochlear vestibular bone. The cochlear vestibular bone is the door of the fundus of the internal auditory canal. And we can see that we can start to see the labyrinthine portions of the facial nerve turn over there. Can you see?
Yes, sir.
Okay, so now we can try to remove this bone. Prova a darmi una curette. I don't know if we are able with the curette. We can try. Probably no, because it's too heavy. We can improve the view of the cochlea. Dammi l'aspiratore. Presa. Now we have to drill. It's too heavy. This bone, Dio lei. Now the drill is not so long. Scivola. Fammi lavare e aspirare. In this step, you need a long drill. This is too short. Anyway, non aspira niente, ragazzi. Non aspira. Non aspira. Suction doesn't work. No, no, me lo devi mettere bene.
रेट्रो लैब भी कर सकते हैं शायद, जा सकते हैं वहां से, बताएंगे कैसे आवेदन के पीछे
Lava.
एक बार जनरस बता सकते ऊपर लैबिंग का अप्रोच होता है सर, इसके बाद सर आपका जो
Dammi rispetto. So now the problem is the instrument, that we need a long instrument. This instrument is not so long. Anyway, we can try. Dammi la fresa. I can't reach this area. No, I can't reach. Can we have a longer one? Just a little bit, because I can't reach the, if it's possible. Prova a darmi la curette. I can try with the curette, because the drill is not possible to reach here because it's not so long. I can try with the curette. Okay. We can start to see the fundus. This is the area of the fundus. Can you see? This is the basal turn, middle, vestibule, and the fundus. We can try, probably we have the longer drill. No, we can. Yes, now it's better. I'm drilling the cochlear vestibular bone. Lavare, aspirare. Okay. Can you see here? Can you see this bone? That there is the dura of the internal auditory canal here. So, but now we can drill again. Reza. Yes. Aspiratore. Lavare. Dai, lava. No, non va, ragazzi, dai. The suction doesn't work. No, doesn't work. Da là. So we are waiting for a suction. The suction doesn't work. So anyway, the secret of the transpromotor approach, if you want to reach the fundus of the internal auditory canal, is the cochlear vestibular bone. So you need a long drill. without long drill, it's not possible to reach this area. Now probably the suction is working. Well, no, va. Vabbè,
Non si fissa.
vabbè, non si fissa.
Questo qui viene via come...
Okay, now it's working. Lavare. Lava. No, non va più. Non va. Non va. The suction doesn't work. Now we can try to see if it's working. Okay, so now it's working. Again, we can see the anatomy. Dammi la curette. So, dammi prima il falsetto. We can see the anatomy now. We have again the basal churn of a cochlea that is here. You can see scala tympani and the scala vestibuli that is here. This is the vestibule with the facial nerve that is here, and all the cochlea, the middle and apical churn. And under here, there is the internal auditory canal. This is the dura of the internal auditory canal. And if I cut the dura, I can see the nerves. The first nerves that I can see, I don't know if this is possible to see the nerve because it's a cutting bone, but we can try. It's not like a head, so we can check. Dammi la curette. We can check if it's possible to see the nerves. I hope. Okay. Okay, yes, it's possible. You can see the nerves. This is the cochlear nerves entering into the cochlea. You can see here. Dammi un falsetto. So we have the cochlear nerve that is here, and the facial nerve is in the middle, and here there is the vestibular nerves. So we can enlarge our window in order to improve the view. Can you see the cochlear nerve entering into the cochlea? Can you see? Nobody. Dammi la curetta.
Yes, sir, we can see it.
Now we can remove this so you can see better. Okay, aspiratore.
Yes, sir.
Posso dire che non va un cazzo. Ok, dammi il falsetto. So the anatomy of the internal auditory canal here is different because the projections of the nerve are like this. This is the cochlear nerve, this is the vestibular nerve, and more deep in the middle, here there is the facial nerve. The facial nerve is this one in the middle. You can see.
Yes, sir.
And the labyrinthine portion turn from here, running over there, reaching the genicular ganglia that is here. And this is the GSPN.
Yes, sir.
We can try to drill here over the cochlea in order to see if it's possible. Non hai un uncinetto piccolo. To see the labyrinthine portions. Okay. Fraser. In order to do this, you have to drill really. It's not possible. It's not so long. Not so long.
Yes, sir.
No, we are not able to reach the area of the. Ce l'hai una diamantata? We can try to change with the diamond bar if it's longer. And of course, if you want to following all the internal auditory canal, dammi un falsetto. You have to drill.
Yes, sir.
With a long drill all this area and following the internal auditory canal till the porus. The porus is in this projection here, just a little bit deep, but you need a long drill, not a normal drill. You need a different set, of course. But anyway, and you can see this is the vestibular nerves reaching the spherical recess and the elliptical recess. So it's like this. Dammi un aspiratore ancora. No. Dammi un aspiratore più piccolo. No. No. No, non aspira niente. No, non è delicato, non aspira. Ok. We can try with the diamond bar if we have a longer one.
Yes, sir.
It's not long. It's not long. I'm not able to reach. I can try, but it's not able to reach. Aspiratore. No, I'm sorry. I'm not able because I'm not able to reach the area of the labyrinthine portion that is here. You can see that partially. We can start to see partially. Dammi ancora. Dammi ancora la fresa. Please, if you have a question or if you want to see something different, let me know.
Yes, sir. No questions.
Hello, sir, can you trace the internal carotid artery?
Hello?
Can you trace the internal carotid artery?
Yes, yes, internal carotid artery. We can see the internal carotid artery. So now I can stop the dissections of the labyrinthine portion because you can see that we can reach, but with this drill is not so easy because it's not long enough, but we can start to see something.
Yes.
Dammi falsetto.
We can see a glimpse of it.
Yes, you can see, you can start to see something here. You can see this is the labyrinthine portion.
Yeah.
Entering here. And so we have to remove this bone in order to see from here, turn over there, entering here. So like this. But anyway, if we want to see carotid artery, we have to drill here. Dammi la fretta tagliente, va. Sorry, because I can do like this, because become dark. I don't know why. So I have to work in this way. In order to see the carotid artery, you have to see the Eustachian tube, and after we have to drill under this bone.
वो cortical headlight से cortical करके postal incision. For headlight. Not endoscopic. वहाँ से नहीं cortical mastoid भी करके है. Cortical mastoid भी करके.
Presa. So it's under this bone, but you need to drill a lot of bone. In this case, in some cases, you can have the carotid reduction, so you need them to drill a lot of bone.
Yeah. Sir, can you ask your assistant to keep pouring water while you drill?
Sorry?
You please ask your assistant to pour some water, saline, something.
Yeah, if the assistant can wash during the drill.
Yeah.
Non buttarmelo in faccia, ti prego. Okay. And we can start to see something here. Presa. È che non posso ruotare, capito? Quindi senza ruotare lì è... Okay, let me check. I don't know why here become dark anyway. I don't know why. In this case, you have to drill a lot of bone.
Yeah.
But anyway, it's under here. Lavare, aspirare. Okay, dammi la correct. This is the carotid.
Yeah.
Dammi la correct. Correct. So this is the vertical portions of the carotid.
Yes, sir.
And the carotid become horizontal under the Eustachian tube. So you can see now here.
Yeah, the vertical segment, genu.
Yes. This is the genu.
Yeah.
And there is a lot of bone over because it's
That is
anatomical variation, aspiratore. But of course, it's not like I injected cadaver that you can see the red.
Yeah.
But of course, this is the vertical portions of the carotid that is here. And here under the second tube, there is the genu. And you can see the relationship between the cochlea
Yeah,
and the carotid.
yeah.
I become dark. I don't know why. Anyway, so lavare.
You can see it going along the floor of external aortic canal.
Oh, carotid is here
Yeah,
and cochlea is here.
yeah,
This is the fundus of the internal auditory canal with the nerves.
yes,
You can see the nerves, and with the middle and apical turn of the cochlea, and this is the carotid.
yeah.
And the labyrinthine portion is here. Look, for the transparency, you can see the labyrinthine. Dammi una corretta che provo a vedere se si riesce a...
Even the modulus is seen very clearly.
Yes.
Modulus.
The modulus is
Yeah.
here, and we can try to see if it's possible to have a good view on the facial nerve, but it's quite difficult without the right drill. Anyway, we can try. Respiratore, no, non ce la facciamo mica. Dammi un falcetto. So anyway, this is the special anatomy for transpromontory approach. Now we can start to see the channel of the labyrinthine portion. You can see that if I do like this, I can move the nerves.
Yeah.
And we can improve the view on the cochlea. Okay. And on the nerves. Okay, so now this is all the facial nerve that we can dissect. A little fragment of the bone. Anyway, the genicle ganglia is here, the labyrinthine portion turn over there, over the cochlea, entering here in the fundus of the internal auditory canal. It's possible to dissect also the labyrinthine portions. You need a piezo surgery or longer drill. And I think that the dissection is done. If you want to see something different, I don't know, but dammi aspiratore. Sì, insomma. Questo è il massimo che possiamo fare con questa. Il fondo? Oh, più di così.
So regarding the internal carotid artery from here, till where can you reach, sir? Till the lateral foramen, is it? Foramen lacerum. Can you reach till there with this approach?
The anterior foramen lacerum, yeah, but you need the enlarged transpromontory approach with the microscope. With the endoscope, you can do, but you spend a lot of time to drill without any sense. So this approach you can use for small acoustic in the fundus, in the cochlea, but not for anterior foramen lacerum.
Yeah.
Dammi un falcetto.
Sir, one last thing. If at all you have to reach the clivus, can you just outline the area which has to be drilled to reach the clivus?
Yes, the clivus you have to drill off, become dark. I don't know why. Okay. I can try to, okay. In order to reach the clivus, you have to drill this bone
Okay,
under the carotid.
okay,
And you have to drill all this bone with a lot of drill and go behind the carotid, and you can reach the petroclival suture and the clivus, of course. And you can reach also the dura of the posterior fossa here. And if you drill all this bone reaching the petroclival bone and you can reach the posterior fossa dura, you are really close to the Dorello canal where run the 6 cranial nerves.
yeah.
So this is possible, but of course you can do also with a transotic approach microscopically.
And to reach the sphenoid sinus, which bone, which area has to be drilled? Sphenoid.
The sphenoid, I don't understand.
To reach the sphenoid sinus from here,
Yes, sphenoid sinus in this to reach the sphenoid sinus, of course, the best approach is the infratemporal fossa type C.
Yeah.
And you need to following all the horizontal portions of the carotid here.
Okay.
And drilling anteriorly, you can reach the anterior foramen and also you can reach, you have to drill, of course, the pterygoid and also the pterygoid plate, and also you can enter into the sphenoid. Endoscopically, honestly, it's quite boring. You can do, but
yeah.
it's
Just
not
asking which area to be drilled. That's the.
Yeah. Che cosa? Which area? I don't understand.
Sir, one of the resident junior doctor here wants to see the vertical portion of the facial nerve. Can you trace it till the stellomastid foramen?
Oh, yes. So now we can see this is the second genu of the facial nerve. This is the genicular ganglion.
Yeah.
The labyrinthine portions are here, and this is the segment of the facial nerve.
Yeah.
I in the internal auditory canal that I want to show you again. Okay, just to remove this bone, and you can see better. Dammi la curette, and you can see better the portions of the facial nerve. Let me check. That's it. So,
The vertical portion they want to know from the
yeah,
second
yeah.
genu
Now
to the stellomastid foramen.
Now we can show. I just want to show all the facial nerve because. Okay. So the facial nerve is here. You can see turn over there. And this is the labyrinthine portion running over there. You can see. This is the facial nerve in the internal auditory canal. Can you see this one? This is the facial nerve running over there. Turn here. Genicular ganglion, tympanic segment, second genu, and the third portions of the facial nerve turn under this bone. And here there is the stylomastoid foramen. So if you want, we can drill all this and we can see the third portions of the facial nerve. And so the whole facial nerve is like this. The mastoid segment of the facial nerve, the second genu, tympanic segment, genicular ganglion, labyrinthine portions of the facial nerve, and the internal auditory canal segment of the facial nerve. You can see here. Mi dai una curettina piccola. Can you see the facial nerve in the canal? Internal auditory canal? It is here. Lo vedo o non lo vedo? Ma voi lo vedete o no? Okay, so I think that we did all that we were able to do with this head.
Yeah.
Dammi un uncinetto. It's nice to see, I think, in this specimen, the facial nerve. Here.
Yeah, now it's very clear.
You can see that this is the labyrinthine portion.
Yeah.
Okay. And the porus is under over there.
Yeah.
And this is all there. And look at the geniculate ganglio and ce l'hai una cosina curva? No. Prova a darmi quello. Unfortunately, I have no Thomason dissector because to show you this. Okay.
Yeah.
This is the labyrinthine portion.
Yeah.
And dammi una lentina. Ma sì, dai, quello che c'hai, porco. And the geniculate ganglion is here, this one.
Yeah.
So if I able to remove this bone, but I need, prova a darmi una curette. Now I can try with the curette, but we need a smaller one. And no, it's too big, too big. Because in this case is the most thin part of the facial nerve. So you can ruin completely the. Dammi un falcetto. Just to check here, this is the labyrinthine. Turn under here. Turn under here.
Yeah.
You see?
Yeah, you can see it moving. You can see it moving.
And in order to drill this, you
Yeah.
need a longer one. And the piezo surgery device is the best.
Yeah.
And the geniculate ganglion is here.
Yeah.
And the GSPN is anteriorly over there.
Yeah.
So this is all the. Dammi da togliere quest'osso qua. We can remove this bone in order to see better.
He's being talk to him at least, no? What do you say? Huh? Talk to Dr. Khan. He's being alone. Can we shift to the other OT, please? Audio. We'd like to go to Dr. Khan's operation theater. He is operating a case.
Dammi un falsetto. Non ho capito un cazzo.
Dr.
Sorry?
Dr. Marchioni, sir, you have done a wonderful dissection.
Oh, thank you.
There's a big round of applause from the auditorium here.
Okay, so now we have finished.
Dialogue and attendance, yeah. Circular. Yeah, normal samay.
Thank you very much.
Thank you very much, sir. Thank you. Thanks a lot.
Okay, so thank you very much.
So now we move on to Dr. Mubarak. Hello.
Hello.
Hello, Mubarak, Dr. Arshad here.
Hello.
Hello, Mubarak. We are with you. We have been watching your surgery from.
Can you hear me?
Hello. Hello, Mubarak.
Yeah. Hello.
Yeah, we are seeing your surgery.
Yeah, can you hear me?
Yeah, we can hear you.
So I hope you must have seen the all steps.
Yeah, we are watching.
So I have completely elevated the tympanomeatal flap almost to 360. You can see the erosions on the incudostapedial joint. There was a tympanosclerosis in the anterior, in the superior, posterior, superior, posterior, inferior area. Chota section. I have removed everything. So I have cleaned almost. See this?
Yeah.
Now,
Mubarak, one thing I wanted to ask you.
Yes.
How far laterally can you elevate the anterior canal skin with your endo hold?
How?
how far laterally can you elevate the anterior canal skin, not the rest of the 270. I'm talking about from 12 o'clock to 6 o'clock anteriorly.
So 6 o'clock, 12 o'clock.
Anteriorly, not there.
Anteriorly, I go almost 360, but I keep the flap. Just so I will show you. Huh? See.
To see the entire bony rim of the anterior canal wall.
Yes. So you have to look
Yeah.
at huh?
That part, yeah.
Almost
the hidden part, not there. From there to down.
This one.
Yeah, that entire stretch from there, 2 o'clock to 5 o'clock.
Almost.
Yeah, that how do you elevate that 2 to 5?
Yeah, you have to go under the skin here
Yeah.
and flap.
Can you do that and show it?
Yeah, under the skin, and don't touch this. Otherwise, the whole cuff will come outside. So I have kept the flap here between the 2 o'clock to 5 o'clock. And from here, I have undermined. See this?
No, you place back the flap on the posterior canal wall. Can you replace back the flap? The entire flap.
See this. First, you see this, okay? I have elevated completely.
No, see, Mubarak, what happens, you know? There will be one thick mucosa from the mouth of the eustachian tube, which will be very deeply stuck to the undersurface of the remnant TM there.
Yes, you have to scrape that. You are talking about the mucosa, na?
Yeah, separating the complete mucosa from the eustachian tube.
You're right.
Coming to the undersurface of the anterior rim of the tympanic rim.
Exactly. I'll show you because I have completely scraped it out and taken out the annulus also.
Yeah, you place back the flap and show.
Yes, I'll just repose back.
Yeah, reposite it back and then anteriorly you elevate. You see how far can you elevate? Can you go in a bit still?
Yeah, I will go a little bit. Just we will line this. Okay.
Yeah, take in your endoscope further down.
Yes, now we will go.
Yeah. See you elevate. Yeah, elevate as much as you can so that you can see the bare bone. And you should completely separate the mucosa from the eustachian tube.
Here I have completely
separated. Can you show the bare bone there?
This is only the bone here, okay? So I have taken out the annulus also. Let's go inside the perforation.
Yeah, lift it up, man. Still.
See this?
Yeah, separate the mucosa there from the
yes,
both of the eustachian tube.
We have elevated anteriorly.
From the mouth of the eustachian tube to the anterior rim, there will be mucosa there. From there, from there to there, yeah. You push it down.
From here, and the graft will rest here, okay?
You push that mucosa
This is the
down.
bony wall. This is the mucosa.
Yeah, push it down. Push it down. Yeah, that completely push it down. Even superiorly also. Superiorly.
This is the mucosa.
Yeah. See, that mucosa will be very thick in most of the cases. Now you can see the bare bone. Yeah.
A bit more. Okay.
Superiorly also you push it down. With the same round knife.
Hypertrophied mucosa.
That either you can remove or you can push it down also. That's not a problem.
No, I am taking it out because it's not good mucosa. See this?
Yeah.
Okay. So I will take this out.
Because that is the one which can be a cause for mucosalization.
It comes over the graft.
Yeah.
So that's the reason for the mucosalization. So,
even a small bit between 1 o'clock and 2 o'clock also. That is also not seen completely.
Yes.
1 and 2.
Just above eustachian.
Yeah. Above the eustachian tube.
Just we will take that out. See that's a mucosa. That's a really good point. And I try to take that out. And here comes the role of that annulus and this. Okay. So I will take this out. Just take care of it. Okay,
Yeah.
and that's out.
And between 12 and 2,
काहीतरी देतेस तू.
Yeah, it is dependent.
And you can see the part of annulus also here. Okay.
yeah.
Let's. So take care of the flap because that's very of paramount importance.
You cut it sharp.
There is annulus also, huh?
Yeah, you're pulling it, that's why it's coming out.
And some tympanosclerosis also. See this? See this, huh?
Yeah, correct.
Okay, out. Okay, looks better.
Yeah.
And we will harvest the cartilage and we'll do the middle ear endoscopy thoroughly here because it's nice. You have already seen the dissection of Professor Marchioni. So it's good wide canal, so we can do the good middle ear endoscopy. Okay, so now it will go like this. And yeah, better. Okay.
Yeah.
Yes, just again elevate the tympanomeatal flap, ballpoint. काहीतरी आहे का भाई PRF? Huh?
Hello, you want to show that PRP in this case is already done or it's
They have not drawn the blood properly. Yeah, some very small PRF sheets they have created because they have not drawn the blood properly. Yeah, how much is the sheet you have created? Only two pieces. Yeah, but I want here. See, now I will keep it in the middle ear. I have enough to keep it in the middle ear because tympanosclerosis was there. We don't know the pathophysiology of the tympanosclerosis, but here I have a firm belief that by putting the PRF sheets, it will avoid the erosions of this and take care of some inflammatory process inside the middle ear. So, see, let's go. Anterior wall, posterior wall, superior wall, inferior wall.
Can you check the mobility of the ossicle, Mubarak?
Come again?
Check the mobility of the ossicle. Just move the malleus. I think the lenticular process is eroded.
Yes, that's what to know. So I will cover it with the PRF here because this is a chronic process. Tympanosclerosis was huge completely in the posterior half. Okay, so it's eroded here, but mobility is there. Okay, see this. Yeah.
Can you flush the posterior sinus and show with saline? Flush with saline there, yeah.
Posterior?
That part you flush with saline with your curved suction tip.
Yes.
Or remove a bit of bone also, that overhang if you want to. Or just flush and see what comes out.
Where?
There, in the posterior sinus. Posterior,
anterior isthmus?
In the posterior isthmus.
Posterior isthmus, okay?
Posterior
See,
isthmus.
you have to look at the mucosa. See, I will go very near now. You need not to worry. You can go very near and see. Okay, you can see the facial?
Yeah.
Yeah. So whenever you see the nice mucosa over the facial, need not to worry that behind there will not be any problem. That's the
sometimes some thick glue you can flush out.
incus is eroded. We will put some flush, no problem. Okay.
Yeah.
Tell us.
Ideally, in these cases, the incus has to go.
Come again?
Ideally, in these cases, the incus has to be removed and you have to reconstruct. between-
No, I will not remove. I will try to preserve and cover it with the PRF, and that will form the new joint. Huh?
But you said PRF dissolves and disappears in 1 week time.
अरे थोड़ा आवाज ये करो, मुझे बराबर ठीक से सुनाई नहीं दे रहा, इसको आवाज बढ़ाओ. Yes, tell me what.
But in the previous case, you said the PRF lasts for only 1 week and then it disappears, you said. So how does
Yes.
it protect this
But,
increased
yes,
stability?
no. In the external auditory canal, it vanishes, okay? But here, it provides some growth factors. The hypothesis is that wherever you keep it over that structure, it starts functioning like that structure, okay? So if you keep it over the bone, it will start osteogenesis. If you keep it over the mucosa, it will grow the mucosa. If you keep it over the skin, it will form a nice squamous epithelium. So that's an hypothesis. So if you'll keep it over this.
But these cases will eventually have conductive hearing loss in a few years down the line.
Yes. So little bit enough. See, why to remove the incus? See this. It's nice. Why
No, once the lenticular process is eroded, whatever that edematous mucosa is there, it is giving a false sense of mobility. Once that edematous mucosa subsides, few years down the line, this patient will have a conductive hearing loss, irrespective of whatever you wrap it with.
So tensor fold. See, this is a young girl.
A perforation with a
13-year-old
necrosed lenticular process is in fact a failed cholesteatoma.
Young girl, 13-year-old. I'm not sure to take the incus. And hearing is just how much? That's mild hearing loss.
Now that is because of that edematous mucosa which is conducting the sound. Once you graft it and this mucosa becomes normal, this girl will definitely have a moderate conductive hearing loss. Just maybe 1 year, 2 years down the line.
I don't think so. We will revise then, and then we will put a vertical strut.
There is no lenticular process at all.
I know to keep it and use a
Hey, patient is out. Taking out incus for me is whenever there is, I suspect a little bit of granulations, cholesteatoma, adhesive otitis media, some pocket.
But what could have caused the erosion of the lenticular process here? There has to be some reason, no, for the lenticular process to have gone away.
If it would have been eroded little bit more, I would have wrapped it with the small piece of perichondrium, and then I kept over the PRF over that. Okay. Yeah. Okay. Yes. For such things, I will not take out the incus. So beautiful ossicular chain. Why to take it out? Let's give a chance to the nature. Yes, but if it would have been some squamous epithelium, some pocket here going, some glue coming out, and it's completely block anterior stomach, posterior stomach block, then definitely I would have taken out the incus. Okay.
He is the expert. You have come to listen to him. Let him do the job. You asked the question, you can ask him afterwards. So going on and on and on. There was a gap with the
Yes. See, it's a good movement. Huh?
I do not agree. This is Arun Gadre. I do not agree with your Dr. Harsha. I do not agree that you should, I agree with Mubarak. I don't think if you have good bone, I don't think you should sacrifice it. I mean, there are different ways of reconstructing. You can use an appleworm prosthesis if you're worried about it. You can use bone cement. But I don't think you should take out, just take out bone because you don't like how it looks.
Yeah.
That is insanity. Don't, you have a patient on the table, a young child, and our job should be to give a safe ear and a hearing ear.
Yeah, see, this girl is a sweet girl, 13-year-old. Huh? Give her nature a chance, huh?
No, I agree with you. I think you're doing the right thing. What you can also do an arthroplasty at that level.
Yes.
And Dr. Mundada has from Nagpur has actually written a paper in the laryngoscope about arthroplasty. This is an example where you can exactly do this.
Yes.
There's not necessary to just sacrifice bones like this. Yes, correct. Correct. The third thing you can do is you can take a bone pate, put it on and wrap it with fascia. So there are different ways of doing it. There are different ways of, we all have our favorite methods of doing it. So, you are the expert and we want to see how you are doing it.
One more. Because that ossicular chain is a fantastic creation of the nature. Okay, that's typical, the gain which is achieved with this malleus, incus and stapes combination cannot be achieved with that's a piston-like movement, like putting some vertical strut or putting a porp or doing any assembly. Okay, this is the nature's best assembly. That's malleus, incus and stapes. Try to preserve. Yes, if it is a cholesteatoma, if there is, you suspect something, then, well, so that's why the otology is still interesting, because a lot of questions are not solved, and there are different school of thoughts. But we need to continue the research and following your cases meticulously. Now again, this 13-year-old girl, so you have to preserve very nice 5mm tragal cartilage for the cosmesis. Clean kar hai.
Check.
काय करते त्याला नाही एकटक उगाच करते इथं आते हे दे मला ब्लेड
Hello, sir.
Yes.
Can you show us with 30 or 45 degree?
This one? This is the endoscope?
Yes, sir. PSQ region. Yes, sir.
This is 0 degree.
Sir, we want to see with 30 or 45 degree inside anterior and posterior arithmeticus.
2.7.
Sir, we want to see with 30 or 45 degree.
You want to
inside.
see?
Yes, sir.
Okay.
Particularly PSQ region.
वो है क्या 30 डिग्री का वैसे
नाही
ते खाली घेऊन गेला होता ना तर बघा आणलं का
अनुपम आलेत का नाही आले का नाही म्हणतात
Hmm.
Sir, how you decide the size of the cartilage required?
So usually, depending upon now, this is a young child, this is a 13-year-old. Depending upon the perforation size and the canal, usually it varies from 9 mm by 10 mm. So you have to create a cartilage of at least 1.2 centimeter by 1.2. So with a simple crocodile forceps, you can just measure the size of the perforation or the canal size and keep the cartilage little bit 2 millimeter more than that. So see, this is the, you first open this. So I have a measuring grid here. See this, okay? So the completely open crocodile is here.
Okay,
One,
sir.
Yeah. 1, 2, 3, 4, 5, almost 8. 3 and 3,
Okay, sir.
7, right?
Okay, sir.
You see the canal here, 7. If it is approximately.
You measure the canal from, sir, superior to inferior or anterior to posterior?
Come again?
You measure the canal from superior to inferior or anterior to posterior, sir?
Anterior to posterior, okay? And even
Okay.
superior to inferior. So, okay, this superior to inferior is little bit more always.
Okay, sir.
Yeah. Come for sim. Come for sim.
इससे तो दूसरा फोर्सेप द्या.
इसको तुम सक्शन कर सकते हो क्या? क्या नाम? अन्विता क्या नाम? हाँ, सिर्फ इसमें तो अच्छा दिखेगा, थोड़ा छोटा ही, ज्यादा नहीं है. हाँ. So wherever I am dissecting, if you can just do the section. Yeah. This forceps is not good. ये चल पक्ष सोडू नकोस मला न सांगता. Section. अरे छोटा है तो section. So see now this for the young girl, this cartilage is around at 8 millimeter only. Okay. The thickness is 8 millimeter. If you'll take out the perichondrium, it will just in 7 millimeter or 6 millimeter. So need not to slice this cartilage. पकडताई काय करतेस इकडे? तर थोडंसं पुल करना मला इकडे.
तर मॅडमने पकडले वाटतं. पुल कर दो थोडासा.
Section. Take a time to harvest unnecessarily. Don't make a So on this side, you can nicely dissect. तू suction कर. तिथे बघ जरा. So almost separated. Yeah. Forceps कुठे गेला? So we are harvesting almost double. ठीक है?
Okay, sir.
Complete. अरे काढताना नका करू, तोडून काढाल ते सगळं काय करताय? हा काय करताय? इसको
Always use new knife, right, sir?
Yes, because once you take a incision, this Indian blades doesn't. ह्याला जरा बाजूला सक्शन नाही कर, बघत बसू नको. Okay.
Yes, nice, sir. Nice.
So you can put it on just a simple ASM grid, and all these instruments are there in the lucky draw. I hope you must have put something. Okay? So daily there are 6 lucky draws in Seocon.
Let's see, sir. My turn is on or not?
ASM grid to Rhino grid. Just put the things and yes. So there are daily 7 prizes to win, and all these innovations are there for you.
Thank you, sir. Thank you on behalf of all delegates.
Yeah. So if you can put side, see this almost 1.2.
Yes, yes.
Okay. Yes. Normal, sir. You should in the morning. You should when you are sending the resident, you should put everyone's card there. Yes. So.
Good afternoon, Dr. Mubarak. Dr. Bila Prajapati here from BJ Medical College, Ahmedabad.
Hello.
Hello, sir. Very
Yes.
nice section going on, sir. Hello.
Yep. Please.
Sir,
Go ahead.
can a small piece of cartilage be placed between the eroded incus and the stapes so that it will enhance
Section.
the rosiculoplasty?
Here, in this case?
Yes, sir. In this case?
In this case, I will not put because there is a joint still it is there. Just only the incus is eroded. So I will put as a simple PRF sheets to cover the incudostapedial joint. थोड़ा section. कुछ दे करते मला दाखवायचं. Timepass करत बसलेले ना. So here there is no need to put that tragal cartilage. But if it would have been eroded much more and there is a gap between the lenticular process and the stapes, then I would have put a small tragal cartilage piece with a hole which will be connecting incus to the stapes, and then I would have wrapped it with the perichondrium and PRF sheets. Okay.
પછી અમારી હોટલ હતી ને એ મસાઈ મારામાં જ ત્યાંનો પેલો જંગલી ભેંસ તે ભેંસ જંગલી જ હોય ત્યાં છે નોર્મલ ભેંસ હોય જ નહીં આપણા જેવી દૂધ આપે એવી ભેંસ જ નહીં જીરાફ એટલા બધા જીરાફ ટુકડે
जरा हे लाव
તો
સ્કિન હોક
ચરવા આવે છેક તમારા રૂમ સુધી બતાડું આ રહ્યું આ મારા રૂમ છે અને અહીંયા ચીબરા ચરે છે વાડ જ નહીં કે ચલો મોંઘી છે જોર મોંઘી અરે ખાલી મસાઈ મારામાં એન્ટ્રી ફી પર પર્સન પર નાઇટ $70 US. રહેવાનું તો અલગ.
एवढा मोठा needle holder.
ના હશે 15 થી 20 હજાર રૂપિયા પર નાઇટ. ફૂલ બોર્ડ જ લેવું પડે. 2 નાઇટ નો પ્રોગ્રામ કરવાનો હોય એમાં. પછી હા ઓસ્ટ્રીચ પર એક બીજી જગ્યાએ છે ઓસ્ટ્રીચ રાઇડિંગ. હા કાળિયા કાળિયા જેવા
હાલો.
એને તમે શીખવાડ્યું હોય ને
Use 5O, so almost that scar is negligible. You can't see any scar at all. And try doing this with the endoscope so that your hand-eye monitor coordination is improved. You can call it as an endoscopic suturing. It's very much important to train your brain for all these things. And hence we have developed that sheep head model you must have seen today. So everyone can just bring one sheep head and keep on doing the sheep head temporal bone section, even the nasal dissection, that is septoplasty face, everything can be learned on the sheep head because the temporal bones are now becoming rare and rare, at least in private.
Is there any legal matter by using CPAD, sir? Or we can
Yes,
get
sir.
it, we can get it easily
Which one?
for CPAD, sir?
For
Any legal document we require or we can get easily?
for sheep?
Ah, yes, sir.
Oh, there is nothing because this is you just go to the any
Okay.
shop
Okay, sir.
and take it. That's all.
Okay, okay, sir.
No need of any legal things. That's what I'm telling you. Anybody can just keep on doing dissection. The ear is very much similar to that of the human temporal bone with
Yeah.
slight differences.
Yes, sir. We had a witness
Yeah,
in
but you will get the feel of those tissues. You can all practice tympanoplasties, ossiculoplasties, facial nerve decompression. Okay. Even you can do the implant also because only sheep has got the 1.5 ton.
HP proven. He sends every
So our fellows, around more than 100 fellows who has done this dissection till now, who has come for the short fellowship, during the 7 days, 15 days, they just keep dissecting
side there is
10 sheep heads.
there is epithelium which grows. So the mucosa doesn't
And this is the way you can develop your surgical skill.
that's what they call mucosalization.
You have to train your both hands, then eye, and monitor coordination. Yes. Oh. बस फिर the cartilage है. Cartilage. तो आला का है 30 डिग्री.
नाही आला अनुपम. अनुपम फोन करा ना आता.
See how thin cartilage it is. Yeah.
Yes, yes, sir.
Yeah.
Thinner than last
For
patient.
this you need a very fine forceps, like a fine forceps. And it is very difficult to peel it off in young and this child, the children's, because it's a developing cartilage. And it is very easy to peel it off in the adult.
In young, most soft cartilage, right, sir?
Yes,
In children's cartilage is soft.
yes, cartilage is soft
Okay.
and it's difficult to elevate. Huh?
Okay.
Take a time because it's very soft. You can break the cartilage. So even whenever I use the cartilage for the soft wall reconstruction, I keep the perichondrium like this, and you can use the island, okay, for covering.
Okay, sir.
Efficiently.
PRF is not available, then we can use perichondrium.
Absolutely no. For we don't need a perichondrium here. We have a PRF. Huh? So if the incudostapedial joint have been eroded much more, then I would have used the perichondrium over that, huh?
Okay.
To cover, to create a pseudo joint.
Periosteum is better or perichondrium over joint, sir?
Come again?
Perichondrium is better or periosteum is better, sir? For joint, IS joint.
For perichondrium, huh? It's quite tough, nice.
Okay, sir.
Periosteum, if you harvest, that's good for the soft wall reconstruction.
Okay.
Okay?
Okay, sir. Okay.
Yeah. So now keep it over. How to measure like this, huh?
Yes, yes, sir.
So it's more than 10 millimeters. So again,
you have to cut.
We'll create a flap.
Sir, what is your view for harvested cartilage from another, for septoplasty from another patient?
Yes.
What is your view for harvested cartilage, preserved cartilage?
Or I don't.
I think I mean to say homograft.
Huh?
Homograft cartilage, sir.
No, I don't use that.
Okay.
I don't recommend.
Okay.
You have ample amount of cartilage. Autograft is available. Why you want?
Yes, yes, true, sir.
Yeah. So this.
Yes, sir. Me, sir. Gadre, sir.
Hello.
Be very careful. This is Arun Gadre. Be very, very careful about using homographs.
Okay, sir.
There was a case when I was a resident at University of California, Davis, where homographs were used from a patient who had been previously screened, but they missed a melanoma, which was then discovered later.
Okay, sir.
So the kidneys went to somebody, the cornea went to somebody, the heart went to somebody, lungs went to somebody. All patients were dead within 1 year because they were on immunocompromised position. So be very, very careful. And particularly in the days of, I remember when I was a houseman and registrar at Sion Hospital, we used to carry a bottle of spirit. And we had gone and stolen bones from the autopsy room. and kept it over there and we used to put it in the patient. I think this is to be avoided.
Yes, yes, sir. True,
There
sir.
I think it's unethical, and I think there are a lot of legal implications that should be avoided.
Yes, yes, true, sir.
As far as perichondrium and periosteum, perichondrium is a very interesting material. So there were some rabbit experiments that were done by Todd Skoog, who was a plastic surgeon in Sweden. And what he found was, if you take perichondrium and implant it, if you take a rabbit's perichondrium from the ear and you implant it under the skin, it stays like connective tissue. If you take that same perichondrium and implant it in the rectus abdominis muscle of the same rabbit, okay, so it produces cartilage.
That's 10 by 10.
And if you take the perichondrium and implant it in the rabbit's liver, it produces bone.
Oh, great.
So the cambium layer is very interesting. So that is the reason. So I personally like to use perichondrium. I don't like to use periosteum.
Okay, sir.
I will use periosteum sometimes if I'm not finding enough. Sometimes we have these patients with 3 and 4 revisions. Then I'll use periosteum, but I'll take it deep to the temporalis muscle. You retract the temporalis muscle above, and then you can get a nice big piece.
Okay,
Over
sir.
there is the middle temporal artery, so you have to be just a little careful about bleeding from that spot. So you
Yes,
just
yes.
bipolar it, and then you can take it.
Povidone iodine. हे वाकडा फोरसेप केला का वाकडा पिक
That case that I mentioned about was the reason why we had a tissue bank at University of California. They shut it down because of that one case. About 7 or 8 patients died.
So this is the angle which is given to the peak. Look at this. So when you rotate just little bit, it will cover the 1/4 of the circle. So to open the tensor fold, you just put it here and open it.
Okay.
That's all.
Each and every case you open, sir, like this.
Yes.
Each and every case.
Yeah. Each
Okay.
and every case.
Okay, sir.
Because
Sir, can you show us with endoscope if available?
they have taken it for the dissection. It's not available.
Okay, sir. Okay, sir. Please, sir, show us tomorrow. Okay, sir.
We will show it tomorrow. Okay.
Okay, okay, sir. Okay, no problem, no problem.
Because the lot of endoscopes are gone there for the.
Yes, yes, sir. We can understand, sir.
Okay.
Professor Khan, this is Arun. I have a question for you.
Yes.
You're doing that maneuver. Is there any trick that you have so that you don't snag the chorda tympani as it is going, medial to that into the iter chordae anterior? How do you prevent that from getting?
No, it will not. See this. You have to just go inside and open it. It is not going to.
I see.
Yeah.
Okay.
As far as because I am doing it for every case, but and I have not found out at least patients saying that I am having the problem with taste.
You know how much I love my food, so.
Yeah, exactly. But whenever I damage here, I tell to the patient.
Sir, what about your views on chorda tympani?
Chorda?
Tympani. Stretching is worst, then cutting, or what? For the benefit of juniors.
I'll tell you, that is what we were taught. But thought that stretching it is worse than cutting it. I'm not so sure that's true.
Yes. Now, betadine.
No, is that once it is cut, it is permanent.
Yes, yes, sir.
No masala.
The concentration of betadine that you're using here?
This is 0.5%.
So are you irrigating with normal saline?
Yes.
Okay. I am putting sometimes gentamicin or amikacin in irrigation.
No, I couldn't get. Hello.
Sir, is there any benefit of adding antibiotic solution in irrigation?
For this, no. This is pure normal saline, but I prefer ringer lactate.
Okay, sir.
Yeah, more physiological.
And sir, whenever we, if by chance movement of the malleus increase while separating the TM flap, then are you giving a steroid or anything to prevent SN loss?
The sound is breaking. Can you repeat it again?
Sir, while denuding the malleus, if excessive movement of malleus happened, then are you?
Just 1 minute, because there are a lot of noise outside. I can't hear.
Okay, okay, sir.
Just 1 minute.
No problem, sir. No problem.
Blade. Naya 15 number. So these are the PRF sheets. What questions you asked?
Sir, while denuding the malleus from TM flap.
Okay, denuding the malleus. Yeah.
Yeah, if excessive movement of malleus happened.
Yes.
To prevent SN loss, are you giving steroid or no?
If I feel that it is I have made it hypermobile and malleus is moved a lot, so in such cases I give a steroids. So sometimes it happens, but if you meticulously take it out, the while denuding that take a precaution, it doesn't happen.
Injectable steroid, or are you putting, sir,
No,
steroid
that's
soft gel form at the area of the stapes?
Oral.
Oral. Okay.
So just one small piece I will take to cover the incudostapedial joint. And here one piece I will keep it over the promontory too. See, it was a lot of tympanosclerosis. You can't guarantee again that tympanosclerosis will not happen in this patient because we don't know the pathophysiology. So in hope, I am putting this and somehow I am getting good result. But we have to do a lot of research on this, and we will come again with the research. At present, we are just because at present the research what we do, we create this fibrin sheet. One sheet also we send to the pathologist to count the platelets. Okay, how many platelets are there? How concentrated platelets we get by doing this? Okay, so that thing is going on, and then clinically we are appreciating the good results. So let's see. Okay. एकदम छोटा है क्या है? See, it looks like as an TM. Hello?
Yes, sir.
Yeah, it looks like as an TM. Even sometimes the cord is stretched and all. I have started using this PRF for that. So a lot of research needs to be done for this. And this is a simple research we can do by comparing, by putting this in few cases and not putting in few cases and compare. Okay. So that looks good. Small piece. तो छोटा है तो piece एकदम. Pickle. पेशेंट घूम रहा है. अभी मुझे ब्लीडिंग नहीं चाहिए, हाँ, बिकॉज इतना अच्छा ड्राई फील्ड है. सो प्लीज टेक केयर ऑफ. पल्स बढ़ गया. Okay. And now graft. त्याच्यात ठेवलाच नाहीस.
Sir, PRP sheet that put PSQ region, it can not block the ventilation pathway.
Come again?
Sir, PRP sheet that you kept on the PSQ region, is it not block the ventilation pathways are there?
No, so I told you, no, this gets dissolved. It does a function by providing only the growth hormones and stem cells. It is not going to stay there. These are just aggregates of platelets.
Okay, sir. Yeah, I understand.
You got it?
Yes, sir, got it.
Yes. We don't want this. See this, this is from, these are the lints. See this. So they have kept over the edge. So I will take it out because this is the reason for your failure. Okay. This forms the, this is the lint from your,
Yes.
yes, this is the autoclaved drips. So you should take those each and everything out.
It is very important to remove the threads, sir.
Yes.
Yes. Before putting graft, we have to examine under endoscope or microscope.
Yes.
Yes. It's very important.
Your endoscope helps in this. It doesn't allow you to keep it clean. So that's why even for cleaning the instruments.
Yes, it is very important point, sir.
What our staff uses, this is again a sponge. That is a nasal Ivilon pack. Okay. We clean the instruments with this only. Yeah?
Great.
But now they have kept this graft on these drips, which are cotton, made up of cotton. Okay, that's better. Those all small things helps you in your
Yes. Very important points.
improving the results. Okay.
Yes, true.
And this I have learned from my private practice because I am afraid of seeing the patient again.
Very true, sir.
Yeah.
Sir, this is Neil Patel here.
Yes.
Sir, everyone is in demanded to see the PRF sheet generation. Like, how do you make it?
That's already been generated.
Please show us tomorrow, sir. Okay.
Yes, sir, we will show it.
Yeah, tomorrow two things, sir. One is
tomorrow there are
angle
four
telescope
cases.
and PRF sheet. Okay, sir.
I will directly show you, but before going. And
Tell us.
whenever there is a promontory is divide of the mucosa, previously you used to keep the silastics, okay? So here you can cover it with these PRF sheets, that's all.
Okay, sir. That's good idea, sir.
Just try, this is a simple research you can do in your.
Yes, we will.
Yeah.
But we want to know, sir, tomorrow that what are the precautions to be taken to harvest the blood and to put it in the tube, and how to maintain the sterility. Oh, okay, sir.
Yes.
Tomorrow, please show us practical things.
Yes. See, this is a perfect graft, nicely.
Sir, any tips and tricks for cartilage placement?
Yeah, tell me.
Cartilage placement, tips and tricks.
Of cartilage?
Placement as a graft.
Yes. So for number one thing, you have to measure the graft. See, you have to, this is a perfect disc now, which has been created. Okay. So you measure it and create a perfect disc. For that, you need those grids to measure. Okay. You can't just make some graft and push it. That's all. Huh?
Okay, sir.
So
Any,
this,
any specific thickness, sir?
Huh?
Any specific thickness?
Thickness?
Yes.
Yes. This has already been proved by the Professor Hattenbrink by laser vibrometry that cartilage of 0.5 gives an excellent audiological outcome comparable to that of temporalis fascia. So your graft needs to be of that thickness.
0.5.
Yeah, 0.5.
Okay, sir. Is any time, sir, necessary to put F-gel in the middle here, sir?
No, I don't advise that. Huh?
You never put.
Never put.
Okay, sir.
That is the reason for the infection many of the time.
Okay.
I have seen many patients. Look at this. If it is a perfect shape, it will nicely and snugly fit.
Yes. Very nice, sir.
Huh? So now this is take care of your flap. Abgel. So whenever these things happens, use the wet abgel to moisten the tympanomeatal flap.
F-gel soaked in antibiotic or betadine, sir?
Yes, the simple saline solution or antibiotic.
Okay, sir.
Take a time to repose back because this is curled. See this, otherwise. This is a hematoma which has been created due to the infiltration. Okay.
Sir, is it not necessary to remove that reddened flap?
Which one? This one?
No, sir. Inferiorly, medially and inferiorly, sir. Please remove that gel foam. Then we can see.
Yes.
That red. Yeah, sir. That red flap.
That is an hematoma because while infiltrating.
Oh, okay.
Okay.
It's not granulating. Okay.
Yeah, no need of.
Okay.
And my PRF is, see how beautifully the cartilage is fitting if it is of perfect size. Huh?
Yes, very nice, sir.
Yes.
खूप पाहिजे सर.
आता कुठं झालं की आता संपल्यानंतर. Okay. And then 1 or 2 PRF sheets are there. एक ड्राय ॲब्जेल दे मला थोडस.
It prevents warping, it prevents
So we'll एवढा मोठा दिलास ताई. So just we will soak those small bleeding.
Somebody was asking about steroid.
What is your post-op protocol, sir? Tell again, sir. Many members are not in the morning.
So no antibiotic. If it is a little bit wet here, so I will give antibiotics. Huh?
Which
Or
antibiotic you prefer, sir? How you give?
which antibiotic?
Yes, yes.
This is simple. At present, I give cipodoxime with clavulunate,
Okay, sir.
painkiller, and antihistaminic.
Okay. For how many days, sir?
And if it is little bit wet here, so sometime and one shot of IV antibiotic during intra-op, my anesthetist give that.
Okay, sir.
And if it is for the cholesteatoma cases, I give almost
And sir, always use antihistaminic post-op?
Yes, yes.
A few people are saying that because of antihistaminic ciliary movement dampened.
No, I love antihistaminics. So
Okay.
I give and another thing, I ask patient to chew the chewing gum after 1 week so that it take care of the eustachian tube. Huh?
Okay, sir. And sir, are you advised post-op ear drops or ointment to fill the canal?
Come again?
Post-op antibiotic drops or ointment?
Post-op?
Antibiotic drops or ointment?
Usually not. If abgel becomes a dry, then I give a simple mixed antibiotic drops.
Okay.
That is antibiotic plus antifungal.
Okay.
Yeah.
And after how many days you clean the gel foam, sir?
No, I wait till it automatically goes. I usually don't remove it. It
Okay.
gets all and come out.
Okay, sir. Okay.
Yeah, need not to take it. But sometimes it becomes a hard, it becomes like as an wax when it becomes a dry. So in such cases, I give the drops so that it will come out, dissolve and come out.
Yes, yes. True, sir.
See why I don't take it now? Because I'm keeping these PRF sheets. So if in OPD I take it out, so everything will come out, because this should last year.
Yes, yes, sir.
Okay. So even if the bare bone is there, that is taken care. That's better. और कुछ है थोड़ा?
हाँ, है थोड़ा सा.
In case all these patients you give IV antibiotic because it's operated here, no? So not whatever protocol I have. This is not a good one. So we'll throw that out. Unnecessarily, we'll not create
Yes,
an environment for the infection. Okay. That is not
thread-
good. And there is some lint.
threads are there.
So lint was there. So I am throwing that out. Okay. So this is sufficient. And now we'll put the ab gel. Yes. एकदम बुडवून देऊ नको तो अर्ध अर्ध हे दे ड्राय पाहिजे थोडस मग सगळं नुसतं बुडवून दिलंस क्लीन कर अर्ध थोडस ताक पाणी antibiotics. So if there is if you find some blood, use a dry one so that, yes.
Sir, how to put the gel foam for benefits of junior, starting from which quadrant?
You first go anteriorly, antero-inferior, antero-superior. Okay. Now there is a overhang. So you have to secure this first and then come out. See this.
Yes, yes.
This is the overhang here. So
First gel foam put inter-inferior is very important, sir.
Yeah.
Yes.
Sir.
Yes.
Okay, so we're planning to move to Professor Gadre sir's lecture.
Yes, yes, please go ahead.
Yeah.
So now I will be just putting.
Excellent, sir. Excellent surgery. All we have a huge round of applause for it. Thank you, sir.
Thank you very much.
Okay,
Thank you, sir.
Yes.
Welcome Professor Arun Gadre sir for his lecture. Please, sir.
काय झाले तिथे लेक्चरच आहेत ना आता. हम्म. कट करायला नाही. हम्म.
And this is your laser.
This doesn't. It's not. Doesn't. You can.
So this was originally supposed to be a long 1 hour talk, but I'm tired of. Can I get a little water? Pani hoy to jara. But I think everybody's getting tired. You all need a break or anything? I'm happy to wait while you. क्या हुआ ऊपर ले
कम आवाज आ रही है.
अभी ठीक है? Okay. Thank you, Neil. So, one of the things that we have all learned is that anatomy is the bedrock of our specialty, right? If you don't know your anatomy, you cannot operate. That's as clear as day and night. So what happened was, I was at the Hausier Institute as a fellow, as a research fellow, and I was looking for the blood supply of the human endolymphatic sac. That was the purpose of doing these studies. So what we were doing was we were taking human heads and cleaning out the blood clot from the cadaver, fresh cadavers, and then flushing all the clot out and then injecting methyl methacrylate into the arterial system and blue in red, and then blue methyl methacrylate in the venous system. And we were looking for the blood supply of the endolymphatic sac. So I probably injected 8 heads. And, the late great Dr. Bill House was there, and he came and we actually wrote a paper on the blood supply of the human endolymphatic sac. But then what happened as a result was I had all these beautiful specimens. And before leaving for the United States, I had worked as a research fellow at Tata Memorial Hospital in Bombay. So I was a head neck surgeon before I became a neurologic surgeon. And so what I did was I said, let me start looking at the blood supply of the endolymphatic sac. At the same time, we said, well, we've got all these specimens, why throw them away? Why not utilize them to the maximum? And one of the things that I found was when you go to the museums of natural history, you see these skeletons made of sharks and of whales, beautiful white bone. Well, how is that made? Does anybody know how it is made? So there's the Museum of Natural History in Los Angeles, and I became friends with the deaner over there. And there's actually a beetle called the dermestid beetle. And what it will do is it's like a maggot. It basically eats all soft tissue. It does not eat the plastic, and it does not eat bone. And so you get a very nice relationship of the vascular anatomy as it compares to the bone itself. So you know where it is in relationship to the bone. And utilizing those principles, we've devised certain flaps and other things. So I'm going to show you one of those. So whenever we are talking about these flaps, you can either show the flap, how it's designed, or you can say, put in a case as to why we did what we did. So this is a 60-year-old lady. She's was transferred at that time I was working in Houston. She was transferred from a community hospital with aphasia and left-sided weakness. 2 months before that, she was playing cards with her friends at a coffee shop, and she distinctly remembers having severe left temporal pain. It occurred spontaneously. There was no sneezing, there was no blowing of her nose. And she saw her primary care doctor, who said, oh, maybe it's your eustachian tube and you can take some nasal steroids. So they put her on Flonase or fluticasone with no relief. 1 week later, she again goes back and they said, let's take some sinus x-rays and see what the problem is. And they found a very dark area inside of her head. So they were not sure what this is. They thought it may have been a cyst. So a neurosurgery consult was requested. The neurosurgery consult takes time. You just can't walk in the United States into a neurosurgeon's office and expect him to see that day unless you're dying from a extradural bleed or you have a brain tumor. So while waiting, she started to complain of some difficulty with her memory. She was found scanning for words, motor control on the right side. She would have her raise her arm and the right side would go down, close her eyes, and she would drop her right hand. She started dragging her lower extremity and she goes into the emergency room thinking she now has a stroke. She did have some hypertension, but what is important in the history is she was morbidly obese before and had undergone a bypass and with a 150-pound weight loss. So this lady was about over 300 pounds when she started, and she had a rapid weight loss over the previous few months. Examination was essentially benign other than the stuff that I told you, so we are not going to waste our time on that. Her ear exam, tympanic membranes were both normal. There was no fluid level, no erythema, air conduction was greater than bone. On a tuning fork test, and on Weber's test did not lateralize. Nose and throat exam was essentially within normal limits. This is what you see on a coronal scan. You can see this is, maybe I should just walk over to the, oh, there it is. Okay. So this is a coronal scan, which shows, you can see the cortical bone on the outside. You should have a very distinct white sheet of bone over here, but what you see is there's a big area of air inside of her temporal lobe. This is the external auditory canal. Over here, you got a pointer? Thank you. Thank you. So this is, you can see the basal turn of the cochlea here, the superior canal, horizontal canal, seventh nerve, and what you can see is a big blob of air that is a pneumocephalus in the lady's brain. You also had some scattered air bubbles. You can see something in the on an axial scan. You can see an air bubble in the internal auditory canal, something in the region of the clivus. So there was a lot of air all over the brain. You take another image, and what you see is a true coronal scan shows this pneumocephalus again. When you go back, there was air in her ventricles. There was air around her spinal cord. Okay, pretty extensive pneumocephalus. And I looked at the literature, and there are very, very few cases of spontaneous pneumocephaly. I saw 2 in 1 month. This is one of them. I've never seen one before, and I probably never will in the rest of my career. So over there, the first thing you're thinking is this a tumor? Is something eating into the brain? Why did this pneumocephalus even occur? And so we got an MRI, and here you can see on a T2 weighted image, you can see the CSF with air in the ventricles. Makes a nice picture, does not add anything to our findings. All right. So we decided to put her on, one of the ways of treating these pneumocephalus cases is you put them on oxygen to try to displace the nitrogen in the hopes of it getting resorbed over time. So that's standard, or you can use carbogen too, but it gives a headache. So this lady is already suffering. So we put her on oxygen, waited for a while. The pneumocephaly became smaller, but did not go away. And her symptoms continued. So then we decided to operate because we figured that probably this spot is going to be in the middle cranial fossa, through which the air got sucked in. Now, we know that morbidly obese people have raised intracranial pressure. And our working hypothesis at the time was that if you have a sudden drop in weight, you have the opposite effect. In other words, instead of having raised intracranial pressure, you drop your intracranial pressure. Now you have a pressure differential between the air pressure in the middle ear and because obviously air has to move in from an area of high pressure to an area of low pressure. And that's probably the explanation for what happened. So I walk into the operating room. We had a new, a young neurosurgeon from Turkey. And being the senior person, I have the prerogative of walking into the room a little later than everybody else, right? And this is what I see. There's an image guidance system that she used. I said, why the hell are you putting an image guidance system? When you have bony landmarks, for a neurosurgeon, image guidance is very important because they're operating in a bowl of pudding, right? The brain is like pudding. So you don't have any landmarks. Once you're in the brain, you don't have any landmarks. But when you're operating between the dura and the brain, you really don't need it, right? So I just walked in and I said, I think we better get rid of it. You got to be polite about it. You don't have to be nasty about it, but you can basically tell them that it's not necessary. So this is our draping. This is the left ear. You can see the incision being made like this. I generally tend to, I do not like to have an incision on an incision. One of the problems with middle cranial fossa surgery is what? You get a scalloping in the temporal fossa. In fact, there is a prosthesis that has been made because it cosmetically looks horrible. It looks as though somebody has taken an ice cream scoop and taken out tissue from here. Why does that happen? It happens because the muscle over here, the temporalis muscle, becomes necrotic and dies over time. There's also a fat pad in the temporal region, and that fat pad disappears. So that is the reason why I decided to devise this operation. So we make this incision in this direction. That is our draping. You're also, for the juniors in the audience, you're sitting at the head end of the table in the middle cranial fossa. So you're looking down, the feet are away from you, and you're looking from up top at the floor of the middle cranial fossa. So this is your curvilinear incision. It is based, you're going to rip up the superficial temporal artery, but you do have a very rich supply from the occipital artery and the postauricular artery. So you have a fairly good blood supply to this flap. I've done now probably 50 cases using this technique and not had a problem. You obviously want to stay behind the hairline. In males in particular, when there is a receding hairline, what you're concerned about is you don't want to have a big scar in front. Your aim should always be at the end of the operation that your patient should forget you. They should not be thinking about you. In fact, one of the things I tell my patients is, you need to fire your doctor. You need to, you say that you don't need your doctor, then I've done my job, right? So clearly you want to stay away from the seventh nerve. The seventh nerve, you know where the landmarks are. And so this is what we do. We generally elevate a flap. I tend not to use big retractors. I like to have a low profile system. It's called Lone Star hooks is what we use in order to hold the flap in place. The next thing we did was you elevate the temporalis fascia as a separate layer away from the muscle, all right? And you preserve the branches of the superficial temporal artery if you possibly can. Next, you elevate the temporalis muscle. This is now the temporal fossa over here. You leave a cuff of temporalis muscle along the temporal line. If you do not do that, there's no place to sew it to. You cannot sew it to the periosteum. So you have to leave a little cuff of tissue and you elevate the temporalis muscle. Next, what you do is you have to raise a bone flap. Now, there are different ways of raising a bone flap. In those days, what we did was, so this is the level of the external auditory canal. It's about a 5 by 3 centimeter flap. If you're doing an acoustic neuroma, you're going to take maybe a 5 by 5. But what you have to do is, this is anterior. This is towards the nose. That is towards the occiput. You've got to angle it upwards If you do not angle it upwards, you start getting into the air cells of the mastoid, and then your craniotome doesn't work. The other thing that happens in these morbidly obese patients is that your dura is very badly stuck to the periosteum. And so if you're not careful, as you will see in this case, we tore the dura. Okay. So now the brain, if it is supported in cerebrospinal fluid and you put some pressure on it, it takes that pressure well. On the other hand, if you put a retractor directly on the brain, on brain tissue, it is a terrible situation. So this is what we did. We are doing the craniotomy with a craniotome. And what you have to do when you're using the craniotome, which is, I mean, I was supervising the junior neurosurgeon, which is you need to rock it. There's a foot plate that basically rocks. And as you rock it, it dissects the dura away from the inner table of the skull. And you don't just go hold it and go zzz, you do that, you will tear it because the inside of the skull is not a flat line. It is undulating. Okay. So there you have it. Toward the dura. Now what happens? Now you're spending 1 hour because you wanted to go fast. We spent 1 extra hour now repairing the dura with a dural patch. All right. This is elevation of the dura along the floor of the middle cranial fossa, and you can see multiple holes. Those holes often have arachnoid tissue and was probably the site through which the air had gotten into intracranially. At the base of the flap, what we did is we put a blunt hemostat out, a curved hemostat, and just split the muscle. It's almost like doing a McBurney's incision for an appendix, where it's a muscle splitting incision. And then what we do is we take stay sutures and try and deliver that fascia through the muscle. In the old days, we used to take the whole muscle and throw it into the middle cranial fossa. But I don't do that anymore. It's thick. You're disturbing the function of the muscle. So this is what you do. You've delivered the muscle, the fascia, the temporalis fascia through the muscle. And then what you do is you lay it in that defect, over the defects in the middle cranial fossa, like you see over here. And then the rest is history. You basically put your bone flap back, you sew your muscle. Now, when you're sewing this muscle back, you've got to be careful. You've got to take horizontal mattress stitches. If you do not take horizontal mattress stitches, the temporalis muscle tends to shred because you're in the axis of that muscle. Because as you know, the temporalis muscle in the front gives vertical fibers, but in the back it's horizontal fibers, right? So that's a technical point that you've got to do. We close it with Vicryl, and the incision is sutured. And this was the patient at the end of the case. As a matter of fact, this resident of mine, that was me, and those days I had I used to have a beard too, just like Singh Saab in sitting in the front. I used to have a whole hair, gradually it has gone away. My hair from the top have gone, the hair from the ears have started to come out. But that's just where we are at. So that was me in Texas. That this fellow is now in Beaumont, Texas. He's in private practice, and she now goes and sees him. He was the resident involved in her care. So I've over the last 15 years, I've been able to keep in touch with her, and she's now fairly old, but still doing very well. This was what she looked like at 2 months follow-up. You can see the incision, and I don't cut with the knife. I cut with the Bowie, frankly, and I've never had any problems with it. I do not use Rainy clips. This is what she looked at a 12-month follow-up. Again, notice there's no temporal wasting at all. And now I have a whole series of cases. In fact, we're going to go back, and one of my residents is looking at all our numbers, and we'll probably have an article in PRS or one of these journals pretty soon. So what is the vascular basis for this? So this is one of those specimens that I made, where we had injected methyl methacrylate into the carotid system. What do you find? When we talk about the branches of the external carotid artery, we've always been taught about the superior thyroid, the ascending pharyngeal, the lingual, the facial, the superficial temporal, the occipital, and the postauricular. So we all know these branches. But when you look at Gray's anatomy, what do you see? You see one artery. You don't see this. So what I noticed was every single artery, if this is the facial artery, It's beautiful in its design. I mean, how God has designed this is absolutely stupendous. Because this, if you see the areas that are flexible, things that move, the artery has to stretch and so it's always a little longer. It's always more tortuous in these sort of areas. And then what happens is every artery is accompanied by a sister vessel that is supplying the periosteum and the bone. All right. You see the same thing over here. Superficial temporal artery, there's an artery that's supplying the periosteum and bone. The occipital artery, the mastoid process, you can see the occipital artery that is has a sister vessel that supplies periosteum and bone. Why is that important? Now we can exploit this anatomy to our advantage as surgeons. So in other words, we can move tissue if we split it and move tissue separate from each other while still maintaining its blood supply. That's why. So for example, I have utilized the postauricular artery to design a flap like this. Instead of just drilling away the bone, you use an osteotome, raise a flap, and you can flip it in like a trapdoor, and you can create a posterior canal reconstruction if you so desired, right? You can take a flap based on the middle temporal artery and do lateral orbital wall reconstructions. So there are lots of things that you can do utilizing this principle. So we took it a step further, and what we did was we injected a whole head, and then we dunked it in hydrochloric acid. What does the acid do? It takes away the soft tissue in the bone. Everything goes away, right? And then you get a mass of plastic. But there is a method to this madness, right? So at first sight, you can see that this is the forehead. You can see the eyelids over there. You can see the nose, the lips, the chin. You can see the submaxillary gland. You can see the upper pole of the thyroid gland. You can see the outline of the pinna. It looks really, really a mess of arteries, arterioles, and capillaries. Well, so I decided to look at it under the microscope. And here, all of you are watching this, are sitting inside the head, looking out from inside the head out at the world. And what do you see? You see the middle meningeal artery over here. You see the deep temporal artery over here, and you see the superficial temporal artery in the distance. Again, showing this layered blood supply to the temporal region of the head. So this is that same specimen before I broke this. Again, showing the named vessels have duplicate supplies. It's not just one vessel as is shown in Gray's Anatomy. A lot of us have done for Eagle syndrome, we've taken out styloid processes through the tonsillar fossa. Next time you do this, look, think about this picture, right? What do you see over here? I was lucky to find one. You can see you're now sitting inside the head. It's half a head. You can see the maxilla, the mandible. You can see the ossified stylohyoid ligament. You can see the internal carotid artery and the external carotid artery going there. You can see the occipital artery coming off of it. And you can see how that styloid process basically goes between the internal and external carotid artery. So it's perfectly okay to do, but you really have to hug that styloid process when you take it out. So keep this in mind so you don't injure the carotid artery. So I think I was given 10 minutes. I think I've gone a little over, but I hope this was useful. This we have used now for epidermoids. We've used it for middle fossa reconstructions. And this a picture I like because it was taken not very far from here. It was taken in Lohegad in the Sahyadri Mountains when I was a medical student. I was hiking, and I actually watched this spider catch this insect in real time as we were hiking. So so this is particularly poignant for this talk. If you have any questions, be happy to answer those.
Thank you, sir. That was a wonderful talk. Well, now we have DKC oration, that is Dr. Khan Creations oration by our very own Dr. Sapna Parab ma'am. I welcome her to the stage, and I would like a big round of applause for her. Thank you. निकाल दो.
Your mic, take a mic.
I would like to call Dr. Professor Gadre sir. Sapna ma'am would like to. Agrawal sir, please sir, facilitate Dr. Gadre sir with the memento. Felicitate, sorry. Push करना है, that
3705. Yes. Yeah. Good evening, everyone. I hope you all enjoyed the surgeries in the morning as well as the cadaveric dissection, that is both microscopic as well as the endoscopic. So, as I said in the morning in my opening remarks, this is the first time we are holding an endoscopic ENT conference, and we are going to have 4 orations. So this is the first oration for today. That's the DKC oration based on Dr. Khan's Creations oration. Should I go ahead? Yes. Okay. So in this presentation, we are going to talk about the innovations which Dr. Khan and myself, we have done over last few years. Some of them have been patented, some are trademarked. I would like to just mention about our journey, which we of last 13 years since last 2012. So the title is Innovations in Endoscopic ENT Surgery. Myself, Dr. Sapna Parab from Talegaon, Dabade. So the claim is whenever I say endoscopic ENT surgery, I exclusively mean endoscopic two-handed surgeries which are done with our endoscope holders. Is that okay? So we are having few endoscope holders, that is endo hold, just attach, slice it. Okay. So coming to what is an innovation? Innovation is nothing but it's a process of translating an idea or an invention into a good or a service that creates value or for which the customer will pay. So innovation is nothing but it's a simple new idea, device, or a method which makes your life simpler. So definitely the question would arise, why is innovation required in ENT when there are already so many time-tested techniques which are giving you good results? So when we are having microscopic ear surgery, and obviously everyone is getting good results with those, why do we have to go to endoscopic ear surgery? When everyone is using temporalis fascia and getting good results with temporalis fascia, what is the need to have a cartilage? And that too, when you're having a cartilage, why do you need to reduce the thickness and use a slicer? So it's nothing but the answer is to make the life simple, to answer certain difficult situations which you have over certain period of time. So limitations of single-handed endoscopic ear surgery. First of all, as the name says, it's a single-handed. For long duration surgery, your one hand is holding the endoscope and the second hand is doing the instrumentation or holding the instruments. So obviously in 1 hour surgery or less duration surgery, definitely it is beneficial. It doesn't pose much of problems, but In long duration surgeries, definitely there would be fatigue associated. Or think of a situation in which you are having bleeding and your one hand you're holding the endoscope and the other hand you're doing the instrumentation. And if there is a bleeding, obviously you'll have to stop with your instrumentation, do the suctioning, take care of the suction. Or imagine another situation in which you want to do the drilling. One hand is holding the left, that's the non-dominant hand is holding the endoscope and you're doing the drilling. Then there is irrigation which is collected over there, the fluid. So again, you'll have to stop the drilling, do the suctioning. So obviously there are certain situations in endoscopic ear surgery where you definitely feel the need of two hands, because as we all know, two hands work complementary to each other. So microscopic technique, that is two hands in which your left hand would be holding the suction, the right hand would be holding the instrumentation. The same technique is employed for endoscopic ear surgery. So how to take care of that? So you have panoramic view of the endoscope, plus you have two hands to use, which are both utilized during the surgery. So simple solution is to hold the endoscope with a instrument that's known as an endoscope holder. So the journey started basically with Just-Attach. Just-Attach is nothing but it's a universal attachment plate which was initially developed in the year 2012, and we applied for patent in the year 2013, and we received the patent after 9 years in the year 2022. So it was a long journey of the application. So definitely please. So Just-Attach is nothing but, I would show you the pictures. It's basically, you have microscope. So you have to use all the actions of the microscope and you want to convert the microscope into an endoscope holder. So the basic action which we utilize is the gas spring action, the up and down movement, then the rotation and the fine focusing. Fine focusing is nothing but previous one. Fine focusing is nothing but your rack and pinion. It's like your histology slides, which you used to just move it with the rack and pinion, just 1 millimeter wise. So same thing, other than having it horizontal, if you place it vertical, it will allow your movement of the endoscope millimeter wise into the external auditory canal. So it's not just any endoscope holder, it's basically giving a dynamicity, it's controlling your movement into the external ear canal, and it's not giving it a jerky movement. Next one, no? This one. This one. So other situations, what we need, for which we have developed some innovations, that is slicing the cartilage. Then another one of our other innovation or improvising the technique is protecting the ear canal and the endoscope during drilling from the rotation burr. Next is measurement of and giving specificity to the graft size when you use them during surgeries. That is, whether it is tympanoplasty, you measure your graft size, what you put for reconstruction, whether it is septoplasty, you should know what size you're placing. So I'm going to talk into detail. Then another instrument which is not yet developed, but it's in the process, that's modifying the electrocautery for preventing the damage to the skin. So some of the, okay. So I've just spoken about Just-Attach. What you can see over here, the first instrument over here, that was the one which was developed in the year 2012. It looks very primitive rather. Then there was advancement to it. It's known as Just-Attach. Just-Attach is nothing but combination of two words, just attach. You attach a plate to an already existing microscope and convert that microscope into an endoscope holder. Basically, you're going to use it just as a support system for your endoscope. It will be holding the endoscope. It won't be working as a microscope unless you want to use it simultaneously during certain phases when you feel you have to go back to the microscope. So it helps in the transition journey when you're shifting over from microscope to endoscope. So Slice-It is the instrument which we have devised for slicing and achieving precision during tympanoplasty. Endoplay. Endoplay is nothing but, you must have seen today while Dr. Khan was demonstrating the instruments which are used in micro ear surgery or endoscopic ear surgery. We have imparted certain angulations at the tip, at the distal end of the instruments. That's known as, trademark together as endoplay. the sickle knife, or if you see the flag knife, the circular, certain angulations are given which will make your life easy when you're doing endoscopic ear surgery. Next is the ASM grid, which is a measurement grid, which is used for measuring the grafts. Next is rhino grid, the one which we use during rhinoplasty. Auto shield is nothing but the protection given to the skin and the endoscope when you're doing the drilling. And endovent that is yet to be developed. So this is how the initial journey started when we started first with the cartilage technique, and it was documented in the American Journal. Then came series of changes in which we developed, revised our own techniques. So these are few of our publications. Even we did an interesting study. Basically, when we were doing the cartilage tympanoplasty, we realized that when we were slicing with the, we were slicing initially with the Coors cartilage slicer. So certain cases, whenever I used to slice, I realized that I used to get wonderful 2 pieces of slices. But in certain patients, whenever I used to use the slicer, I used to get bad pieces. Not that one was getting wasted or rather too thin and the other one was adequate enough. So then we conducted a study just to know why the slicing is not good in certain patients and why it is very good in certain patients. When you're using the same thickness plate, why? So the reason was the variation in the thickness of the tragal cartilage. So in about 20 to 30 cases, I don't remember now, but what we did is we harvested extra piece of cartilage in every patient, and a specimen of that was excised and given to the assistant. It was recorded. The thickness was recorded in 4 dimensions. That is when you harvest the cartilage, top, middle, bottom, and the overall thickness. So in each patient, we had 4 thicknesses which were taken, and it was tabulated considering the age and the gender. And we realized that less than 15 years of age group, the thickness of the tragal cartilage may vary between 0.8 to 0.9. Between 15 to 30, irrespective of the gender, it was something between 0.9 to 1, and more than 30. That's because of your thick perichondrum. Basically, it was more than 1.1. So according to that, we devised a formula which said, if the child, or if you're operating on a pediatric patient who's less than 15 years of age, and you want to do cartilage slicing in this patient, you have to use a thickness plate about 0.3 or more, because the cartilage slicer is provided with 3 thickness plates. That's 0.1, 0.2, 0.3. So 0.3 you have to use in the child. If you're doing it in a 15 to 30-year-old adult, then you can use either 0.3 or 0.2. And in case of a more than 30 years of age group patient, you'll use either 1, or the best thing would be, if you're having a good thickness cartilage, obviously it will be more than 1. So you just place the cartilage into the slicer. You just slice it without any thickness plate. So whatever is excess of 1 mm would be sliced off first. And then you'll be having a perfect slice of 1 mm. And then you use your respective cartilage thickness slicing unit, that is either 0.1, 0.2, 0.3, or 0.5. And then you place into it, and then you'll get the respective one. So this is a simple formula to achieve the precise thickness when you're dealing with a particular age group. So just as this is how the designs look, these are the sketches, how it turned from paper into from directly the sketches to the OT instrument. And this has been published in the Indian Journal. So basically what Justache does, it doesn't do anything of its own. It just does the work of holding an endoscope, but it takes or adopts the movements of the microscope. That is, it takes the help of the horizontal arm to do the up and down movement, the fine focusing or the rack and pinion for the millimeter-wise movement into the external auditory canal, the joint at the horizontal arm and the vertical flow, it gives you a sidewise movement. So basically all the movements of the microscope, up and down, rotation, angulation, all the movements which are there within your microscope are imparted to that of an endoscope with the help of this universal plate. So I think I'll not go into the details of the video, I'll go ahead. So then the second thing which we started doing was, I'll just go behind. Okay, if you see over here, the slot which is there, it will be holding the endoscope. So basically, if the main problem with Justach was it was attached to a bulky microscope, which was having its own optical unit. So basically, when you're operating, there are high chances that it would not be, it would be bulky enough to obstruct the movement as well as your visualization over the monitor. So the next thing to it was a side arm which was attached, or it was a detachable extension arm which was holding the endoscope. So it was far away from the main body or the axis of the microscope. So you can fix it in a particular angulation away from the main axis or the main body of the microscope. So this was the Justach ASM2. So this is how it looks. So as you can see, it's far away from the main body and it is further away, so it wouldn't interfere with the working of the ear. So this is how it looks. So these are how the initial sketches, how they looked and how the idea was converted from paper into an instrument. So then initially, though it was used for ear surgery, we then started extrapolating its use for the nasal surgeries, for tonsillectomies, and also for laryngeal surgeries. So as I said, Justach was the initial work when you are shifting from microscopic to endoscopic. So, but when you want to absolutely go for endoscopic, so next step to it was endohold. Endohold is nothing but it's a portable one. Now, if you see an endohold, it's nothing but it's a copy or looks like your microscope. It has a horizontal arm. It has its own movements which are similar to that of a microscope, but it does not have the optics of the microscope. So it is named as Endohold GS201B. GS because it is based on the gas spring action, that is GS, and 201B, that's the rack and pinion action, which is allowing its movement into the ear canal. So similarly, as it allows the movement into the ear canal, the same advantage can be used to allow its entry into the septum, that is when you're elevating the flap, you're having sharp spurs. You need not do it by the conventional technique or by the loops. You can directly use the endoscope, focus on the spur, and without any damage to the flaps, you can elevate a good flap. So these are the various parts. It has a vertical part and horizontal part. Then there is the, okay, this is the vertical part. This is the horizontal part. This is the gas spring one. These are the three movements over here. That is the angular movements which are given and the sidewise. And you can see this blue part over here. It's nothing but your vertically placed rack and pinion, which will allow the movement into the biological cavity. Okay, so all of you all have seen beautiful surgeries today. I wouldn't go into the details of this. So the quest for perfection continued, and we have different endoscope holders for better results or better applications. So this is Endohold FLX201B. Why the term FLX? FLX because it has two flexible ends which are being guarded or controlled by this magical clamp. If you loosen this magical clamp, both the arms would loosen up and fall down. So the utility of this is especially in case of rhinoplasty or your tonsillectomy or laryngeal surgeries, where after achieving a particular position, you wouldn't alter it much, unlike that of your surgeries where you constantly need the movements. So this is basically once you fix it, you retain in that position. So it's Endohold FLX 201AB. A basically when it does not have the rack and pinion action, and B when it is provided with the rack and pinion action. So you can see this. So now this is Endohold GS201B, some of the pictures. So as you can see, there are today, which is being demonstrated or was there at the DKC stall number 15. That's the most refined one, which you can see over there. So we have been using septoplasty. Do you want to see the video or should I skip the video? Okay. So this is how it looks. So basically the assistance is very much minimal. The endoscope is being held and mounted onto the endoscope holder. The left hand is holding the Killian speculum. You can see it over there. Next is focused onto the screen where I'm elevating and the flaps, especially over the spur. So definitely the question would come, why do you want to use the endoscope holder? You can obviously use endoscope in one hand and use your suction elevator. But the precision what you get with the endoscope holder, the optics is much more. It will be demonstrated on Sunday. So we have even used it. We do not do much of nasal angiofibromas, but couple of the ones which we have done, we have used the endoscope holder. So the two hands plus the endoscope. So it does definitely have a benefit. So what are the challenges now? So as we have been using the endoscope holder over the so many years, we have realized obviously we should have certain or rather perfection, like the Karl stores what they have, or like how Carl Zeiss gives. So definitely perfection continues. So over the next few years, we are planning to have the endoscope holders, which would be voice controlled or which would be having robotic actions. So hopefully in the near future, we'll be having some new additions to our endoscope holder. So now coming to Slice It, as you can see over here, Slice It is not just a slicing device. It's not just slicing. It has multiple applications. You can see over here, there is a measurement grid over here. On the inner aspect of it, it's a measurement grid again. The Kurz slicer, which is there, it is just a rectangular bar, which is not having the flanges. The importance of this flanges is it's providing it with the measurement grid, plus on the sideways, you can see on opening up the cartilage slicer, that's a slice it, there are multiple wells, what you can see over here, or rather circular impressions, which are ranging right from 4 mm onwards till 10 mm. So what these are for? So if you have a cartilage with you and you want to give it a particular dimension of 10 mm, 9 mm, 8 mm, 6 mm, 5 mm. So I would place my cartilage over this and remove the peripheral part so as to give a particular size of 10 mm. So obviously, again, the question would rise, if you're having 10 mm cartilage and 9 mm, okay, why the hell you need 5 mm cartilage? Yes, it is required, because if I want to do ossiculoplasty, because we have been doing ossiculoplasty not with the TORP or the PORP, we are using only cartilage. So when you're using cartilage over your stapes foot plate or over your stapes superstructure, you should have a particular size. So in that case, we use the circular one of 5 mm, make a slot into it of about 1 or 2 mm and place it either as a cap over the stapes superstructure, or we make it into an umbrella for the over the foot plate. So we have a little bit changed the terminology and we call it as the 3A, 3B. So this is, when you say 3A, it is not the one which is in the books. This is our classification which we have made. So 3A is the type when you use it for stapes superstructure is present and you're placing it as a cap over the stapes superstructure, and 3B, an umbrella which is placed over the foot plate. So again, this cartilage umbrella which is made, it has specific dimensions. So I'll go ahead with it. I'll tell what it is. So again, this one would help in measuring. So from one particular cartilage of 10 mm or 12 mm length or dimensions, you can design multiple grafts. That is, by removing perichondrium on both the sides and not slicing it, you'll have 3 grafts. If you directly slice it in between, you will have 2 cartilage perichondrium grafts, which you can remove the peripheral parts and make it into an island. Or you can use it for ossiculoplasty just by taking 5 mm, make a slot into it, use it for 3A, or make a slot into it and pass a vertical bar and make it into a 3B, that's first over the stapes foot plate. So these are the multiple different techniques what we use for ossiculoplasty. And since I have been working with Dr. Khan since 2007, and at least I have not used TORP or PORP since then. We are working with the cartilage, and believe me, it does give promising results. And we also use it for multiple other techniques, that is for reconstruction of the soft wall after removing the cholesteatoma, for mosaic tympanoplasty, for inside out cholesteatoma also. So now another thing over here. So there are multiple wedges over here, what you can see, and each of them is having a particular dimension. So if you place it over a particular one, it will help you in reducing the thickness, or rather length of a particular piston, or if you're working with a Teflon torp or pop, obviously it would allow you to cut it at a specific length. Okay, you can see it over here. So from one single cartilage, you have multiple pieces which are created, and this cartilage can be used either for type 1 tympanoplasty, type 2 tympanoplasty, or your ossiculoplasties, and also for your soft wall reconstruction. In most of the cases, we do use only the tragal cartilage, but definitely in certain cases, tragal cartilage wouldn't suffice. So in those cases, we do use the conchal cartilage. So this is a simple diagram over here, what I was talking about. You have a cartilage of 5 mm circular dimension or a triangular one over here. You make a circular slot into it with a punch rod, maybe of 2 mm thick overall dimensions. So your 5 mm cartilage would have a slot of about 2 mm. So inside this, if you put a vertical strut about 5 mm in length and 2 mm in thickness, and when this is placed into it, it looks like an umbrella. And this is the one which is placed over the stapes foot plate for ossicular reconstruction. And it's known as the umbrella technique. So you can see in the bottom pictures over here, the same cartilage is placed over the stapes foot plate, and it's being reconstructed with multiple sliced pieces of the tragal cartilage. So it's being used, the tragal cartilage is being used in the form of mosaic pattern. Okay, endoplay. So in ES, that is endoscopic ear surgery, we work in a canal of 7 to 8 mm. And when you're doing two-handed ear surgery, you're again, this small canal of 7 to 8 mm, you're again introducing two instruments and making the life little bit difficult. So how do you take care of certain situations in this? One thing is by taking external ear canal stay suture. So that would give you additional room for your instrumentation. Secondly, what you can do is you can give bend to the certain instruments, because for example, if I'm working with an endoscope and into a canal of 7 to 8 mm, and I want to go anteriorly. So if I'm working with two instruments and I want to go anteriorly without compromising the visualization, that's not possible with the straight instruments. So I need to give angulation at the distal end of the instrument so as to allow the visualization without compromising the actual steps. That is, you must have seen in the previous case when Dr. Khan was operating, that was, we have given bend to the side knife, to the circular knife, as well as to the sickle. So not only it allows the elevation of the flap or the separation of the annulus from the flap, but also in removal of cholesteatomas from certain hidden areas, because the angulation does help without compromising the overall visualization. And another thing is when we work in vertical axis, the instrumentation is under the lens if you're using the straight instrument. So again, it would hide the field of, it would obstruct your field of vision. So I'll just show these few pictures in which we have given certain bend to the instruments. So you can see over here, this bend is given, it will help to take care of the, especially taking care of the anterior part of the tympanic cavity, also in cholesteatoma. Over here, you can see we have given a bend to the suction tip. So we have different suction tips with different angulations. We have given the U-shaped bend or W-shaped. So definitely it would take care of the anterior isthmus, the tensor fold, and taking care of the pathology in the anterior part or the isthmuses. So this simple, next one is auto shield. Auto shield is, it's a very simple instrument. It's just made up of stainless steel. It's like your sleeve, which you place over your handpiece, and it is provided with a suction irrigation. That is, it is having the irrigation one chamber over here, and another one, it's not seen in this picture. There's a suction plus irrigation chamber. So when you place this over your handpiece and then you apply your burr and you just tighten it up, it will give protection to your lens of the endoscope, as well as it will prevent damage to your skin during drilling. Plus, another important advantage is it has simultaneously having the suction as well as the irrigation. So it's more beneficial in single-handed ear surgery than two-handed ear surgery. So this is another simple innovation which has been developed. So next, coming to rhino grid. Rhino grid is the one which we use during rhinoplasty, as the name indicates. Rhino grid MSD. MSD is measure, slice, and dice. So one side of it is having the measurement grid, which is measuring about 12 by 12 centimeters. And the other side is having, it's a stainless steel block. One side is a measurement grid and the other side is having multiple depressions. As you can appreciate, the central part is a square shaped depression into which we collect all the grafts which are diced or sliced, and surrounded over the periphery are 4 wedges or gaps, what you say, but each of them is of different depths. One is of 3 mm, one is of 1 mm, 1.5 and 2 mm. So what's the importance? When we harvest rib cartilage, it's difficult to give you accurate thickness in each. So you place the rib which is harvested into that. If in case if you want a thickness of 3 mm, you place that into this wedge and pass your blade over it. So obviously the one which gets sliced, the bottom one is 3 mm. If you do not want it for 3 mm, you want it for rim grafts, you do need something of 1.5 mm, then go to another one that is 1.5 mm. If you want little bit thinner than that, then you can go for the other one. So these are just the permutations. So simple things which would give precision, because precision should not be limited to few. It should be also for each and everyone who is also in the learning experience. Next is rhino gavel. So rhino is during rhinoplasty and gavel is a hammer. So the difference of this instrument or this hammer is it's made up of hilum. Hilum is a bactylite or polyoxybenzyl methyl anhydride, which was the first synthetic plastic which was made. It has extremely high thermosetting properties. It has been used in the aviation industry and is absolutely good. So it is autoclavable and definitely better, because when you're doing a rhinoplasty, when you're doing using the chisel and the hammer, definitely the forces are better transmitted with the help of a material which is not the same one. So over here, you can see rhino gavel in action during lateral osteotomies. So this is yet to be made. This is just suspense to be unfolded, probably for next Seocon. This is the one we are working on. So thank you all. This is all our students or fellows who have been a constant inspiration for us. And thanks to all. And thanks to Dr. Mubarak Khan and everyone over here and to Team Seocon for giving me the opportunity. Thank you so much. Any questions? No questions?
Okay. Thank you, ma'am. It has been a wonderful day today. All right, everyone, we have a karaoke night lined up. So before that, huh? And also we would like to call on stage LM Namdev sir, Dr. Sachin Nagre sir, Dr. MK Taneja sir. Please, sir, do the honors.
We have lucky draw at after the banquet, or rather before the banquet, in which 7 lucky people would be chosen, and the
Can I have the mic for a minute?
yes, sir, please.
Sure. Thank you. I thank the organizers, Dr. Mubarak, Dr. Sapna, for giving me an opportunity to be here and sharing this session. I started my journey and bought Andhra microscope in 1981. And for the last 30 years, I was holding temporal bone courses. And recently I felt, should we make a change that we should shift from microscope to otoscope, endoscope, and I was a bit confused till the people were doing with a single hand, holding the endoscope with the one hand and doing surgery. So I thought, okay, it's not my cup of tea and I cannot do it with one hand. And just touch maybe an answer and what I could see from the morning, yes, we must have a training course with 200 microscope, endoscope. Simultaneously, we should have both the things. Look, we have certain problems when we are dealing with microscope. We cannot approach attic. We can not do without doing canaloplasty. Sometimes it is very difficult, and I congratulate Dr. Sapna Parab, Dr. Mubarak for this wonderful conference, and it was an opportunity for me to upgrade myself. Thank you.
Congratulations, Dr. Khan, sir, and Dr. Sapna Parab, madam. And not only I congratulate to these, I congratulate complete ENT fraternity to for the that these innovations have made the ENT as a very precise and perfect branch, and these innovations have changed the complete scenario of the surgical procedures. And one thing which especially I want to say that since very long we are using microscope, and we may say that there was what was the need to bring these new procedures. So, and we used to say that tympanoplasty, there are only 70% results, there are only 80% results and 85. Today's patient does not want results. If there is surgery, results should be 100%. And endoscope provide we to work in each and every corner in the middle ear to remove the disease, so that the results are 100% and surgery is successful. So again, I congratulate Dr. Khan and Dr. Parab madam and all ENT faculty.
So we would like you to give. Sir, please, madam. Chairperson.
I call upon Dr. Bagibadi sir to give our chairpersons.
All right. So, as you all know, so here comes what we have been waiting for the whole day. It's time to party now. So we meet in about 40 minutes, 50 minutes. There's a karaoke night and then a banquet later on. So see you all. It's here only. Karaoke night is here only. Okay, waiting forward to see you all. Thank you. Yes, we have 2 prizes for karaoke. Sure. Two extra prizes by Dr. Sachin sir. Those who reach before 8 a.m. today. Tomorrow morning session has to be attended. Sachin sir will give them prizes.